Morning, everyone, and welcome to this meeting, which is the meeting of the Portfolio Committee on Health on the 10th of October. We have a lot of work we want to be able to achieve today. We're going to have a briefing by the Financial and Fiscal Commission on the analysis of the NDOH's annual report. We are going to have a briefing by the Auditor General of South Africa on the analysis of the health sector's annual reports. And then at 2 o'clock, we have a briefing by South African Health Products Regulatory Authority on the annual report. So we're planning to finish by 17:30 today. We will ask the FFC to complete theirs at 10:30, and then we will have the AG from then onwards. It is just before we do that, we also have new members on our platform. And we'd love to first, before I introduce them, get an idea of attendance from Ms. Majalamba, so that I am certain of where we are with regards to the members attending. And then I will give each and every member an opportunity to introduce him or herself. It's very nice to see some of you after a long time. Flengwa, I see you there on the picture. So it's going to be good to see all of you. Do switch on your videos or your cameras when you introduce yourselves, honorable members. And we will then, after that, welcome everybody else. So, Ms. Majalamba, over to you.
Good morning and thank you, Chair. Present is Dr. Jacobs, Ms. Geller, Dr. Harvard, Mr. Klaba, Dr. Notnahelm, Ms. Clark, Ms. Hicklin, Ms. Chirwa, Ms. Stengwa, Mr. Van Staden, and others.
Thank you very much. So I'm first going to allow introductions of ourselves, and then I'm going to read the rules of engagement for the day. And then we will, from there onwards, start introduce the members from the FFC and continue with our work. Be reminded that the department and the department is not necessarily invited to the FFC and the NDOH's presentations. If I don't introduce them, it's because of that reason, but we will be very happy if there are members of the department present listening to the presentations this morning. So let me start with the honorable members. Honorable Member Gela, you can start leading the introductions.
Thank you very much, Chairperson. My name is Honorable Anna Gela. I'm the member of the Portfolio Committee. Thank you, Chair.
Thank you. Let's go one by one, honorable members. Honorable Kaba.
Thank you, Chair. My name is Honorable Kawa, the member of the Portfolio Committee. I apologize about the video. It's not showing, though I have opened it, but I'm the active member here. Thank you, Chair.
Honorable Clark, I see you there.
Thank you, Chair, and good morning to all, and good morning to my colleagues. It's good to see you after a long time. Good to see you, Chair. My name is Michelle Clark. I'm a member of this committee. I'm a member of the Democratic Alliance and the Shadow Minister for Health for the Democratic Alliance. And while I have the floor, Chair, I would also just like to welcome our new member of the Democratic Alliance who replaces Member Wilson, and welcome to Member Madeleine Hicklin, who has an enormous amount of knowledge on health. So it will be good to have her on the portfolio. Thank you very much, Chairperson.
You might as well introduce yourself there. We see there the picture.
Thank you so much, Chair. Good morning, everybody. My name is Madeleine Hicklin. Thank you so much for that, Michelle. Yes, indeed, I have been active in the health sphere since 1984, when I started as a health educator writing the first AIDS awareness brochures in this country in 1984. I'm currently the copy editor of the Association for Perioperative Practitioners Journal. I'm also the copy editor on 8 nursing textbooks. I have quite an extensive background in the nursing arena, and I am very, very, very excited to be part of this really great committee. I look forward to working with everyone. Thank you so much.
Thank you, Honorables Harvard, Lamini, and Lydia.
Well, I will go, Chair. Seems like
Yes.
the connecting. It's I'm member Philip van Staden. I'm member for Freedom Front Plus and a member of this committee. Welcome to our committee, Member Hicklin.
Anyone, honorable members?
Thank you very much, Chair. Let me introduce myself. I'm Honorable Lydia Muruane. I'm a member of this portfolio committee from the African National Congress. Thank you so much.
Thank you.
Thank you very much, Chair.
Yes, continue, Mark Lengwa.
Thank you very much, Chair. Let me welcome first all the members and the new members. My name is Magdalena Tutuzile Hlengwa. I'm a member of this committee. I'm from IFP. Thank you.
Thank you. Honorable Kirwa, Honorable Tembukwaya, Honorable Supers.
Thank you, Chairperson. My camera is off because I'm in hospital now. But greetings to all the colleagues. I am Honorable Naledi Chirwa. I'm deployed by the Economic Freedom Fighters, and I'm also part of the portfolio committee as an alternative member. Thank you.
Thank you. We wish you well. If it's yourself who's not well, Honorable Chirwa. Honorable Tembukwaya, Honorable who else is here? Honorable Sukars, I see you there. Honorable Harvard, Honorable Lamini.
Good morning, Chair. Good morning to all my colleagues. Yes, my name is Mari Sukas. I am the ACDP representative on this committee. I'm an alternate member. Thank you.
Thank you. I think these are the members who will be introducing themselves. Welcome to those new members to this portfolio committee. It's a hard-working portfolio committee. We are usually ahead with the work which is set before us. We pride ourselves on that, and we have very good relationships with one another, and we try to keep it that way as we go forward towards the end of this term. So just to bring us back to what we will be doing today, honorable members, before I continue is to read the rules of engagement. And that is to inform you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sitting, the rules of the National Assembly apply, including the rules of debate. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in this virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons at the bar at the bottom of their screens, which has an option that allows a member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections, and also to be reminded that we do use the WhatsApp group of the Portfolio Committee on Health to indicate if you want to raise anything. So I will also be keeping an eye on that, but you're also welcome to raise preferably on this platform, because you do have the bar at the bottom of your screen, which assists you to be able to raise your hands when we get to the point where you would like to do that. So for now, honorable members, I'm just looking at whether I've gone through all of the rules. We've done introduction by the members. We have also said that we will receive now the presentation from the CE, which is led by Dr. Baba. Is there anything that I have left out? I don't think so. I just need to look at something here. So, yes, as I mentioned earlier, if there's anybody from the Department of Health, because I had picked up the name of Dr. Pillay, you're very welcome to this meeting also. Dr. Mbaba, are you present? Can you please introduce yourself and your team, and then lead us straight into the presentation? We're already running a bit late. We are 13 minutes past 9. We would see if we're able to finish within the time allocated to you. Thank you.
Thank you so much, Honorable Chairperson, Dr. Jacobs, and good morning to all the honorable members. My name is Dr. Patience Nombeko Mbava. I am the chairperson of the Financial and Fiscal Commission. It is a great pleasure to be here today as the commission. I am accompanied by commissioners who are on the platform and also by the research team from the Financial and Fiscal Commission. Chairperson, if I can ask for our slides to be flighted, which were sent. I will continue in the interim, Chairperson. The Financial and Fiscal Commission, to introduce ourselves, who is the Financial and Fiscal Commission? The Financial and Fiscal Commission is a constitutional body mandated through Chapter 220 of the Constitution. Our role as the Commission is to make recommendations as envisaged in Chapter 13 of the Constitution or in national legislation to Parliament, to comment on legislation to Parliament, provincial legislatures, and any other organs of state determined by such legislation. Our primary focus as the Financial and Fiscal Commission is to advise Parliament and provincial legislatures on the equitable division of nationally collected revenue amongst the three spheres of government. Should there be legislative provisions or executive decisions that affect either provincial or local government from a financial and fiscal perspective, the Financial and Fiscal Commission must be consulted. I'd like to pause, Chairperson, and just confirm if our presentation is flighted.
Sorry, Dr. Mbava, I lost my connection there, so I'm right back.
Thank you so much, Chair. Chair, I was confirming if our presentation will be flighted on your side.
Please. Yes. Did you get permission to co-host?
Can someone flight it for us, please? Thank you so much. Can you make it a presentation, please? Thank you so much. If you can move to the next slide. Thank you so much. Honorable members, our presentation today will essentially cover the role and function of the FFC, which I have already covered. And then we'll also bring a contextual analysis of our presentation. Then we will move on to do a proper analysis of the performance of the National Department of Health and its provincial departments in terms of their performance. And we'll look also at the entities of the department. I will then come in on the last slide to provide the concluding remarks. Next slide, please. Thank you so much. I have already covered this slide. The next slide. Thank you so much. On this slide, I want now to hand over to the researcher who is going to take us through the context and then the other researchers as well.
Thank you, Chairperson. Good morning, Chair of the committee and other honorable members and colleagues that are in the platform. I'll take you through the first part of the presentation, which is really about the context. So we thought it would be good to provide some contextual issues in order to preface the actual presentation. So I'll be going through those so that we can be able to set the scene for the presentation. So starting off by just acknowledging the fact that since 1994, South Africa's public health care system has improved. But what we've seen is that the COVID-19 pandemic has negatively impacted health outcomes, and therefore the system is under strain due to a number of factors that include a high disease burden, staff shortages, service backlogs, and a growing population that is without medical insurance. Secondly, we want to point out that in 2022, the vast majority of the population, estimated at 51.5 million South Africans, relied on the public health care system because they lacked medical aid. The number is expected to increase, thus further burdening a system that is already overwhelmed. So the point that we're making here is that investing in infrastructure to reduce backlogs, to increase capacity, and also to enhance service delivery is crucial in addressing this issue. What we also want to bring to the attention of the members is the fact that the fiscus has been under a lot of strain and therefore constrained for a long time now because expenditure has been growing at a much faster rate than government revenue, and that has resulted in a huge public debt. And in response to that, government has instituted a fiscal consolidation exercise that is aimed at reducing spending and managing debt. As a consequence to that, we see that the health budget, which includes also conditional grants that are a part of the sector's budget, is expected to decrease from 64.5 billion in 2022-23 to 60.1 billion in 23-24. We raise the fact that this decline in funding is very concerning to the Commission, primarily because it affects the quality of public healthcare, particularly if you consider the fact that there are existing backlogs and the impact of the COVID-19 pandemic. So what we've experienced and we've noticed in the past is that these budget cuts, in conjunction with other increasing costs, have resulted in limitations on medical personnel and reduced investment in healthcare infrastructure and maintenance. Next slide. So the graph on this slide, so this slide, we basically delving more on the fiscal consultation and its impact on the health budget. So the graph on the slide illustrates the growth of consolidated health spending, and that's represented by the orange bars, and the percentage of debt service cost related to health expenditure, which is represented by the blue line, and the percentage of health spending compared to overall expenditure, which is represented by the blue line. By the green line. So the period of the analysis spans 2019-20 to 2025-26. So as I've already explained, the fiscal consolidation was about the debt that has been rising, resulting from a higher expenditure in relation to government revenue. So as honorable members will be aware, the higher the debt that you accumulate, the higher the costs that are associated with that debt in terms of the interest that you pay on that debt. So we were making the point that debt service costs have been rising, resulting in less money that is now available for crucial social services such as healthcare. On the other hand, what we've seen is that the health spending has been decreasing and is forecasted to continue to decline as the fiscal consolidation exercise continues to be implemented. So the numbers on the graph they tell us that initially there was an increase in the health budget, and that was in response to the COVID-19 pandemic. However, we see that the increase has since been reversed, and the budget is projected to temporarily experience negative growth before eventually improving in the last in the last 2 outer years of the MTEF period. Next slide. So in this slide, what we're doing, we are comparing South Africa's healthcare expenditure with that of other countries, particularly looking at advanced economies. So what we want to really to understand is that is South Africa getting the rate of return in terms of the investments that are being done with regards to health spending. So the graph reveals that South Africa spends a similar portion of its GDP on healthcare when you compare it with advanced economies such as Canada and the UK. But when you compare South Africa with other developing countries, we see that South Africa's healthcare expenditure is above average when it compares with other developing economies. So the most important thing to note is that despite this level of spending, which is high by international standard, there is a weak correlation between healthcare service spending and health outcomes in South Africa. And this suggests that in as much as we are increasing healthcare spending, this is not translating necessarily to improve health outcomes. Additionally, we're making the point that healthcare spending and delivery in South Africa are significantly unequal. This is due to the fact that there is a separating equilibrium of the healthcare system and its financing, which basically means that quality healthcare is not evenly distributed among the population. Next slide. So moving on to the next slide, and what this slide is showing us is the inequality in health spending. So we see that according to Statistics South Africa, in 2021, the estimated HIV prevalence rate in the country was around 13.7, translating to approximately 8.2 million people. The high infection rate has significant financial implication, particularly concerning providing those affected with antiviral drugs. Perhaps the most important point is the fact that the healthcare system in South Africa exhibits a significant disparity in resources, thus necessitating the need for accelerated health reform, such as the implementation of the National Health Insurance, which we will elaborate on later in the slides. But we just want to say currently the private sector, which has more resources, caters for about 15 to 16% of the population, which is just a quarter, while the remainder, which is about 3/4, relies on the public sector, which has fewer resources. And this, in our view, is a very critical matter. And in this regard, the Commission is conducting research on this particular topic, and we will be presenting it as part of our annual submission in May next year to Parliament. Next slide. So this slide is mainly on the historical trends in health spending and health outcomes in South Africa. And the graph on this slide illustrates the under-5 mortality rates and government health expenditure per capita in South Africa. And the period that we've been over which the analysis is taking place is between 2002 and 2020. So the first point we're making here is that South Africa has significantly reduced the under-5 mortality by 55%, and this is a reflection of an overall improvement in health outcomes. However, the rate remains higher than economically developed countries within similar profiles. Secondly, we are saying that there is a correlation between increased health spending and better health outcomes in this particular aspect. It's important to note that factors such as the introduction of antiretroviral drugs have also played a significant role in the decline of under-5 mortality. So the coverage of ARSV for people living with HIV has increased substantially from 3% in 2005 to 73% in 2020, highlighting the positive impact of increased access to treatment on health outcomes. Although there has been an increase in life expectancy in South Africa, which has risen from 56 years in 2000 to 65 years in 2020, it still falls below the average of other countries with similar economic development. Next slide. So on this slide, we're looking at fiscal consolidation in the context of increasing pressure on public healthcare. So the slide presents a graph that illustrates the proportion of death caused by communicable and non-communicable diseases, and we're looking at the period between 2002 and 2018. So the graph tells us that deaths from communicable diseases, maternal causes, and nutritional conditions have decreased since 2005, thus reflecting an improvement in overall health. However, the number of deaths caused by non-communicable diseases such as cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases has increased. So this trend is putting a strain on the healthcare system. And additionally, we're acknowledging the fact that approximately 10.1 million South Africans are affected by chronic health conditions. Therefore, with that context in mind, we're saying that the health sector budget cuts are a concern because they lead to reduced resources and limited capacity to meet the growing healthcare demands. Next slide. So this slide is really about the burden of diseases. So the graph displays the prevalence of various diseases among the population it reveals a significant burden of both communicable diseases, which spread from person to person, and non-communicable diseases that are typically caused by lifestyle factors or genetic predisposition. The emphasis is on the need for specific focused prevention and intervention programs to address these diseases. Next slide. So we continue on this slide. About on our analysis on the burden of diseases. So this graph depicts the number of individuals diagnosed with cancer categorized by gender, and the period is between 2008 and 2019. So we see that cancer is the second leading cause of death globally, following cardiovascular diseases, and it was responsible for over 10 million deaths globally in 2029. So the graph demonstrates in the South African context a consistent rise in the incidence of cancer. Next slide. So in this slide, we deal with an issue that we think is important also when you look at the health sector. It's about the medical legal claims. So this graph depicts the payments made for medical legal claims, and we're looking at the period between 2012, 2013 to 2020 and 2021. So what is apparent from the graph is that there has been a significant increase in this payment. The increase, we see that it has been from 265 million in 2012-2013 to nearly 2 billion in 2018-19. So this is a really significant increase in these claims. And the reason why we think it's important is because these claims represent some kind of a leakage from the budget at a time when the fiscal is constrained, and we have to do more with less. So we see that medical legal claims payments make up approximately 1% of the total health expenditure during the period from 2018-19 to 2021, with the Eastern Cape having the highest share at around 3%. Since 2018-19, the contingent liabilities have exceeded 50% of the provincial healthcare budget. Again, we think this is a key issue that needs further analysis and understanding. And in that regard, therefore, the Commission is currently conducting a research project on these medical legal claims. And again, it will form part of our annual submission that we'll be submitting to Parliament May next year. Next slide. So when you talk health in South Africa, you can't finish the conversation without talking about the NHI, because it's a topical issue and it's an intervention that is expected to really turn the sector around. So we just here presenting our reflections on the NHI. So we start off by making the point that the NHI is a proposed universal healthcare system in South Africa. Its primary objective is to address the healthcare disparities that exist among the different population groups in the country. The aim is to provide equitable access to quality healthcare services for all citizens, regardless of their income or where they live. So by ensuring that the essential healthcare services are accessible to everyone, the NHI seeks to improve health outcomes and reduce health inequalities. So implementing the NHI will require significant investment in healthcare infrastructure, human resources, and technology. This investment could potentially strengthen the overall health system in the country. It may involve the construction of new health facilities, the recruitment and training of additional healthcare professionals, and the implementation of improved health information system. These efforts will contribute to enhancing healthcare services and delivery across the country. But then one of the main obstacles in implementing the NHI, of course, is the issue of funding. The point that we're making here is that the NHI will require substantial financial resources in order for it to support universal healthcare coverage. So the government needs to find sustainable financing mechanisms to ensure its long-term viability. And this may involve exploring alternative sources of revenue, such as increased taxation or contributions from employers and employees. So, and then lastly, we want to make the point that implementing a universal healthcare system like the NHI is a complex undertaking, and therefore it requires careful planning, coordination, and involvement of various stakeholders, including healthcare providers, government agencies, and the public. So addressing potential logistical and administrative challenges during the implementation of NHI becomes very, very important. And we're saying it should be recognized that the successful implementation of NHI and the resolution of these challenges may require a considerable amount of time. So it might not be something that is a sprint, but it might come up as a marathon. So Chairperson, thank you. And with your permission, may I now hand over to my colleague who's going to continue with the second part of the presentation. Thank you.
Thank you, Chairperson. I'll take over from Tando, and good morning to you, Chairperson, and the honorable members. My name is Sianda Jonas, and I'm part of the research team. And I think as a way of starting, we all know that the health vote mainly focuses on preventing and treating communicable and non-communicable diseases. It also focuses on overseeing primary healthcare services and also strengthening the health system. And in terms of the budget allocation of the vote, it is divided among 6 programs, which is administration, national health insurance, communicable and non-communicable diseases, primary health care hospital systems, and the last one is health system governance. And when you look at the total allocation, you see that in terms of conditional grants in the vote, the conditional grants account for about 89.2% or 169 billion of the department's budget over the MTF period. And you see that this is an increase from the 86.7% or 166.6 billion over the 2022 MTF. But included in under the Department of Health vote a number of public entities which are also funded, which are funded through a combination of transfer payments or own revenue. Next slide. So in this slide, we look at the departmental budget analysis, and what we see that the total departmental budget for 2022/2023 financial year is 64.5 billion in the adjusted appropriation. But we see that this represents a decline from the 65.1 billion, which was allocated in the 2021/2022 financial year. And overall, we see that the department receives an allocation of 60.1 billion in the 2023/24 financial year, which also represents a decline. But when we look in terms of the average growth, we see that the total average growth rate between the 2029/20 financial year to the 2022/23 financial year, the average growth rate increases by 8.3. And when we look at the same over the MTF period, we see that it is expected to increase by 0.4, which is a minimal increase. But we note that despite these nominal increases or nominal average increases, the department may face budget cuts in the upcoming MTPPS, given the fiscal constraints that Tando spoke about earlier, that are faced by the country. And we say there is a need for a clear indication of how the department plans to absorb these cuts, given the increase in the burden of diseases, as Tando has already alluded to. Next slide. In this slide, we continue with the departmental budget analysis. What we see here is that the communicable and non-communicable disease program accounts for the largest share of the department's budget. It's at 41%, which is roughly about 24.6 billion. And this is followed by the hospital systems at 37.6%, which is about 22.5 billion in the 2023-24 financial year. When we look over the MTF period, the primary health care program records a decline in its average growth rate of by a negative 14%, while the average allocation for the communicable and non-communicable diseases program will not increase. And we say here that it is important to note that the public health sector is very sensitive to budgetary cuts and was already under pressure from growing burden of diseases, and the department will have to develop plans to deal with the cuts. So we're emphasizing the need to develop those plans to ensure that these cuts are absorbed. Next slide, sorry. Yeah, and then in terms of this slide, in this slide, we are looking at expenditure by economic classification. And what we see here is that compensation of employees is expected to decline by an average of negative 2.9% over the MTF period. And we also see that goods and services are also expected to decline by an average of 8.9% over the same period, which is the MTF period. We also see here that transfers and subsidies are also expected to increase by 1.5% over the MTPF. And this is largely driven by transfers to non-profit organizations at 3.1% and departmental agencies and accounts, which also accounts for an increase of 2.7%. Next slide. In this slide, we look at the personnel head count and cost. And what we see that the number of posts across all salary scales is declining over the MTF period. And we note that it is essential to balance the reduction of the number of personnel with service delivery needs. And this should not result in a retrogression of services that are supposed to be delivered to our communities. And what we also see here is that the total number of posts declines from 1,281 in 22-23 to about 1,046 in 2023-24. And we note that this may result in structural weaknesses in the department's operational and administrative consistencies, capacities, and capabilities, which may result which may in turn affect service delivery. We also see here that the total cost for all salary levels decreases from 881 million in the 2023 to about 682.1 million in 2023, and the decrease in the cost, in the total cost for all salary levels, as already alluded to, may hinder the expansion of healthcare services, result in poor health outcomes. Next slide. And then in this slide, we look at spending performance by program, and we see that most programs showed an improvement in in spending performance. However, due to a decline in spending performance for communicable and non-communicable diseases and hospital systems, overall spending at the same time is expected to deteriorate from 98.8% to about 97.4%, but it remains above average or in the 90s point. Next slide. In the next few slides, Chairperson, we look at the performance, some performance indicators and the planned targets. But I will not go through, because it is quite a couple of slides, so I will not go through each indicator of the selected slides that we have of the selected indicators. I will just go through some of the indicators. So what we see here is that in terms of the financial management strengthened outcome, The planned target was an unqualified audit for the 2021-22 financial year, but there was a deviation as the department achieved a qualified audit. And the reason for this is that there are inadequate internal control systems which related to the COVID-19 vaccine program. So there is a need to improve when it comes to that aspect of internal controls. And then we see also here that in terms of the management of medical legal cases outcome, the planned target was the development of legislature to manage medical legal claims. And what we see is that here again, the legislation is not yet developed. And the reason for the deviation is that the South African Law Reform Commission is finalizing the discussion paper to inform the legislation. And we say it is important to ensure that that is finalized to assist in managing these cases and achieving this outcome that the department has. Next slide. And then here, again, here we look at the program performance and we look at the indicators. Again here, if we look in terms of a package of services available to the population that is expanded based on cost effectiveness and equity, if we look at that outcome as planned by the department, we see that the planned target is that 70% of the funded post in the NHI organogram be filled. And we see that here, again, the department has achieved this. This was achieved as 80% of the total post in the NHI organogram we filled. And we see that here, at least there is progress in terms of that outcome. Next slide. And then here, again, here we continue with that and looking at, again, in terms of the outcomes, we see that in terms of the outcome that relates to HIV incidents among the youth, the department had an outcome that HIV incidents among the youth be reduced, and the planned target here was that about 2,000, achieving 2,000, the incidents are reduced in the range of 2,000, and the actual achievement was around 1,845 a number that was reduced in terms of incidences. And here we see that KZN, Western Cape and Northern Cape did not reach their targets, which also reflects the fact that the health function is a concurrent function and it needs that cooperation between national government and the provincial government. We also here see again that in terms of the progressive improvement in total life expectancy of South Africa, the target was that 221,900,000 was the target, the planned target, and the achievement was around 189,790,000. And the reason for the deviation here again is around the weak community outreach systems, which we think there is a need to collaborate with communities and NGOs within the sector to try and strengthen those community outreach systems. Next slide. And then here, in terms of this slide, again here, Chair, we continue with looking at some of the outcomes and the planned target and the achievement of those targets. And here we see that in terms of premature mortality due to NCDs, the expectation or the outcome was that it should be reduced to 26%. And the planned target was that a national mental health framework be tabled. And we see that we're happy to announce that the department achieved that outcome. And then also in terms of the quality and safety of care improved, the target was that an additional 100 hospitals, including 7 tertiary hospitals, is achieved. And we see in terms of the actual achievement, additional 84 hospitals were achieved, or were then that was the achievement, the actual achievement that the department achieved, and there was a deviation of 6%. And we see that part of the reasons that the department gives is that facilities that did not obtain 75% and above on the food service policy assessment had budget challenges and lacked appropriate infrastructure. Again, here, touching on the issue of the budget and the lack of appropriate infrastructure. And as already highlighted, that there is that anticipation that the department might face further cuts and the department would need to develop plans to address how they will absorb those further cuts. Next slide here. And then here, when we look in terms of the outcome which relates to community participation promoted to ensure health system responsiveness and effective management for their health needs, the planned target was 2,700 and the actual achievement was 2,630. And there was a deviation here again of 70. And part of the reasons that the department puts forward is that due to the deviation was due to high turnover of community health workers in favor of formalized paid work. And I think this is one of the challenges that the department will continue to face as many health workers migrate into formalized paid work. But there is a need to ensure that there are systems in place which are put in place to deal with that type of migration. And then again here, when we look at the outcome that relates to environmental health strengthened by contributing to improved quality of water, sanitation and waste management and food services, the planned target was that 26 metro and district municipalities are assessed for compliance with the national health system and the target here was exceeded, which it points out to a lot of compliance around or a compliance by these metro municipalities. Next slide. We continue here again with the looking at the outcomes and the achievement and planned targets by the department. And we see here again, in terms of the outcome relating to financing and delivery of infrastructure projects improved, the planned target was 40 facilities constructed or revitalized, and this was exceeded. And this also touches on an earlier point that we made around infrastructure projects to ensure that there is an expansion of services towards communities. Again, for the same outcome, we see that the planned target of 120 public health facilities maintained, repaired, or refurbished. And again, this was exceeded. So we see that in terms of these outcomes, the department is doing relatively well, and we want to encourage the continued performance when it comes to these outcomes. Next slide, Chair. And then in terms of the next slide, we look at the outcome relating to quality and safety of care improved. And the planned target was for 9 nursing college supported, to develop training plans for nurses and midwives. And we see that, and specialist, midwife specialist. And we see that again here, the department has achieved, there was actually no deviation insofar as this. Next slide. And then here, Chair, we look at conditional grants and looking both at direct and indirect conditional grants. And what we see here, when we look at the highlighted column in gray, we see that in terms of the total direct conditional grant, a total of 54.1 billion is indirect conditional grants is allocated. And we see that about 2 million is allocated in terms of indirect transfers in the 23-24 financial year. And we see that in terms of the following financial year, the 2024/25 financial year, we see that there is actually an increase in those grants. But I think we need to be cautious, as we have seen that this might be changed given the fiscal constraints that we face as a country, and these numbers might reflect actually downward revisions. And as already highlighted, that the department will have to develop plans and strategies to absorb those cuts going forward. Next slide. And here, we again continuing with grants, we look at conditional grant performance, and we see that the overall performance of the health conditional grants shows that spending is above 95% of total expenditure when it relates to grants or the different grants as they are shown in the graph. And we see that the district health program grant shows underspending of 5.4%, and this is due to delayed rollout of the HPV vaccine due to prioritization of measles vaccines, TB outreach affected by weak community outreach systems and poor data capturing. And this also relates to the weak community outreach systems that we touched on earlier as we're speaking about some of the outcomes that the department sets itself to achieve. Next slide. And then in this slide, we look at the proportion of total provincial revenue allocated by provincial health department. And we see that we already know that provinces allocate the bulk of their resources to education. It's about 41.3% that goes to at the education function. And this is followed by the health function at 34.2%, and also public works, roads and infrastructure at 9.7%. And then the other then goes to local government and housing at 5.1%. So we see that the health function is the second, it gets the second largest share of the provincial allocation. Whereas the proportion allocated to provincial health increased from 33.6% in 2019-20 financial year to 35.8 in the 2021-22 financial year due to COVID, to the COVID pandemic. Over the recent period, the provincial share allocation allocated to health is projected to remain relatively stable around 34%. And this again, with the fear of overemphasizing, relates to the cuts that might be faced or the expenditure moderation that we might face as as health, and the need to factor those in. So next slide. In this slide, we look at allocation and growth in provincial health budgets. And what we see here is again that we make the point that we see that provincial health budgets are under strain, and we see that between 2022/23 and 2023/24 financial years, allocation to provincial health budgets have either declined or increased marginally under 1%. And what we see there, we see that in that highlighted column, which it shows that, for instance, for the Eastern Cape, there is a decline of 0.3%. And then as you look, one of the largest declines is Northern Cape, Northern Cape, at 7.4%. And then we also see that provinces such as KwaZulu-Natal decreased by 3.7%. So again here, the emphasis is around the decline of the health budget, both at a national level and also with provinces in terms of their growth rates. So there's a need again here to emphasize those plans. Next slide. Here, Chair, we just highlight the pressure on the health sector, again in line with the consistent message that we're trying to communicate, that we know that health is a concurrent function with implementation driven by provinces, and we see that wide-ranging cuts amongst other things under the central hospital services, provincial hospital services, and district health services. There are those wide-ranging cuts that are there, which are of concern to us. And we say here the impact of this reduction on service delivery must be understood, especially in the context of continued strained fiscal conditions. So again here, Chair, we highlight that there are these cuts, and these cuts are of concern, particularly with the idea of expanding healthcare services to those that need it the most. And there are these upcoming cuts or cuts which are going to continue, and there is a need for the department to develop plans to factor in these cuts or understand their impact and what impact they will have on service delivery. Next slide, please. Here, Chair, I will hand over to my colleague Neo, who will take us through the entities before handing again to the Chairperson for concluding remarks. Thank you, Chairperson. Over to you now.
Oh, thank you very much, Sianda. Good morning, honorable members, and good morning, Chair. So I'll continue with the presentation, the third part of the presentation. So on the third part of the presentation, we speak to entities within the health sector and also analyzing funding and expenditure frameworks thereof. So these entities comprises of the National Health Laboratory Services, the South African Medical Research Council, Compensation Commission for Occupational Diseases in Mines and Works, the Council for Medical Schemes, Office of Health Standards, Standard Compliance, and finally the South African Health Products Regulatory Authority. So next slide. So firstly, with regards to the National Health Laboratory Services, we see that the entity was established in terms of the National Health Laboratory Service Act of 2000 with the primary mandate of providing pathology services and also playing a significant role in monitoring TB and HIV. From the projected direction of total spending, we see a notable increase with an average annual growth rate of 9.6%, reaching an amount of 15.3 billion by the 2025-26 reporting period, from an initial value of 11.6 billion from the 2022-23 reporting period. Furthermore, a significant 73.8% will be allocated to the laboratory test during the medium-term period. Consequently, an expenditure of these tests is anticipated to rise at an average annual rate of 11.1%. So as part of the financial sustainability strategy, we also see that the National Institute for Occupational Health anticipates deriving 92.4% of its revenue during the medium-term period from fees charged for laboratory tests. And additionally, we see also a 5.6% of its revenue that will be, 5.6% of its revenue will also be obtained through transfers from the department. The funding for laboratory tests is primarily sourced from the fees levied on these tests, with the projected revenue at an average annual growth rate of 10.1%, increasing from 10.7 billion in 2022-23 reporting period to 14.3 billion in 2025-26 reporting periods, in accordance with the expected rise in test volumes. In terms of service delivery, from a service delivery perspective, we see that the maintenance of communicable disease surveillance programs retains a paramount significance in delivering comprehensive surveillance and guidance pertaining to diverse communicable diseases. And this is with an allocation with an allocation of a yearly growth rate of 5.1%, increasing from 459.9 million in the fiscal year 2021-22 to 534.1 million in the 2024-25 fiscal year. Next slide, please. In terms of the South African Medical Research Council, we see that the council conducts research or conduct and funds health research and medical innovation in terms of the amended South African Medical Research Council Act of 1991. The entity further conducts research regarding that. The focus of the research is on the deployment and procurement of vaccines. During the MTEF period, the council aims to accept or publish approximately 1.9 scholar articles, books, book chapters authored by individuals affiliated or funded by the council. This also constitutes an estimated 52.1 billion, which makes up 50.2% of the council's budget over the MTEF. So we also see that approximately 1 billion, making up 24.8% of the council expenditure over the MTEF, is expected to be allocated to innovation and technology initiatives aimed at enhancing public health. This is critical in terms of enhancing capacity of low-income and also middle-income countries to provide mRNA vaccines, providing also scholarships. From an expenditure framework, we see that the total expenditure is also projected to experience a growth of 0.7% annually, increasing from 1.4 billion in 2022-23 reporting period, and also to 1.5 billion in 2025-26 reporting period. The decline in expenditure during the 2023-24 can be attributed to one-time allocations for COVID-19 vaccine research in the fiscal year 2021/22 and 2022-23. Finally, we also perceive that there will be a projected surplus of 25.9 million in the 2023-24 reporting period. Next slide. In terms of the Compensation Commission for Occupational Diseases in Mines and Works, we see that the Occupational Diseases in Mines and Works Act of 1973 mandates the commissioner to collect levies from controlled mines and compensate lost earnings caused by occupational diseases of cardiorespiratory organs. So during the medium term period, the fund will emphasize augmenting the number of benefit payment dispersed with a projected increase of 7,600 in 2022-23 to 8,600 in 2025-26 period. We see that the fund also aims to augment the number of certifications finalized from 13,200 to 15,000 over the same period. Beneficiary payments are anticipated to experience an increase from 449.8 million in the 2022-23 reporting period to 543.3 million in 2025-26 reporting period. This growth is primarily attributed to an unwinding adjustment on the provision for outstanding claims liability, which is projected to rise from 312.2 million in 2022-23 to 396.5 million in 2025-26 reporting period. Over the medium term, the fund anticipates that an amount equivalent to 1.2 billion, which makes up 74.4% of its revenue, will be derived from interest earned on investment, and at the same time, the remaining 399.9 million, making up 25.6%, will be obtained through levies imposed on controlled mines and works. The revenue is predicted to experience an average annual growth rate of 7.8%, rising from 433.1 million to 542.3 million in 2025-26 period. Next slide, please. So in terms of the Council for Medical Schemes, the Council for Medical Schemes is a regulatory authority for overseeing the medical schemes in the industry. So this is set out in Section 7 of the Medical Schemes Act of 1998, further with the mandate to protect the interest of beneficiaries in line with the provision of National Health Act of 2003. It must also be noted that the Council for Medical Schemes also has an advisory role to the Minister of Health on related matters. The Council of Medical Schemes assumes a vital role in supporting the department and facilitating coordinated efforts on the medical schemes industry to achieve universal health coverage. So we see that in terms of expenditure, we see that the projected total expenditure demonstrates an average annual growth rate of 4.7%, projected to rise from 193.4 million in 2022-23 reporting period to 221.9 million in 2025-26 reporting period. The Council is expected to generate approximately an equivalent amount of 616.4 million, which makes up 95.2% of its revenue over the medium term by collecting levies imposed on medical schemes. An additional estimated 20.4 million, making up 3.2% of the revenue, is projected to be derived from transfers received from the department. Revenue is also expected to follow an upward trajectory in alignment with expenditure patterns. The projected surplus declines from 2.5 million in 2023-24 to 1.4 million in 2025-26. Next slide, please. Now, in this slide, we look at the Office of Health Standard Compliance. We see that this entity is established in terms of the National Health Amendment Act of 2013 to monitor and enforce the compliance of health establishment compliance with the norms and standards. Furthermore, we see that this was also established to enhance the caliber of health provision. The office is anticipated to increase the number of health establishments subject to inspection and certification of adherence to established norms and standards. In terms of the expenditure framework, we see that the proportion of health facilities subject to inspection is projected to rise from 14.5% in the fiscal year 2021-22 to 18.4% in 25-26 period. The expansion is facilitated by additional budgetary allocations of 10 million in 2023-24. 12 million in 2024-25 and 15 million in 2025-26. The majority of this funding is allocated to compliance inspectorate program, which undertakes the majority of the office activities and accounts for an estimated 35.7%, which is equivalent to 182.1 million of its total estimated expenditure over the medium term period. Expenditure is also projected to experience an average annual growth rate of 4.9%, increasing from 157.5 million in the 2022-23 reporting period to 181.7 million in the 2025-26 reporting period. The office revenue is derived entirely from transfers made by the department, which are projected to a total of 516.1 million over the medium term. Next slide, please. In this slide, we look at the South African Health Product Regulatory Authority, and we see that this entity is established in terms of the National Health Act of 2003 and the Medicines Related Substance Act of 1965. We see that this entity governs the manufacturing, distribution, sale, and marketing of medicines and medical devices to promote health, well-being, and safety of the public, ensuring access to safe, effective, and quality health products. It is also noted that there is substantial decline in percentage of new licenses finalized yearly related to good manufacturing practices and wholesaling practices from 77% in 2019-2020 reporting period to 42% in the 2021-22 reporting period. The primary function encompassing the assessment of drug safety, quality, and therapeutic effectiveness, as well as the process of registering medications, are anticipated to constitute 31%, which is equivalent to 392.4 million of the authority's expenditure during the medium-term period. Therefore, it is noted that to enhance operational efficiency and facilitate the expeditious expansion of medication accessibility by streamlining the timelines for scientific evaluations and clinical trials, the authority intends to enhance the skills of personnel through talent management initiatives and the recruitment of experts in essential domains. Consequently, the number of personnel is projected to rise from 292 individuals in 2022-23 to 331 individuals in 2023-24, and for the duration of the MTEF period. On the expenditure framework, we see that the overall revenue and expenditure are anticipated to experience an average annual growth rate of 7%, increasing from 349.4 million in the 2022-23 reporting period to 428.4 million in the 2025-26 reporting period. And also over the medium-term period, we see that the authority foresees that 696.8 million, making up 54.9% of its revenue, will be derived from fees levied for the provision of its services, while 478.5 million, making up 40.1%, will be obtained through transfers from the department. Next slide, please. So I'll hand over to our chairperson for the concluding remarks. Thank you, Chairperson.
Thank you so much, Neo. Honorable members, as we conclude, these are the key takeaway from our presentation this morning. What we found as a commission is that South Africa has shown progress on a number of health indicators, as witnessed by the increase in life expectancy and a decline in infant mortality. Secondly, public health care is under pressure due to heavy disease burden and increased demand, together with budgetary cuts, which place the healthcare expenditure under increasing pressure. Thirdly, we have found as a commission that despite relatively high expenditure as measured by percentage of GDP spending on healthcare, this expenditure does not always translate into desired health outcomes, and South Africa continues to perform below the average for other upper middle income countries. There are a number of health reforms, such as the NHI, which aims to enhance the efficacy and efficiency of healthcare. However, major issues pertaining to funding and implementation thereof need to be resolved. We also found that the increased expenditure on settling medical legal claims diverts scarce resources away from service delivery. South Africa is experiencing a growth in the burden of disease. Furthermore, the department has shown an underperformance against a number of set targets in the communicable and non-communicable program. Therefore, we believe that greater focus is needed to improve the spending performance against a number of conditional grants, in particular the District Health Program grant. Finally, we have found that there is significant underperformance of the Compensation Commissioner for Occupational Disease in Mines and Works, which results in the non-payment of eligible beneficiaries, which necessitates an intervention to assist eligible beneficiaries in accessing payments. That concludes our presentations to the committee. Over to you, Chairperson.
Thank you very much, Dr. Mbaba and the team. We are very grateful for the emphasis that you have put on the fiscus and the importance of the fiscus for service delivery in the healthcare sector. I get a sense that you have made a great effort to emphasize that budget allocation and budget spending and services to the people go hand in hand, that the one is dependent on the other, and that there should be awareness by the portfolio committee of this and an interrogation of this by the portfolio committee. So, having said that, I'm going to look at hands from the members of the portfolio committee. As Honorable Clark was first, Van Staden second, Lengwa third, Haba fourth, Hickland fifth, North Nagel, Tembakwayo, Yela, and then of course myself in the end. So I'm going to repeat. It's Clark, Van Staden, Lengwa, Haba, Hickland, North Nagel, Tembakwayo, Yela, Havat, and then myself. Honorable members, I had deliberately chosen to have a shorter presentation from the FFC comparative to what we normally do. And we started a bit late also. We didn't start late, but we took a lot of time because we had new members to introduce. But there's important work that I think we need to get from the AG on the sectors which we tend to cut a bit shorter generally because of the time that's allocated. So I'm going to ask you to be to the point, and so we can go through this, put your questions, get the answers, and then we move on to the AG after that. Not that this work is not important. Thank you. In that order, honorable members.
Thank you, Chairperson. My first question is, how does the FFC foresee the fiscal consolidation measures impacting on government's NHI plans, given that given that we still don't know exactly how it will be financed or how much it will cost, and keeping in mind that the finance minister has repeatedly said it's unaffordable? How will the reduction of personnel be balanced with the service delivery needs given the severe strain already experienced by the public health system? When will hospitals start to run out of money, and what plans are in place to prevent such catastrophically? What's the suggested consequence management for underperforming or poor performing entities, given that many of them are not showing signs of improvement? What is the role of the FFC? What role do they play if it is found that budget allocations cannot support what is expected of service delivery within our hospitals? During COVID, there was an extra budget put in place for healthcare during 2020, and that obviously was taken away after COVID. And what are the chances that that extra budget that was in place during that period of time can be allocated back to health facilities? Because I think that would make a big difference. And what consequences would be taken against vaccines that had expired and that were sold at a premium rate to us in South Africa instead of what was sold at the rate to European countries? Fiscal consolidation is cutting out wastage, dealing with medico-legal claims, which we've been told today again is up to 2 billion. And of course, many of those medical legal claims are surrounded by fraud and corruption with medical staff, doctors, and lawyers that collude with each other. And when we had the Presidential Health Compact, we spoke to some of the advocates that were involved, and I'm looking forward to a presentation from them because they were going to come to the committee to give us their plans how to reduce medical legal claims, because not just that, you know, your accruals is also deducted off your budget before you can even function. And then I think there's a very urgent case to look at the money that we get in from government tax in terms of sugar tax, which should all be used towards diabetes, obesity, and that is definitely not happening. And, you know, we speak about having to improve our hospitals and build more hospitals, but Chair, you yourself know that we've seen on our oversight visits how many facilities at hospitals are just standing and not being utilized. So, you know, I can't understand why those facilities are not improved instead of building lots and lots of new hospitals. We spoke about that at length at our oversight. When I just take the Kempton Park Hospital that was built at a cost of millions of rands and never utilized. So, I mean, what are we going to do in terms of those issues? And then I also want to raise that the OHC, who does very good work, but is unbelievably understaffed, and will never be able to do the inspections they need to do to ensure that our hospitals actually comply to the ideal clinics program that the NHI says they should do. So, you know, in my view, we must fix our systems, fix our hospitals first before we can even think of implementing the NHI. You implement the NHI at a massive cost, but you still sit with you know, inadequate facilities. Thank you.
Thank you, Chairperson. My questions will be straightforward, and I hope that the Financial Fiscal Commission can give me answers on this. I just want to know what the numbers they're having in the current shortages of doctors and nurses. So what is the current number they have on the vacant posts for clinical and non-clinical staff? My third question is, what is the number they have in the current backlog in medical procedures? My fourth question is, what is the amount for medical legal claims for this current financial year? The 125 billion you reported this morning was also reported by the Auditor General to this committee in October last year. So I just want clarity on that number, please. Then on slide 27, you spoke about 21 hospitals that was constructed or revitalized. Can you provide a list of these facilities to this committee, as well as a list of the 157 public health facilities that was maintained, repaired, or refurbished? Is there a report available regarding the shortages of medical equipment in hospitals and clinics? If so, can you please provide it to this committee? On slide 39, I just want to know what is the number of facilities that was inspected by the OHSC during this financial year on the public and the private sector, if you have that number available for us. And lastly, Chair, on slide 41, regarding the NHI funding and the implementation issues, can this be expanded upon to us, please? Thank you very much.
Thank you very much, Honorable Chair. And also, thank you very much for the comprehensive report. My question is that, considering the forensic chemistry laboratory struggled to keep up with the growing backlog of the toxicology cases earlier this year, how has your agreement to allocate additional resources to speed up its work affected the budgetary allocation? Thank you.
Thank you, Chair. Yes, thank you, Chair. Chair, just to indicate, Chair, I think let me welcome the presentation indeed as it is done. It's so organized. But Chair, just my question will be, as follows. Which healthcare goods and services are mainly constrained by the budget cuts? Isn't the reduction of compensation negating the need for more healthcare workers? And will the decline of goods and services impact quality healthcare provision? Just want to understand that. But lastly, Chair, in relation to tracing patients and linking them to treatment, what is the robustness of our preventative healthcare programs and how are they supported in the budget?
Your Honorable Heatland, I'm going to repeat now. It's Heatland, North Narvel, Tembakwayo, Gela, Harvard.
On NHI here. NHI,
thank you so much, Chair.
Yeah, that is going to be implemented. Thank you, Chair.
Honorable Kawa, you can repeat that. I didn't hear you speaking, so I spoke in between. Did you have another question?
I'm happy to repeat. I don't know if Chair, have you captured my questions?
Your last question. Just only your last question, please.
No, my last questions were comments to say, Chair, the NHI, it's a non-negotiable matter. It's going to be implemented. So Honorable Clerk maybe is mistaken to be worried about the implementation of the NHI. We are not discussing that yet.
Thank you, Honorable Speaker.
Thank you so much, Chair, and thank you for the presentation. My questions are largely covered by Honourable Clark and Honourable van Staden, but I would like to just make these points. The improvement in the facilities that were mentioned, I would like to know, we are anticipating a staff growth that is mandatory, but the budget is being reduced. And yet we have doctors and nurses sitting at home. Where is the improvement of the facilities going to be facilitated? How is it going to be facilitated if we don't have enough staff to run these improved facilities? And where exactly are these improved facilities? Why do we not use, Honourable Clark mentioned the Kempton Park Hospital. There is also another one in Edenvale that hasn't been fully restored, but there are a number of facilities that can be restored or resurrected, so to speak, instead of rebuilding or building hospitals at enormous costs. I'd like to know, in terms of drugs and equipment in private and public health facilities, what shortages exist and how are they going to be covered, particularly in the public health facilities with regards to the treatment of communicable and non-communicable diseases. Again, with the decrease of the budget, around about 7.6% in the district health program, how is this going to affect service delivery and which programs are going to be the most affected? In terms of the primary healthcare, from a primary healthcare perspective, we need to be very, very careful about cutting budgets that affect the most challenged parts of our population who are in need of primary healthcare facilities. We need to refocus and inform people, especially about what is really available at primary healthcare facilities and which primary healthcare facilities are falling short of the ideal clinics standards. We know that there are many, and I think that has to be addressed long before one looks at the introduction of a national health initiative that is only going to overburden an already crumbling health infrastructure that we have. I'll leave it there. Thank you, Chair.
Thank you, Chairperson. I think it's my chance now.
It's North Narvel and then you.
Thank you, Chair, and thank you for the presentation. I've got just one question that I would like to ask, and it is, has private healthcare expenditure as a percentage of the GDP increased relative to public spending? Thank you, Chair.
Thank you, Chairperson. I'm going to start by asking
questions from Honorable Naledi Shirwa, who's not here. And it says sexual abuse and improper conduct allegations reported to Parliament earlier this year. What is the update thereof? Institution, systematic process, and capacity in investigating, supporting and implementing consequences for cases. How does the institution handle cases and allegations of sexual harassment? Mine are as follows. Under quality and safety care improved. I have a question based on the Eastern Cape Province hospitals, the ones that we visited recently, that has infrastructure problem and a range of very serious problems that are encountered there. And I just want to ask whether some hospitals from Eastern Cape are amongst those hospitals that were refurbished by you, and if not, do you have in your list of those that will be refurbished some hospitals that are from the Eastern Cape? And the last question is based on Compensation Commission for Occupational Disease in Mines and Work. And just to say, according to the first paragraph, it says the Occupational Disease in Mines and Works Act mandates the commissioner to collect levies from the mines and so on, so that the people that suffered from silicones and that disease should be compensated. I have a case of somebody who's suffering from the very same diseases, and it's 2 years now that he's not working and he's waiting for compensation, and no one, irrespective of whatever though we knock at, because I'm negotiating on his behalf, no one has come to solve his problem, nor at least paid him something. So who do I send this problem to for further consideration? Thank you.
Thank you very much, Chairperson. Chair, let me first welcome the presentation done by FFC, but you also touch or maybe comment on the issue that was raised by Honorable Clark. I think Honorable Klaba, you are correct when you are responding to say that NHI, it will be implemented. As African National Congress, we are listening to the citizens of South Africa. And all of us, unfortunately, Honorable Clark, you are not part of the public hearing during the time that we were conducting them. And people have said sharply that they want NHI as yesterday to correct the imbalance of health system that is happening in South Africa. There was also example that was done, or I used to do, by Honorable Wilson, to say that, Honorable Wilson, if we can implement NHI, your helper, Anna, will be assisted even in the private hospitals where he needs medical attention. So I think that chapter, now it's on the implementation stage. I know that you also quoted the Minister of Finance, what he said, but I think the voice of the people, we are to listen to them. They've already spoken. It's now with the NCOP, which is what the president, after the NCOP has done with the consultation, and also people are positive. When you check the public hearings in the provinces, even the Western Cape, people are supporting the NHI because they see that it's going to work and also improve the health system across. So I want to support what Honorable Kaba said, that forward with the NHI, forward, we are not going back. We will implement the NHI. Coming to the questions that I want to ask the FFC, as I've already appreciated your presentation, my question is only one. What impact will the current proposed cost containment measures have on the fiscal allocation for public health care? Thank you very much, Chairperson.
Good morning. Thank you, Honorable Chairs. I also thank you the full presentation from FFC. My only one question is, what is the correlation between intervention programs and the budget for communicable and non-communicable diseases, like cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases, which are increasing in a manner that will distinguish expenditure for HIV? I thank you, Chair.
Thank you, Chair. Thank you for the presentation. I just have two questions and one comment. Firstly, I want to say thank you for highlighting the plight of mine workers and the urgent need for Parliament to intervene in that. We have many mine workers that has died of lung disease and never seen payment, and it is one that this committee should notice and should take up and intervene as Parliament of the people. The second, my questions are the following. Firstly, to be forewarned is to be prepared. So I would join Honorable van Staden in asking, could you expand on what are the challenges administratively and operationally that you've mentioned? Is it just a general statement, or do you have an analysis in terms of the challenges that this Parliament should be aware of as it seeks to implement the NHI? And then secondly, it's actually three questions. 7.6 billion rand loan was made for vaccine procurement. What is the impact and the consequences of the strategic procurement failures? And that is both at a provincial level, where we see contract management and procurement practices costing the public purse millions of rand going to waste, as well as when it comes to one of the biggest health crises that we've had, which is COVID, and the strategic failures in terms of procurement management. And Honorable Clark highlighted one when she mentioned pricing. The others are obviously the capacity negotiations, planning, and the vaccines that has expired. I think as a committee, it is important for us to know what the impact of that has been, as well as the 7.6 billion rand loan that we still have not received a report on in terms of its spending and value to the public. Those are my questions. Thank you, Chair.
Thank you very much, honorable members. Just lastly from myself, now I spoke about this earlier, but clearly you've indicated the correlation between health spending and health outcomes. Also considering the increased burden of disease, the increase in the number of chronic diseases, the challenge with increased demand for healthcare services, And then additionally, also the provincial health budgets being cut where services are actually delivered. So the question I really want to ask, since it's been emphasized here a number of times, what does it in real terms mean if we say that there is fiscal consolidation, and what is that impact really in real terms? And if you are able to maybe speak to this, and how does it impact on health provision and healthcare for patients? The next part is about the main quality weakness, and maybe you must take those three words together. The main quality weakness of expenditure is the FFC, where you identify a weak correlation between healthcare service spending and the health outcomes. And the question really is what in your mind can be done to address those challenges, and how can those gaps actually be closed? I see there's also the hand of Honorable Morewane. Honorable Morewane, for the future, you must please indicate early, because I tend to ask my questions last. I will give you an opportunity now. But I was actually wondering whether you were going to raise your questions. Please do.
Thank you very much, Chair, and my humble apology. I have raised hand before you came in, Chair, because of course I wanted to ask my question before you can ask yours. I hope you'll accept my apology, because I was raising my hand before. It means you have not maybe seen it. Chair, let me also welcome the presentation, and my question is just one question. What funding models can be considered to close the infrastructure financing gap in the health system? That was my question, Chairperson.
Thank you very much. Very good question, Honorable Morewane. Just to close my question on the provincial health budgets, and I was saying that is actually where services are delivered. And one can think one of the programs you mentioned was HIV, TB, malaria, and community outreach, for example. And we are thankful that you brought all of this to our attention, and we should, as a portfolio committee, be able to come with strong recommendations with regards to the cut of the budget of the health department. I'm handing back to you, Dr. Mbavane, for any answers to the matters raised. Let us be mindful, honorable members, that, and I want to say this because some of you come with a Bible full of questions, and you know you're still going to receive all of those entities coming to make presentations. And this is our very first meeting already. We're going to run probably about 15 or 30 minutes into trouble today. Maybe some of those questions you raise can also be raised with the individual entities at the time when they do come to present, so that we manage our time a little bit better. But over to you, Dr. Mbavane.
Thank you so much, Chairperson, to yourself and to the honorable members for all the questions. We will answer the question as much as we can. Some we can respond in writing due to the time constraints. We in our presentation, honorable members, I think we have been quite clear that we do see that there are inequities in the healthcare sector in terms of the skewed nature of healthcare provision. We see that the private sector has more resources than the public health sector, and we do think that we need some sort of health reforms in this instance. And the national health insurance has been proposed as some of those reforms that are currently under discussion. Whilst we do acknowledge that, we also, honorable members, acknowledge that the NHI in its current form remains an unresolved fiscal risk, which needs to be properly counted in terms of what is the impact on the fiscus. As the Commission, we are also on our side currently doing ongoing research as to the efficacy of the NHI and how it can be funded quite effectively. We also noted, commissioners, honorable members, rather, that, you know, there are budget cuts that we see in the system, and that we see these budget cuts also as impacting public health care. And in the medium to long term, we see these also impacting service delivery in this regard. Wanted to find out now if the commissioners who are on the platform have any comments, and then also the researchers to get some of their comments on the technical side. Commissioner Rockman, do you have any comments? If not, the researchers can also respond.
Thank you, Chair. Good morning, honourable members. Now, I think the researchers can take a bite at responding to what they can respond to. But, Chair, as you indicated, the NHI funding models, we've done some research as the FFC. Perhaps we can share again with the committee our research at the time. And then there's an ongoing body of work. And then it is a concern that the health sector, as much as it may be protected in the guidelines on cost containment, it is inevitable that goods and services will be impacted. Conditional grants seem that it's likely to be impacted. I think the clinical posts, to some extent, will be protected. But needless to say, it will definitely be necessary for all departments, provincial departments, to plan around the vacancy and turnover rate of staff, and perhaps also look at occupation-specific dispensation and the implementation thereof. We would need much more efficient management of overtime and OSD specifically in the departments of health. Thank you.
All right.
Back to you. Next.
Okay. Just to respond to some of the questions that were raised. I think the first one that I will attempt to respond to is around the loan, the increase, the loan taken for COVID-19 and its impact on the fiscal system. I think it's quite the impact is that there'll be an increase in the ratio, the GDP to debt ratio. It will increase the debt service cost, like any other loan that the government would have taken to fund whatever expenditure pressure that the government would have. But more specifically, an increase in GDP debt to GDP ratio and an increase in debt service cost crowds out social and investment spending. So that is the impact. That's how it then filters through the fiscal framework or the fiscal spending or the fiscal pairs. And then in terms of as it relates to the issue which was raised repeatedly around the issue of fiscal consolidation, I think in our annual submission, we do touch on the issue of fiscal consolidation. And part of the things that we highlight is that South Africa tends to rely excessively on expenditure cuts to reduce fiscal deficits. And we do note that although this may be warranted in some circumstances, but revenue measures should also play a role in terms of supporting the reduction of fiscal deficits or trying to achieve a fiscal consolidation. Because we say that, expenditure cuts, some of the expenditure cuts may be detrimental to growth. So there is a need to be targeted in terms of what expenditure cuts are targeted. And here, as it relates to health, we do note that some of the expenditure cuts may begin to affect health outcomes, may begin to exacerbate the inequality in terms of access to health. So there is a need to consider what type of expenditure cuts do we undertake in order to remain on a fiscally sustainable path. But overall, we say that for us to get back on a fiscally sustainable path, there is a need to have measures that support growth, because I think more cuts may be detrimental. So we need to grow our way out of this fiscal impasse, as it were. And then in terms of the specific hospitals which were refurbished, this is the information that is reported by the health department in their annual report. And if there is a need for the list of the facilities that were constructed or refurbished, we can, I'm sure through our chairperson, request that information. And I'm sure also that the committee, as it interacts with the Department of Health, can also request that information, so that there is much clarity in terms of which facilities were refurbished, as the department has reported that. But even on our side, we can do that. And then I think that also relates to whether the Eastern Cape is also included, insofar as the list of host facilities that were refurbished. I think that the request of the list would then resolve that question. And then, insofar as before I hand over to other colleagues, insofar as the specific specific expenditure items as they relate to goods and services, we can get those specific expenditure items, but this does not relate only to consumables, but it also relates health and goods and services. Sorry, goods and services also relate to a vaccine procurement that are used, the machinery that is used. So it is a broad category that includes other expenditure items which may be vital to achieving health outcomes. So hence we are very cautious to say cuts there as well may be detrimental or may affect health service delivery. So there is a need even there to interrogate further insofar as which items, specific items, are then subjected to cuts, so that we don't cut items that actually enhance or strengthen this service delivery insofar as health. I think I will hand over to my other colleagues who can touch on some of the issues that were raised.
Thank you so much. Thando, do you have any comments before we hand over?
No, thanks, Chair. I think Sianda has covered all the issues that we wanted to respond. Suffice to say that the key message that we wanted to relay to the committee is the fact that we have a fiscal consolidation exercise that is being implemented by government, which seem not to take into consideration as Sianda has said, as FFC, we've always made the recommendation that the fiscal consolidation must be pro-growth. And then secondly, the most important aspect after that is that of service delivery. So we have a fiscal consolidation that seems not to take into consideration growth aspect, but also most importantly, the service delivery. So as we implement this fiscal consolidation, what is important for the sector is to bring out sharply how it is affecting service delivery, so that this could be taken into consideration as we implement it. Thanks, Chair.
Thank you so much, Sianda. So as we hand over, Chairperson, I think the key message is that whilst we implement cost-cutting measures, let's protect our socio-economic rights to healthcare. Thank you so much, Chairperson. Over to you.
Thank you very much. Let me take this opportunity, Dr. Mbava and your team, to thank you for the presentation and also for the responses to the questions raised by the members. We look forward to the other matters which you said you would send in writing. You're welcome to send that to the Secretary of the Portfolio Committee, whom you have the email address of. Honorable members, we're going straight into the presentation from the Auditor General. Dr. Baba, you're welcome. You and your team to stay on. You're also welcome to leave. But we will now receive a presentation from the Auditor General of South Africa, which is the briefing on the analysis of the health sector's annual reports. And I see that Ms. Musinyana and Tipe have already been made co-hosts. I also see one of their leaders, Mr. Andri Segeto, on the platform. But I think I will hand over to Ms. Tabelo Musisinyane to introduce everyone. We will then, after that, go straight into the presentation. And honorable members, we are now behind with 30 minutes. It will eat either into our lunch times or it will eat into the presentation time of SAHPRA, or we'd have to probably just go a little bit later today. So I'm going to hand straight over to the representatives of the AG on the platform. Thank you.
Thank you, Honorable Chair and Honorable Members. Good morning. As indicated by the Chair, my name is Tabelo Musisinyane. I'm currently the Acting Business Unit Leader in the unit we call National D in the National Office that is responsible for, amongst others, the health portfolio. Correctly said, Honorable Chair, I'm not alone today. And as I mentioned, some of the things I'll just ask them maybe to switch on the videos and wave. I hope I'll get everybody. So I will start with my principal, Mr. Andri Segeto, who after the introduction, I will also ask him to have some opening remarks. He is currently the head of portfolio within the office of the AGSA. I also have Mrs. Mule Tipe, who is the senior manager responsible for the audit of the National Department of Health. And also she then assists with the coordinating of the audits of the provinces. I also have on the call, she's accompanied by her managers. I do understand they were supposed to be in the call, so I'm not sure. Okay, I see some of them are switching on videos. We also have the senior manager, Mrs. Bozo Chauke. She's responsible for our information system audit. And then we also have our colleagues that come from the performance audit unit. They assist us with some of the technical stuff that as auditors we need assistance with. And we have Marika Snehans, who is not a visitor in this committee. She's presented a few sector areas. She's accompanied by Dr. Melbeck. I hope she can also share screen. She's our health specialist that assists us. If you'd recall, Honorable Chair members, we are auditors in trade, so we do understand that some of the technicalities from the health side, then she did assist us. I hope I covered everybody on my side, but I think my colleagues can indicate if I missed them. But I think the message there, Honorable Chair, we came with our technical team so that if there's any other questions that the Honorable Chair and members would want to know, they would then check in and jump in and assist. So I'm going to allow our principal, Mr. Andri Segeto, just to greet before we then start the presentation. Over to you.
Good morning, Honorable Chairperson. Good morning, Honorable Members. Tabero, you must ask permission from the Honorable Chairperson before you bring in people on the platform. But since I have the floor, Honorable Chairperson, Honorable Members, thank you for the opportunity. I think I'm also quite mindful of the guidance and the caution advanced by the Chairperson insofar as it relates to time. So we will not have a lot of long opening remarks. And I also ask then that the colleagues, despite us having a number of issues that we would like to elevate and present to the portfolio committee, that we just focus on elevating those salient or key important points. We will also then therefore take the presentation as having been engaged with by the members, and therefore Tabero and the team will just, as part of their presentation, focus on highlighting some of those salient key points. As part of the presentation structure, Honorable Chair, Honorable members, so we will report on the audit outcomes of the national department, as well as those entities that report at the national level within the portfolio. But also, as per usual, we will include on some key high reflections on the matters of sector, which are linked to service delivery. Honorable Chair, Honorable Members, This is done with the aim of really empowering and supporting the committee as part of its oversight responsibilities to have sight of some of the key matters and key issues on the sector, because as we all are familiar that the sector has a concurrent function in the sense that most of the service delivery happens within the provinces. And so the accountability ecosystem is working in the respective provinces where those audits would have been concluded in the respective provinces. The accounting officers or the HODs engaged, as well as the MECs, insofar as it was practically possible. And then we then consolidate all the audit outcomes of those respective provinces, and then give also a high-level overview of some of the key focus themes that we would have identified on the sector. So on an annual basis, we sit back and we reflect and we say, what are some of the key topics that are prevalent within the sector? What are some of those key pressure points? And where can we then assist in providing the impact that we would like to see on the ground? So the presentation will be the audit outcomes of the national space, the reflection on the provinces and the respective outcomes of the provinces, but also then include a reflection on the key messages on those themes that we would have identified. I must also state, Honourable Chair, Honourable Members, when we walked in, we picked up that there was quite a raging debate around one of the key themes that we will also present on. Thapelo will give a little bit better context insofar as it relates to that particular theme when we get to the presentation. But without further ado, Honourable Chair, Honourable Members, as per the Chairperson's guidance, I will then hand back to the team so that they can start their presentation and then continue and proceed so that we can then be mindful of the time per Honourable Chair's guidance. Thank you, Thapelo.
Thank you so much for the opening remarks. Honourable Chair, before we continue, we would like guidance on how the Honourable Chair is suggesting we take the presentation. So we have two sets of slides, which is firstly is the National Department and its entities, and then we also have the sector. So we are asking for guidance, Honourable Chair. Do you want us to present both slides back to back, or do you want us to take a break halfway through?
I'm going to suggest that we take both, but be mindful that one's attention span is not that long, but I wouldn't like to have discussions in between. So I'm going to suggest we get the first presentation, we take a 5-minute break, we get the second presentation, and then we have discussions on both. Thank you.
Thank you, Honourable Chair, for your guidance. So with the first sort of presentation, Mrs. Muletipe is one who's going to be taking the presentation, and then with the second set of presentation, then I will be taking the presentation. So I'll hand over to Mule to then start the presentation. Thank you.
Sorry there, Thapelo, just to remind you that we normally do not spend enough time on the work on the sectors. So hopefully you spread this, that on the one hand we have the presentation on the department, but then we also get a thorough presentation on the sectors to spread your time evenly between those two. Thank you.
Thank you, Chair. We will allocate the time as your guidance, Chair. Thank you. Over to you, Mule.
Much, Honourable Chair. Thank you to the members, and thank you again to my leadership as we're taking you through the BRRR slides on terms of the outcomes of the health portfolio. I am having technical glitches. Okay. As we do year on year, we aim to build public confidence, thereby through the work that we do in terms of that we then strengthen the country's democracy, which we enable oversight by presenting these outcomes to you so that you have them in your view, then you're able to then hold the portfolio to account. On this slide, we're sharing the lived experiences in terms of our South African citizens, which is unfortunate in this time and age. And our aim is to work together with the portfolio, with those in the oversight, in order to change the picture that we're currently seeing. In terms of the next slide, Honorable Chair, we're looking at the accountability ecosystem, which is what we have within our AZSA. On the left side, we have the leadership and the decision makers. On this slide, we're showing the relevant officials, the senior management, accounting authorities, and the executive authorities. These are the people that are responsible for the annual performance plans, they're responsible for the annual performance reports, and they are the ones that will be reporting in terms of the targets that they would have set, and they are responsible for the portfolio, ensuring that the right internal controls are implemented, ensuring that when things are not going right, they therefore go back. They need to make changes where they need to make changes. And from there is credible financial and performance reporting. On the right side, we have the support and oversight committees like yourselves. We have coordinating departments which are responsible for assisting the department in reaching their targets and ensuring this. In some instances, for example, when the APP is published, we have coordinating departments that should be assisting the national departments and the overall sector in ensuring that everything is well, everything is done well. And we also have the support and oversight, which also assists in terms of ensuring that everything is done accordingly. And in the middle, we have ourselves as the AZSA. And in terms of the work that we do and the service, the work that we do in terms of the audit processes and the value add work that we do, we get insight in terms of the work, we share it with management. And by that doing, we would like to influence management in ensuring that their targets are met and that they do the right things, they implement the right controls. And in the absence of that, we therefore have an enforcement. This is where the material irregularity or the amendments of the PAA come in, where we issue the material irregularities. And if these material irregularities are not adequately dealt with at the right level, then we enforce, and therefore we go through certain processes to ensure that money is not lost to the fiscus, or there is service delivery that that is impacted. We also involving the CSOs in terms of the work that we do, because we acknowledge that all of these things, it's for the citizens. We also want to have active citizenry in terms of our accountability ecosystem, because whatever that is done at any level, ultimately it will then impact the citizens of South Africa. On the next slide, we are reflecting the audit outcomes of the portfolio. We are continuing to audit as we have been auditing. We audit the financial statements, we audit the predetermined objectives as well as compliance with the relevant laws and regulations. What we are seeing in this picture, we are seeing an improvement from the portfolio. This is because of the National Health Department improvement of the audit outcomes from the prior year. The qualification area, which they had in the prior year, management worked very hard in terms of resolving the qualification area with the assistance of the new CFO who was appointed last year. So this issue was resolved from the audit processes. Then if we look into just the financial side, on the financial side, Chair, we have the other findings. So as I've mentioned, that we audit the financials, we audit the PDO and compliance. So basically it means that the entities and the national department in yellow, they are unqualified, but they just have the issues that we have identified, either in compliance or in performance information. This is where we have then issued the findings. So on the national department, there are issues that we've identified, particularly under the performance information. I will just get into a bit more detail as I go through the slides. On the CMS, similarly, there has been unqualified with findings particularly on irregular expenditure as well as consequence management.
Can I just interject quickly? Can I interject quickly? There's somebody who possibly has two devices open. There's a lot of echoing from your side. And if you do have your camera on, you could also switch that off at the see if you get an improvement. So whoever that is, please make sure that you only have one device on at this time. Thank you. Please continue.
Okay. Please confirm if it's better.
Yeah, that's normally when there's another person in the same vicinity having another device, or they could maybe move away. Or if somebody has two on, please make sure you only follow with one. Please try again.
Okay, I believe that there is an improvement here.
Much better, thank you.
Thank you so much. Apologies for that. So if we look at the CMS and the NHLS, their outcomes have remained unchanged from the 1920 financial year, Chair. So this is where there needs to be improvement or needed to have implemented certain internal controls, identified what is working or what is not working in this area so that they then move to being unqualified. NGOH and SAHPRA, they remaining unchanged for the 2021-22 financial year. With SAHPRA, what we are seeing is that in terms of they now have compliance finding that was issued. This relates to revenue management, where we have identified that effective and appropriate steps were not taken to collect all money that was due to the entity. This is because proper processes were not implemented in terms of collecting the revenue that is due to the entity. On NHLS, we have not identified any findings on performance information. However, there are a lot of findings that we had identified through the audit processes, where we saw that from the financial side, there were a lot of material misstatements which were not picked up by the review processes, by the internal controls from the management side, which had to be corrected via the audit process. And then if we look at on the left-hand side, we have MRC, the Mines and Works, as well as the OHSC, which have attained clean audit, meaning that there were no findings on financials, on predetermined objectives, as well as on compliance areas. It's important, Honorable Chair, that we not only look in terms of this, but we also look as to whether there is achievement of targets relating to the PDOs. It is good and well if they are ticking the right boxes and they are green, but there also needs to be an outcome that is on service delivery that relates to the targets that need to be achieved by these entities. The good thing that we've noted is that the financial statements have been consistently submitted on time by the portfolio over the couple of years. If we move on to the next slide, Chair, we're looking at the quality of financial reporting, where we look into the root causes of the issues that we would have identified in the entities that we have. We have proper record keeping, which keeps coming back. This is on the National Department, on SAHPRA, as well as on NHLS, under issues, some relating to performance information, some relating to their financial statements. The daily monthly controls, they are quite critical. They need to be properly implemented. And the in-year reporting needs to be implemented consistently. So reviews are also critical to ensure that some of the things that the controls might have missed are then picked up through the review processes. If we're looking on the right side, we are basically our message there, we're just saying that for NGOH, SAHPRA, and NHLS, if we were to just give them a report now before making adjustments, they would have been qualified. The impact of all of this, it means that there were material misstatements that were identified, which led to the adjustments being made to the financials. Therefore, the audit processes then corrected the issues that were identified, and therefore leading to quality financial statements submitted and reported in the portfolio. As I previously mentioned, that we also audit not just the financials, but performance reporting as well. Under performance reporting, we are seeing that NHLS, OHSC, and CMS and MRC did not have any issues, meaning that the information that was submitted relating to performance information, it was reliable and it was also credible. There were no findings that we had identified. We had identified findings on NGO 8 and SAHPRA, and some of these findings, the department and SAHPRA were not able to correct the misstatements. This is because in one instance, in the NGO 8, there's an indicator which was not clearly defined. This, as a result, measurement of the target was not properly determined. Under reporting, we have instances where the audit evidence did not adequately support the reported achievement on some of the indicators. The impact of these findings that we are reporting on, specifically on NGO 8 and SAHPRA, is that it takes away the efforts to adequately monitor and report on the implementation of key strategic targets within the portfolio, and that the MTS targets are not able to be sufficiently tracked. There's also a risk that these institutions will not then achieve the intended or planned objectives and mandates. On the initial slide, where I was reporting on the outcomes of the portfolio, I indicated that there's some instances where the entities, the mines and works, the OHSC, they have attained clean audit outcomes, meaning they were green. So the question is, are they now achieving their targets in the portfolio? So we're just giving an indication in terms of where they are in the portfolio as to whether they are achieving their targets or they're not achieving. You can see that CMS is leading with 9% achievement rate in terms of their targets, with the NGO 8 at 58%. What we have done, we've looked at the key targets in the MTSF period for the portfolio, and we have identified certain key targets and just would like to reflect on those specific key targets. In the NGO 8, we looked at specifically the NHI program, as well as the other program that talks to the communicable and non-communicable diseases, which we've identified as material programs within the NHI, within the NGO 8 department. We had identified that some of the key targets being the NHI fund purchasing health services by 2024-2025, this indicator, the department has not achieved it, and we do take cognizance and acknowledge that there are other dependencies of these indicator because the bill is now currently with the NCOP. As a result, it's outside the management controls. The other target we looked into that touches on the MTSF is a number of the primary healthcare facilities that qualify as an ideal clinic. Ms. Musisinyane will take us through the detailed findings that we have identified as and when we were auditing this specific indicator and the facilities as to whether they qualify as ideal or not. In terms of the policy and legal framework to manage the medical legal claims in South Africa, that one, there's also other dependencies as well, where we have identified that the South African Law Reform Commission, to finalize its processes, it's still a bit of a waiting game for the department because of the Law Reform Commission. And relating to the case management system, which is developed and implemented to streamline case management in the 8 provinces. This we reported on last year when we were doing the BRRR briefing, Honorable Chair. And we've identified that there's still delays in terms of implementing and using this system in the sector. There are those delays that we've identified. So meaning that these key targets, it's not achieved. And it's one of the targets that is going to enable the national department and even as the oversight committees to have a look into the cases that are being logged, the claims, the medical legal claims that are being logged on the system, and be able to then take decisive action relating to those things. Because if it's on one system, you're able to see where the issues are. You're able to see the lawyers that will be that are dealing with the specific cases. And if there's any outliers, then management and even the oversight committees are able to then deal with some of these issues. On the OHSC, we've identified that there's the percentage of public health establishments that have been inspected for compliance with the norms and standard has not really been achieved. Again, we looked at the impact relating to the targets that has not been achieved. It then delays the NHI implementation to achieve universal health coverage for all South Africans. There's delays in terms of the quality of the primary health care, and possible increase in terms of the medical legal claims due to poor quality health care, which is a loss to the departments and loss to the health funding, which is critically needed in the health environment and in the sector. On the next slide, we have outlined the key performance targets. This information is also in the annual report, and we'll be talking to the areas that we've highlighted in a little bit more detail in the presentation that will be given by Ms. Musisinyane. I will not go into the detail, but we're just outlining these key indicators as well as the actual performance against these indicators and the reasons for the non-achievement. If we look at the ICT chair and we look at the work that we've done in terms of ICT, we have critical findings that we have found through our audit processes, and some of them we reported in the prior year, so we note them as repeat findings. So we have identified that there are delays in terms of national digital health strategy, and that there's also inadequate IT cybersecurity strategy. We also looked at the root causes of these, where we've also indicated that there is lack of governance structures over IT projects and inadequate contract management processes. There are a couple of themes that comes through as and when we look at the some of these slides, such as consequence management as an example, which then leads to poor governance and delays in digitization of the sector and adequate IT controls. So there are poor IT controls, even IT security controls in the environment, which is quite critical in any institution. There are certain recommendations that were given to management relating to these findings that we've issued, and some of them is fostering a culture of consequence management for poor performance. The ICT strategic plan is quite critical, and it forms the bedrock of the NHI system, because some of these systems, they are supposed to drive the NHI. These systems, they are supposed to bring efficiencies in terms of the delivery of services. We find that where there are these initiatives, there is poor usage of the systems. Some of the issues we've identified is that because there's no digital strategy, the provincial systems may not be fit to then support the NHI. And where there's no cybersecurity strategy, the department will be really challenged in terms of identifying, responding, and recovering from a cybersecurity attack. Relating to the HPRS, we've identified that there are delays in terms of the rollout of the HPRS system, and that there's also training that is not provided to the users of the HPRS system, and that this system does not also interface with the other systems. Some of the systems that would then touch on the service delivery aspect, because we're talking about patients that would be going and being registered, and their names being registered when they go to one province. When they go to the other province, their names are supposed to already been there, having the history of the people there. It comes to digitization of the health sector environment. The third area we audit, Honorable Chair, is compliance with the relevant legislation such as the Treasury Regulation and the PFMA. And in that, we had identified that there were no material findings relating to MRC, CCOD, as well as OHSC. And there's instances where we've also identified that the portfolio has dealt with some of the previous findings that were identified on procurement and contract management. And some of those entities that would have affected the consequence management would be NHLS, SAHPRA, as well as the NDOH. However, there are repeat findings that we've identified throughout the portfolio. This relates to the quality of financial statements. It's impacting the National Department, SAHPRA, and NHLS. Consequence management relating to the irregular expenditure is coming through from the CMS side, and prevention of irregular expenditure in terms of the NHLS and CMS. Other compliance areas that relates to revenue management, as previously indicated, it's on SAHPRA, where they did not implement the right controls to ensure that revenue is collected to the entity. On the National Department, we have IFIRA compliance finding relating to expenditure management, where we found that the department is taking more than 30 days to pay their obligations. When we now come to the PFMA compliance and reporting framework, Honorable Chair, there was a bit of a change which was coming through from the National Treasury. Instruction number 4, the PFMA compliance and reporting framework. It came into effect on the 3rd of January 2023. It brought about significant changes in the disclosing of the irregular expenditure, which means that the historical information relating to the irregular expenditure and fruitless and wasteful expenditure will no longer be disclosed on the financial statements. This disclosure is now taken into the annual report. Only the amount that relates to the current year and 1 year comparative is included in the annual financial statements, which is what we audit, which is what is then submitted for audit purposes and for tabling. Our message to you, Honorable Chair and the honorable members, is that we no longer give assurance in terms of the amounts that are disclosed in the annual report, because our audit is limited to the financial statements. However, we have refined our audit approach to uphold up transparency by continuing to audit this disclosure of irregular, fruitless, and wasteful expenditure in the annual report. We have a responsibility as the AGSA to verify if the information captured in the annual report, it talks to the information that is in the financial statements and the information that is in the books of the entities and the National Department. And from that perspective, our objective is to ensure that we could still be in a position to report to the users of the financials in cases where historic balances of irregular, fruitless, and wasteful expenditure are not complete and not accurate. This has no impact in terms of the audit opinion. If we now talking to consequence management relating to the irregular expenditure, we have noted that over the past 4 years, there is a decrease in the current year, 2022-2023. So overall, we're looking at the annual.
Can I just ask you to please go back to the previous slide? It's just a very quick thing, just for us to, on the PFMA.
Okay.
Your message to us.
Yes, Chair.
Yes, message to Portfolio Committee.
Yes.
When you say you no longer provide an audit assurance, is that on the entire, that wouldn't be on the entire annual financial statement, that would be only on this matter of unauthorized, irregular and fruitless and wasteful expenditure, or how can you qualify what I'm just asking?
Okay, thank you, Honorable Chair, for that. So basically, our message is that the historical movements, Honorable Chair, they are no longer disclosed. However, if they have incurred irregular expenditure in the current year and in the prior year, we have a responsibility to audit that amount in the annual financial statements. The historical amount is supposed to be disclosed by the entities and the departments in the annual report. The bulk amount, including the current year and the prior year, is supposed to be disclosed in the annual report. So what we do, we continue to audit it. However, if there are instances where the amounts are not fully disclosed, or maybe there's an issue relating to completeness in the annual report that relates to the prior year. So as an example, it relates to the 1920 financial year. It would not then impact, we would not qualify the financial statements of the current year or the comparative.
It's fine. Thank you. Fully understood. Please continue.
Thank you, Chair. In terms of the slide, we're looking in terms of the movement over the years, the annual irregular expenditure, the increase, and there has been an increase, and in the current year, we've noted a decrease in terms of the irregular expenditure. However, when we look at the balance, we're identifying that there's an increase. So some of these instances, it's irregular expenditure that would have been identified either in the current year or prior year, but relates to the historical information. Hence, we are now seeing the increase in terms of the closing balance relating to irregular expenditure. This irregular expenditure is as a result of the breach of the 5 pillars relating to procurement, meaning that the procurement was not done in an equitable, fair, cost-effective, transparent, and competitive manner. We also unpacked it just to see where the bulk of the amount comes from. For the current year, the 705 billion, it comes from the NHLS, which was a top contributor relating to the irregular expenditure incurred for the current year. We would also like to commend the National Department, SAHPRA, OHSC, and MRC for not incurring irregular expenditure in the current year. We also unpacked the reasons for irregular expenditure not dealt with. And on the top 3 contributors, we have the NHLS, the NDOH, as well as CMS. And we've identified that we also wanted the reasons as to why has this irregular not been dealt with. And we found that within NHLS, they have investigated the irregular, however, it's awaiting condonement. Within the CMS environment, investigations are still in progress. and within NDOH, they have investigated it. However, the consequence management has not yet been implemented. Overall, it's about 99% that has not been adequately or finalized or dealt with amicably so. If we look at the conclusions and recommendations, we would like to just reflect in terms of the recommendations that we gave to the portfolio committee in the prior year. And there is one which was implemented, where we are reflecting back in terms of the NDOH, in terms of the clearing of the qualification. We commend the department for clearing the qualification and addressing the issue, but the onus remains on management to continue with their efforts in terms of consequence management and ensure that everyone is held to account, particularly where there is irregular expenditure involved. The other recommendations that we gave, they speak to the oversight controls that needs to be implemented for a proper record keeping, to ensure that information that is submitted is kept and is kept well. And when this information is needed, it would then support the information that is captured in the financials as well as performance information. The recommendations, they spoke to strengthening of the internal control environment. It speaks to the reviews of financials as well as PDOs to ensure that there's proper compliance with the relevant frameworks. It talks to strengthening of the internal controls, the daily checks and balances, ensuring that the reconciliations are performed as required. The performing and finalization of investigations, NDOH was still in the process of implementing consequence management. However, there's investigations that were done. When we now talk to the supply chain management processes, it is an issue specifically on the NHLS and CMS. And for CMS, it has been happening for a couple of years now. So there needs to be proper focus in terms of CMS, just to ensure that the proper root causes are dealt with and proper internal controls are implemented to prevent the recurrence of irregular expenditure in their environment. Overall, there is some improvements here and there. There are areas where management really need to go back to the daily, monthly, quarterly checks and balances to ensure that records are well kept, to ensure that they do their reviews, to ensure that internal controls are continually implemented in their respective environments. If we look at the overall portfolio committee messages, Honorable Chair, we are just reflecting on the key root causes, key recommendations, and also the commitments that were made by the executive authority. So if we look at the key root causes, they always go back to proper record keeping. It goes back to keeping information that is supported by reliable information. It goes back to the daily checks and balances. It goes back to ensuring that there's proper compliance in terms of the relevant laws and regulations and monitoring thereof to ensure that there is no recurrence. Again, controls relating to IT governance, they are really an issue in the health environment, specifically NDOH. The recommendations, it just means that whatever controls that you implement, it needs to be a proper control. It needs to address the issue. When we go in and audit any environment and we give them findings, there's an area where we give them the root causes. We agree in terms of the internal control deficiencies identified. There's also recommendations on how some of these findings can be avoided or what controls needs to be implemented to show that there is no recurrence. So just going back to those basics is going to really assist the entities and the department in avoiding the recurrence of the issues identified. We met with the Honorable Minister as well as the DG, and they have given us their commitment in terms of strengthening the internal control environment so that the audit outcomes might improve. The entities and the department in yellow can move to the green, and to ensure that the ones that are in the green, they achieve their targets from service delivery perspective. the DG and the minister, they've also given us their commitment in terms of capacitating the internal audit environment to assist with the internal controls so that as a matter of fact, there's an impact in terms of the improvement of the audit outcomes. He also gave us a commitment in terms of improving the IT governance by involving and consulting the relevant stakeholders. Overall, Honorable Chair, some recommendations were implemented, some not. Action plans, they need to be effective action plans that deal with the actual root causes. When an action plan is done, it should not just address a part of the issue. It needs to be impactful in that everything it's then corrected and even corrected going forward. Internal controls, we cannot emphasize that. We cannot overemphasize the importance of internal controls relating to financial and performance management, as well as IT governance and continuous monitoring relating to the compliance of the relevant laws and regulations. And it brings me to the end of my presentation. With your permission, Honorable Chair, I would like to take it back to Ms. Musisi Nyani so that she can just give the overall summary, as well as, I'll just pause there, Chair. Thank you.
Okay, you may do that.
Thank you. Oh. Apologies for that. Thank you so much, Mule, for the presentation. And Honorable Chair, honorable members, that's the end of our presentation from the National Department of Health and its entities. And really, just a recap, what we are presenting today, when we look at from a financial statements point of view, the portfolio really has been sitting in this position for a while, and we've really emphasized on the controls that needs to be implemented at the entities. We do commend the NDUH for then correcting the prior errors. But I think for us, our message is there needs to be efforts towards improving the financial management controls. I think when you look at the presentation, the majority of the issues that are remaining for some of these entities is in the compliance area. And a lot of them is either on where the financial statements are not of good quality when they are sent to us, and therefore the entities indirectly then rely on the audit process to get their financial statements right. But also we're seeing some entities really struggling with addressing some of the issues around the irregular expenditure, especially at the CMS. So we have seen the portfolio making strides, especially on the procurement contract management. There are areas where they don't have material findings reported, and also there are entities that are not then reporting irregular expenditure. We are then saying there's a few things that they just need to tie up so that they are able to move the sector towards clean audit opinion. And we also saw instances where there is no, the targets are not being achieved. And I think ours is to say management really needs to ensure that they implement action plans to be able to then achieve those targets, because we do understand that those targets are linked to service delivery. So that was the message from our side on the NDH and Honorable Chair. We'll then take further guidance from you on the break that you had suggested initially.
Thank you very much. We appreciate the presentation to you. Honorable members, I'm trying to work out the time now. And it is very, very tight. So it is now 11 minutes still. We're going to have a 6 minutes break until 5 minutes to 12. We're going to get the next presentation to 12:20. Then we have questions to 1300 hours, and we'll get responses from 1300 hours to 1330. It's more or less what I'm looking at in terms of time management. So enjoy the comfort break, and we'll be back, start at 5 minutes to 12. Thank you. back, honourable members, and also our staff and the members of the AG who are doing the presentation. We will, as I indicated, continue with the next presentation on the sectors, and then we will take all of your questions, honourable members. I'm trying to ensure that we're able to stick to our timeframes, and I hope you will indulge me on this. So let's continue. Thank you.
Thank you, Honorable Chair. May I please get confirmation that you can see my slide?
I can see it. Thank you.
Thank you so much. So I will be taking the second session, the second part of the presentation, which relates to the outcomes for the health sector themselves, the health sector. So I will not cover some of the slides that has already been covered. So our starting point is a reflection on the actual audit outcomes that we were then signed off at the end of our audit in July this year. And when we look at the overall audit outcomes of the sector from a financial statements point of view, we are noting that there is an improvement in the outcomes that we are tabling today, Honorable Chair and Honorable Members. And the improvement is due to the NDOH that was able to clear the last year matter that was raised, as well as the KZN, Honorable Chair, and the members that were able to get out of the qualification area. If we recall, Honorable Chair and Honorable Members, for a number of years we have been raising the challenges in KZN where they were really struggling to get out of the qualification, and one of the factors we were raising was around the instability in leadership. So in the current year, we are happy to report that the KZN was able to then clear their findings. And what was interesting about the KZN case from the financial statements point of view is when they were dealing with the matters, they did not have material misstatements that were then raised by the audit team. So it just shows that with the appointment of the CFO that they appointed and the internal control that they have improved, they were able to then successfully clear the matters that were raised in the prior year. So our recommendation to them is they continue in the same trajectory so that they don't regress in the coming year. We are also highlighting the fact that we are not seeing an improvement in Eastern Cape, Free State, and Northern Cape. And I think from our side in the slide weights in the purple, those remains then are one of our provinces that we are concerned about. With the Eastern Cape, we noted that there was a slight improvement in the audit outcome. The only matter that is remaining from their side is contingent liabilities. So we are really hopeful that in this year, during the year, as they are then dealing with the monthly controls, then they will be able to address some of the reconciliation issues and then hopefully then clear the matter in the coming year. With Free State, unfortunately, even though they remained in the qualified block, unfortunately, they then had other matters that were raised in the current year. So in the prior year, they only had a qualification and regular expenditure. However, in the current year, there were other matters that came. So from us, it goes back to the conversations that we then give them to say they need to ensure the fact that the control environment is improved so that there is no regression in the audit outcomes. Northern Cape, Honorable Chair and members, remains our biggest concern because this is one of the provinces that has not been moving over the years. And it's also one of the provinces that still has multiple areas that we are raising material findings on, as indicated in the next slide. So for the provinces that are sitting in our orange block, which is the unqualified with findings, we are noting that they are clearing some of the findings on financial statements, but they still have matters that they need to address even on compliance. So in the next slide, we just highlight some of the financial management controls that were not working as effective as we would have loved to, that then contributed to the audit outcome that we saw in the previous page. I think one thing that we are then highlighting that is interesting is the fact that, as I indicated, with KZN, when they were coming from a qualified position, they were able to submit financial statements of good quality, and we really commend them for that. However, we are also seeing that there are some entities, even though they are ending up with no material findings reported, they sort of indirectly relied on the audit process to be in this position. position. So for all those entities, and we're then saying to them, they need to ensure that there's proper record keeping. The daily and monthly controls are implemented on a quarterly basis. When they are submitting the quarterly reports, they need to ensure the fact that there is supporting information that is supporting whatever they're reporting, and it's critical because it does have a rollover effect at the year-end reporting. As indicated, unfortunately, Northern Cape, Eastern Cape, and Free State remains in this block. One thing that I forgot to mention, Honorable Chair, is the fact that unfortunately Limpopo's audit has not been signed. There were some disagreements between the teams, but we do know that they are having meetings to be able to ensure that they then clarify the differences. On the last block here, we are just highlighting the number of areas that Northern Cape had on the financial statements, and this is why we are then saying we believe that an intervention is required in the province if they are to be able to then move from the audit outcome. The next session that I'm going to look at is the outcomes on the performance reporting. So as part of our audit process, we also look at the annual performance plan and the annual performance reports. And our main purpose there is to ensure that whatever the sector is reporting as achievement is valid, accurate, and complete. So, when we look at the changes from the prior, in the prior year, we had only scoped in one program, which is program 2. However, in the current year, we then scoped in an additional program. But when we look at the picture that we are seeing, and I'm really going to talk about the reds and the purple that are on the screen. So the red usually is the worst case scenario. These are instances where the teams are saying we were not able to reconcile some of the information that we are receiving. And therefore, because we cannot reconcile, we are unable to confirm whether the reported achievements are valid, accurate, and complete. And therefore, we raise material limitations. However, when we then look at the purple that we currently have, the purple and there's a light purple, it talks to instances where the team had information, but sometimes there were differences between what the team was seeing and what was reported in the annual performance report. So when you just look at those colors only, it seems like the reds are reducing, which means that the sector is really moving into a place where they are able to give us the information that we are looking for. However, they just need to make sure that the information that they are giving us is tying to the reported achievement. The good story we are telling in this slide, Honorable Chair and the members, is the improvement in the Free State. So Western Cape has for a number of years not received findings in this area, but we really saw a good turn of events with the Free State, where in the current year, they did not have any material findings reported in the annual performance report. Our current understanding is the fact that they held district-wide workshops throughout with all the staffs, from the data capturers up to the DDGs, and they were highlighting the importance of making that the data is correct and the impact it has on the overall audit outcomes. So it seems like those workshops really did work. They yielded good results. And our message to the sector is to say they need to then share best practices with the rest of the sector so that we are able to move their sector from this position that they find themselves in. And I think our impact that we raise with this sector is the fact that because this relates to the achievements that are linked to the MTSF targets, if we are unable to verify some of these amounts, it then really questions the amounts or the achievements that the sector is reporting, and they will not be able to implement the necessary corrections to ensure that at the end of the MTSF a term, they are going to meet the targets that they've set for themselves. So we are working closely with the sector. Even in the current year, that we had what we call a 10 by 10 where we brought together the representatives from the department side, provincial department side, as well as the audit side. And this session was led by the CFO at the NDOH, and we're really commending him for really championing this process. And the purpose was also to bring these teams together to say, how can we assist each other in dealing with the inconsistencies, and the sectors that the province that we're doing well, we're also sharing some of the best practices in the sector. So we really do commend that this session continues, because we really are hopeful that it's really going to have a ripple effect in the change we are seeing in the report. Moving to financial management. So one of the other areas we look at is what we call the financial health. And in this area, but the financial health, Honorable Chair and members, we really look at how the sector is doing from a financial point of view. I do understand that at the point we were joining the call, the FFC was presenting some of the areas around the funds. But on our side, with the little work that we do, what we then do is we try to assess how the funds of this sector are looking as at 31 March 2023. So the exercise we first do is we look at the appropriation for the following year, which is the year that we're currently in. And then we then look at what is the current balance of what we call the accruals and payables not yet recognized. So in essence, these are unpaid invoices. So these are instances where the services was rendered during the year. However, at year end, those invoices were not yet settled. So when we look at those ratios, we're realizing that 17 billion of this unpaid invoices still remained at year end. And that really, it constitutes 19% of the appropriation for the next year. So what that means for us is, if the sector is not able to settle these invoices, they are then going to use the appropriation for the following year to then settle the invoices. And the message here, what we are trying to say is that it means that if this cycle keep continuing, because we did see it in the prior year where the accruals balance was 16 billion, we are saying the sector keeps borrowing from the future while they're trying to settle the prior invoices. And that then has an impact on the funds available for service delivery in that particular year. We also are highlighting the fact that the claims against the state are still high, and the number in this slide represent all claims, including the civil claims. We do know that the majority of this balance is medical legal claims, but we are also highlighting the fact the numbers are still high. And if these claims are successful, unfortunately, they once again are going to eat up on the money that was available for service delivery. We are also highlighting the impact of fruitless and wasteful expenditure. And most of this fruitless, what we noted is instances where they did not settle the invoices on time. So some of these invoices sitting in the 17 billion column, because they are not settled on time, service providers then start charging interest on that balance. And unfortunately, it then sort of puts the sector in a worse position, because then they need to settle their interest. So in the year under review, we saw that there was around 782 million of balance of fruitless and wasteful. The message we are communicating on this slide, Honorable Chair, is the fact that the health sector is really struggling with finances. And we do understand that when the moment the sector struggles with finances, it has a direct impact on the services that they need to render. And we've seen instances where the health sector is forced to reprioritize some of the services they are rendering because of the budget constraints. The next slide reflects the irregular expenditure within the sector. Honorable Chair, because there was a lot of data that we put together from the sector, in the current year, we did not put through the slides that talks to the compliance. But when we really reflect on the audit reports of the sector, there is still a lot of provinces that are struggling with compliance findings around procurement and contract management. Unfortunately, those findings then triggers the irregular expenditure. So even though the amount we are seeing in the current year seems to be lower than the prior year, we are also noting the fact that there was some areas where we were not satisfied with the completeness of the balance. There were also some limitations with the procurement itself. So we are not sure if those procurements that were not submitted, whether they would have irregular expenditure or not. There were also some instances where the irregular expenditure was still under assessment. So what we are then communicating here, we're saying, even though it seems like the sector reduced annual expenditure, with the outstanding matters, their number could actually be higher. I'm going to move to what we call material irregularities, which talks to the slide that Mule presented around enforcement. So in instances when we are auditing and we note some non-compliance or a loss to the state, we do raise what we call material irregularities. So the purpose of material irregularity in the main is to ensure that when we do raise this material irregularities, the accounting officers, they need to implement implement controls to then improve the control environment so that the material irregularities do not continue occurring. The other impact that we would want to see is for the accounting officer to investigate and then hold people accountable that actually caused the material irregularity. The last part, if there was a loss, we then expect the accounting officer to recover the loss. So that is mainly the three things that we want to see when we raise material irregularities. So in this slide, Honorable Chair, we just highlighted the material irregularities in the sector as reported currently in their audit reports. And unfortunately, we still have a high number of material irregularities in the sector. We do know that there is work that the accounting officers are doing on the background. As you can see in this presentation, there are some that are getting resolved. And resolved means that when we were then evaluating what the accounting officer has done on the ground, we were happy that they were able to improve the control environment to prevent the loss from occurring. And in some instances, we were happy that they were able to hold people accountable, and in other instances, recover the losses. So the message we then give the sector is the fact that they need to ensure that the control environment is improved to prevent the material irregularity from occurring. So there's a lot of details, Honorable Chair, around the material irregularity process, but today I just wanted to present a highlight. As the Office of the AGSA, we are available if the committee wants to then engage further on the material irregularity processes. However, what we have observed in this process is that sometimes the material irregularities continues because management is not swift in implementing consequence management, and therefore there's a need for management to swiftly implement consequence management whenever there's either irregular fruit loss or any non-compliance that's being identified. We also have noted the fact that some of these material irregularities, we refer them to investigating bodies because some of them has an element of fraud. But what we have observed from the Office of the AGSA is that some of these investigating bodies takes longer in investigating, and then the process then takes longer to close. But I think from our side, Honorable Chair, the message to the committee is to continue engaging with the sector so that these material irregularities are addressed and the environment is improved to prevent it from occurring again. So I am then going to the key messages for the current year. So over the years in the sector, over and above the work that we do on the financial statements, on the annual performance report, as well as on the compliance area, we also look at key service delivery areas. And our purpose of looking at key service delivery areas is looking at in areas where we can partner and work with the sector to see where they can then improve the service delivery or the lived realities of the citizens. This talks to, if we go back to our accountability ecosystem, the insight elements that we then indicated, where we then look at other areas. So in the current year, when we were looking at the areas we're going to focus on, our drive really became to look at what is happening currently in the health sector. And I think this is what Andres was indicating earlier around the conversation around NHI. We understand that this is where the sector is going, and then we were looking for opportunities to be able to assist the sector while they are waiting for the rest of the process to take place. Where can they be looking at to correct the system so that if we are to implement, or when we implement NHI, the systems are ready. So in the current year, one of the focus areas we look at the resourcing of the primary healthcare facilities. And it's because we do understand that the primary healthcare facilities plays a significant role in the whole health sector system. Our starting point, Honorable Chair and members, was the MTSF, because a lot of the things and a lot of focus that we do in the AGSA, we start at the MTSF, because we do believe that this is the document that government has put together and have set targets to be able to achieve their mandate. So in the MTSF, we noted that there is an indicator around the ideal clinic realization maintenance program. The indicator had a target that by 2024, 100% of the primary healthcare facilities should have attained or maintained an ideal clinic status. So that then became our genesis of the focus area for the current year. When we then reflect on what's sitting currently in the annual performance report of the sector, is the fact that the sector is currently sitting at 59%, which shows that they are not yet at the target that they want to achieve in the current year. And we did highlight some of the red flags the sector to say if they really want to get to the 100%, they really need to put effort onto them primary health facilities that are still struggling to attain or maintain the other clinic status. So we also then highlight the fact that they only have 1 year to go, and they really need to put a lot of work if they want to still achieve their 2024 targets. On the right on the slide, we are highlighting some of the targets that the different provinces had set for themselves in the current year around the addiction status. We do note that some provinces had set a cumulative target and some provinces had set an annual target. That's why it seems like it's different. But at the end of the day, the sector was setting targets to be able to achieve the overall a target. What we are noting, the fact that where we are sitting, the impact of these clinics not then achieving the other clinic status, if we are to implement NHI, they then won't be accredited by the OHSC for NHI purposes. We then look at some of the details or try to unpack the status that we are seeing. So we then perform specific procedures to really see what is really happening on the ground. And we're very specific in our approach. We intentionally selected clinics that previously did not achieve a DINCLI status. And this was us trying to partner with the sector to say, what are the issues on the ground? And sort of at the end of the day, give recommendations to the sector or what needs to be changed. We were very also specific on only looking at the 3 components because we did note the fact that the Addictions program has a lot of items in there. So we then only focused on the medicines and supplies, the human resource and the infrastructure, including medical equipment and basic services. And then because we do understand that there is the non-negotiable vital elements and vital elements in those areas. So our observations from the work that was done on the 27 clinics that we visited, I will not talk to each and every point here, but I'll just maybe elevate 1 or 2. The observation we had is of the 24 clinics we visited, some clinics were still struggling with determining the stock levels from a pharmaceutical point of view. And these are the areas that we do understand the fact that if they are not determining stock levels, there is a chance that when the patients come through to these facilities and they need pharmaceuticals, they will not be able to then get the medicine, and therefore the service that's being rendered by the sector will not be complete. We also saw some instances where the clinics did not have hand hygiene, and we do know the impact of not having proper hand hygiene on the ripple effect from a communicable disease, because it then increases the risk. And then we also saw some instances where clinics do not have maintenance schedules. And we have an example, for example, when you get there and there's a fire extinguisher, but the fire extinguisher has not been maintained in a while. So I think the message we're then communicating is saying, if a fire is to break out in that facility, we don't know if the fire extinguisher will be working. And for us, it's also then one of the risks. And it's also one of the areas that's been highlighted by the adult clinics problem itself. One that we are going to highlight that was under the non-negotiable is the fact that at 18 of these clinics, we noted that they were not restoring the emergency trolley after daily or after use. And we do understand the impact of the emergency trolley being restored is in case a patient that has emergency walks through, they need to be able to swiftly attend to that patient. So these are some of the observations that we found in the clinics that we visited. There are also some of the good things that we saw that they got right when we were visiting, and I'm only going to maybe talk to two around the oxygen levels and the availability of oxygen. So we do commend the sector that from that specific area, all the clinics that we visited actually had oxygen levels, oxygen cylinders that have a pressure gauge that is available, as well as they also have the oxygen levels were at a minimum. We also saw in some of these clinics, even though it was not all of them, but a lot of them had functional sewage system. And we do say on the remaining that don't have, the message is to make sure that they are then able to correct that. So when I look at the root causes, Honorable Chair and members, I won't go through all of this also because of time, but we wanted to highlight some of the root causes around the HR, where we are around the human resources, where we are noting that there are some of these facilities where there is poor daily disciplines by some managers and healthcare workers, and even those that are not adhering to the daily disciplines, some of these managers are not then holding them accountable or instilling that culture. So there's a need for an improvement in that area. We also saw that there are some facilities where they were operating with vacancies, and we do know that the moment they have vacancies, the available healthcare workers are then expected to do maybe sometimes 2 or 3 people's jobs, and therefore things tend to go wrong if they are then spread too thin. We also saw in instances where the organograms are outdated, and therefore when the facility is operating, there is been a growing population, and therefore, even if sometimes they have money to be able to appoint someone, if the organogram is not aligned, they are then unable to appoint someone, or they need to really go through a process of getting that being updated. The one area that I'm going to highlight in this slide is around the finances, which talks to the slide that I was speaking to when we were talking about the fact that the sector is struggling from a financial point of view. Unfortunately, there were some facilities that were indicating that they are unable to do some of these things because of the challenges with the finances, whether it's finances from an HR perspective or from an infrastructure perspective, where they are not able to maintain some of these things. And we are then also saying to the sector that they need to relook at how they are then allocating and reprioritizing their funds so that they are able to support this program. So the recommendations that we gave them, I'm also not going to go through a lot, but I think what we're then saying is for every, for them to be able to improve the quality in these facilities, they need to develop a quality improvement plan and implement it, and they must continue to create and instill a culture of accountability and strong work ethic. And in instances where they need support from either the provincial level, they need to really get that support from a provincial level to ensure that these facilities are able to get back on track and ensure that we have clinics that actually meet the ideal clean status. We also look at what is the possible ripple effect when the clinics are like this. And one of the lived realities that I've already highlighted when I was presenting the observation is the fact that in the absence of medicine, some patients are asked to come back on a later date, or they are then asked to go to another facility to get the medicines that they require. We are saying that sometimes creates an unnecessary financial burden to the people in that area, but also can also have an impact of prolonged recovery. We are also highlighting the fact that where there's broken equipment, it means that a thorough examination cannot be done, and therefore the citizens and patients cannot get the full service that they require. Over and above that, we are then saying the poor healthcare that can take place at the facility could lead to a loss of lives or the lengthy recovery and periods and additional complications. The ripple effect that we are seeing is the fact that in instances where the clinics are not functioning optimally due to the areas that we have highlighted, it does have an overall negative impact on the healthcare and service delivery. We have seen, I think, in some of the instances where some of these patients then reroute to the hospitals to get the service delivery that they want. And unfortunately, we are saying this could lead to overcrowding at the hospitals and additional burden on the hospitals and the employees. And given the patient load at these hospitals, it could possibly then lead to maybe an increase in medical legal claims, because the limited number of staff is then seeing a whole lot of more patients than they were actually meant to see, because the primary healthcare facility is not functioning properly. And we are also then once again highlighting the fact that it is critical that the adult clinic status is achieved, so that should NHI be implemented, they will be able to be accredited with the OHSC. We are also giving just a reflection, Honorable Chair, on the medical legal claims. We did present this in the prior year, but this is just an update from what we did in the prior year. And the part that we're bringing on the link was around the fact that we do know that on the MTSF, there was a target that was set by the sector. This target was based on a baseline that was determined in 2018 of 70 billion. So the sector had targeted that by 2024, they would really want to see the medical legal claims balance at under 18 billion. Unfortunately, with the observations that we've made and we've discussed over the previous years, this balance has not been reduced. We have seen a change in the balances in the prior year. I do note, Honorable Chair, we had reported about 125 billion, but with the work that the sector is doing in unpacking some of these claims and the work that they've been working with the service providers that were appointed at NDOH, they are realizing that some of these claims are not valid. And with that work
work that they are doing, they are also trying to then correct the balance that they've been reporting over the years. And so far, as at 31 March 2023, excluding the Limpopo audit that's not done, the balances were sitting at approximately 67 billion. It is still far off from the 18 billion that the sector has set, and this is because over the years, the medical legal claims balance had changed significantly from the 70 billion that they set themselves in as a 2018 baseline. So therefore, the sector, it seems like the sector is far from achieving their 2024 balance, but we do take note of some of the efforts the sector is trying to do to address the challenges with the medical legal claims. This slide just shows the ripple effect of the claims. I'm not going to talk about the balance, but I'm also going to talk about the actual payments of the claims. And this links to the slide that I presented around unpaid invoices. So we're seeing in the current year that the sector paid approximately 2.6 billion on medical legal claims. And our message still remains the same, that this is money that could have been rerouted to service delivery, but unfortunately, it's then also going to medical legal claims payments. And there's a need for the sector to continue its efforts in trying to deal with the challenges that they face on medical legal claims. The last section that I'm going to cover, honorable and members, is around infrastructure. So I'm going to only highlight one part of the infrastructure, also given the time. But one of the things, and the reason I'm going to do that is because over the years, we've been reporting on infrastructure. Every year, honorable chair and members, we come to this committee and we raise challenges in the infrastructure. We raise challenges around the quality of the infrastructure we are seeing, as well as the cost escalation we are seeing. So in the current year, we still did some work on the infrastructure. This slide just shows the scope, and we were still looking at the 4 stages of the infrastructure delivery, being the planning phase, the project implementation, the project management, as well as the commissioning. For the purpose of today, we are going to elevate messages around the project management that effectively then impacts the delayed projects. So from this sample that we're looking at, 69% of these projects had findings on delays. And we are then unpacking the fact that when a project is delayed, it has a ripple effect on the service delivery in the area. Because when the sector was deciding to either refurbish or construct these projects, they were addressing a specific need in that area. So the moment there's a delay in finalizing this project, it then has a ripple effect on the citizens in the area, and they are then either forced to then travel longer kilometers just to try to get service delivery. So on the right, we are highlighting of the samples that we had, the projects delay in months. And I think we are then seeing in this picture, there's some projects that have been delayed up to 80 months completion, and then some of them, they seem like it was 4 months, but a lot of them are also still delayed with a lot of months. And I think from our side, we are saying this is a delay in service delivery. The key message that we are then highlighting from the infrastructure point of view, it's also still similar to some of the key messages we've been putting or raising in the portfolio committee, that there is when we look at from the planning stage, for some of these projects, there's inadequate need assessment and project planning. And therefore, when they then start to implement the project, then they then are faced with challenges. In other instances, there is ineffective monitoring of project milestones. And therefore, when they are not monitoring the project, when they're not monitoring the professional services, the contractors on the ground, unfortunately, it then results in sometimes extension in time and variation orders. So it's critical that there is close monitoring on these projects. We've also seen instances where some projects were fine and they were commissioned. However, after commissioning, the projects were not utilized. I think there was one of the examples we had even in my MI slide about one of the clinics. So what we are then saying is in the planning phase, something was not done properly, and therefore it seems like the area or management was not ready to commission that facility, even though the facility is finalized, and therefore it then results in either underutilization or delay on utilization of these facilities. So we've seen a few, and we are also then raising to say management needs to ensure that they are ready for these facilities when they are commissioned. I think the other area that we want to highlight is the fact that with the action plans that we have they've been put together on the table, sometimes they don't really adhere to them, or sometimes they're inadequate. So in the recommendation, honorable chair members, I won't go through each and every point, but what we wanted to highlight in this message, the fact that it is critical that at the planning stage, there is proper analysis and the project is clearly defined, documented and approved. And all the role players within the project are also consulted, because we do know that in some instances, the projects are delayed because either there were an unrest or a resistance in the community, or sometimes as they were starting the construction, they then found out that there was something wrong with the area they're going to construct. All these things fits the fact that the planning needs to be done accurately. The planning needs to be done correctly to ensure the fact that the project is going to be a success. I've already highlighted the fact that with the project implementation, they need to be able to manage this project as and when it's unfolding. And in instances where there's variation orders and extension of time requests, they need to really have an adjudication committee that really assess the reasons why the service providers are asking for variation order or an extension, and make sure that in instances where they need to hold people accountable, they implement penalties to these contractors if they are not adhering to the timelines. So in conclusion, honorable chair and honorable members, I'm not going to go on a reflection of what we had recommended in the prior, because my colleague did highlight some of this, and I have also highlighted some of this progress through the presentation. But the message that we are really bringing to the committee is the fact that we are seeing the fact that there still need to be an effective implementation of action plans. When we try to unpack what really is the cause, for every finding that we raise, honorable chair and honorable members, there is a recommendation. There's also an action plan, which is a commitment by management to implement. That action plan is drafted by management, and they also give themselves a timeline. So there's a need for them to really ensure the fact that they stick to the action plans, and instances where the action plan is no longer addressing the need, they revise and then they the action plan. So our message to the committee is to request regular feedback on the progress of these action plans and the commitments that the management and leadership make in this committee. We do understand that in so many instances, we do meet with management and the leadership, and the committee also meets with the accounting officers. In those meetings, commitments are then made by the accounting officer. So the message to the committee is there need to be an effective tracking of the commitments that are made by either accounting officers and executive authorities in these platforms. We are also then saying in the process of requesting these updates, also request management to prioritize some of these investigations. We have seen on instances that when there's a delay in consequence management, unfortunately, certain things are actually going wrong on the ground. So there's a need for them to deal with this swiftly. We have also seen when we engaged, we also then recommended to the committee to say, in collaboration with the NCOP and any other oversight bodies, that the committee must closely monitor the areas that are contributing to the funds being depleted in the sector, because we did see the fact that there's so many things that are putting pressure on the sector, from the funds on the funds available for the sector itself. And also the community must then engage with the sector leadership on their plans they have in place to turn around the situation that they have, whether it's from a service delivery point of view or from a financial management point of view. Because we do know that if we are able to do our part, which goes back to the accountability ecosystem, if all of us, whether it's the leadership side, whether it's the accounting officer side, as well as the AGS and the committee, we still really do believe that if all of us do our roles, we really want to see, and we are positive that we'll be able to see a change in the sector and a move in the right direction. That is it from my side, Honorable Chair. I'm then going to hand back to you. Thank you.
Thank you very much to all of you for the presentations. I must say that it is quite a bit that has just been presented. And I was asking myself that in the 5 years that I've listened to the AG, is this the most thorough presentation that we've had, or is it the most thought-provoking, or is it the more action-provoking? What is different about what we've just heard here today? Honorable Sukus, I'm going to complete what I am saying now before I will take your hand. So, I think what has happened is that in the past 5 years, of course, all of us had grown very strongly in our understanding of what is presented to us, what is expected of us, what is expected of what we expect from the department and the sectors, and that we've all grown to understand better this thing called annual reports and financial statements and being able to interact with those things. And so I think I want to express a gratitude to the AG for this presentation, because surely what we are here for is to be able to, at a very high level, entertain the challenges which are raised and to be able to hold those who are responsible for whatever, for the department, the sectors, the entities, etc. For us to be able to hold them to account to the level that is expected of us to do. So in terms of that, there are so many things which were raised by the AG today, and there are just too many, but I would want to say that in the past year or two, we have been placing more and more emphasis on some of the issues which are being raised by the AG here today, including infrastructure, medical legal claims, services to the people, getting services for every rand that had been, every rand in terms of the grants which are given to the department and the sectors. Fruitless and wasteful expenditure, irregular expenditure. These are the things which we have been talking about for a number of years, and many other things. And I've got a long list of things which we could possibly go through. But just for myself, before I give the other members an opportunity, I thought I needed to raise this, because then I also need to speak about these things. And it starts with the financials. The fact that adjustments need to be made, there are material misstatements, or there are mistakes in that which is presented to the AG, and then there needs to be adjustments made. And after the adjustments, then some of the entities receive unqualified audits or unqualified audits with just misstatements, etc. I think that's something that really needs to be worked on, so that we are able to present to the AG any material that would allow all our department and our entities and our sectors to be able to receive unqualified or clean audits for that matter. The other one, of course, is on the irregular expenditure, where one sees this challenge of it being raised in prior years, and we're still at that point where NHLS is still has been asked, and we've done that in our discussions with NHLS, to complete the condonement. I mean, 4 billion rand being requested to complete condonement. CMS still talking about an investigation in progress, and the NDOH still not following up on the consequence management. So those things, that's, and I've got a couple of these things very quickly which I want to talk to. Contingent liabilities. We've been talking about this for a very long time, and surely these are things which can be addressed. Limpopo not signing off on the financial statements. Northern Cape, I am of the view that we need an intervention in Northern Cape. The department needs to make an intervention and ought to be able to either take Northern Cape under administration or urgently do something to ensure that services are delivered to the people in the Northern Cape. Accruals, payables, 19% of every rand, of every 100 rand, 19 rand of every 100 rand goes to paying interest to other people. So 19 rand of every 100 rand is lost to the system, apart from the other monies which are also lost in the system. So eventually, very little is available for services deliveries. And I like what you said about the root causes. So the question I'm asking is, how do you get people to change the way in which they do things if it is really has to do with the person who has to deliver a particular job or do a particular or has a particular role in terms of their own discipline, self-discipline, discipline within the organization, discipline within the leadership, vacant posts, not performing training for those whom we employ and make sure that they're able to implement what is required of them to implement. Accruals and payables, 17 billion rand borrowed from the previous year, for example. That is a lot of money. So we've come from oversight in the Eastern Cape earlier this year or late last year, and we've seen the damage that this does to provinces. When money that you're budgeting for the new year, you have to use to pay old debt. And surely there must be a point, and we talk in medicine, we say, if somebody has gangrene in the foot, you cut off the gangrene part, but you also cut off a part of the good part of the foot so that you're able to stop the rot right there. You're able to stop this thing from progressing past the good tissues, and then you're able to put some recovery in place. And those are the questions we have to really ask. What is it that we should be doing to be able to address these things? Claims against the department, 75% of budget. 75 rand out of every 100 rand. That is really serious. And so, members, I'm trying to provoke you that when we talk and when you do raise points in this discussion today, that we really speak to solutions. The question is, how must these things be improved? What is it that must be done? How do we hold everybody accountable? And that should be the emphasis of our discussion, because we have a responsibility as much as the department has a responsibility to all of these things. So I will in the end also ask a few questions, but I needed to say that we as a portfolio committee must really center ourselves in terms of our interaction with, for example, the presentations which we will be receiving over the next couple of days on the budget review process. Thank you. So I'm going to take hands. I'm taking hands, honorable members. Lengwa is first. Sukers. Kaba, Van Staden, Clark, Tembakwayo, Morowane, Yiklen, North Nagel, Gela, Harvard, and then myself. I'm going to repeat. It is Lengwa, Sukers, Kaba, Van Staden, Clark, Tembakwayo, Morowane, Yiklen, North Nagel, Gela, Harvard, in that order. Please note your position in that order, honorable members, so that we flow, have a nice fluid discussion, and I don't have to call somebody. Thank you.
Thank you very much, Chair. Let me welcome the presentation. It was a very informative presentation, and yes. My question is that what budgetary and accountability measures can be implemented to curb the ever-increasing expense that is medical claims? Because what I have on my hand is a client that have waiting for 6 months in the discovery medical aid and no medication. That client have a cancer, but he didn't get the medication because there is no payment to this discovery medical aid. Now, that's why I'm using the measures that will be implemented in this medical aid, or whosoever who did not pay the medical aid. Thank you.
Thank you, Chair. Chair, with your permission, I'll leave my video off, just because my internet, I think, is not that strong. My battery is a bit flat. Firstly, I think, Chair, the difference is that it is action provoking. It certainly provided us with a good outlay in terms of responsibility and the need for action. The presentation that was done by the AG, and I want to say thank you for a comprehensive presentation that at the same time speaks to the committee for our role in ensuring that service delivery happened, because all the other technical issues in the end is reflected on the ground. I don't have a lot of questions. I think I would just add comments. Chair, you mentioned that we should be solutions driven, and I think most likely what you're saying is let's have a discussion, let's have it differently by really engaging the presentation. I think in the last 4 years, one of the key things that we've highlighted, and certainly I have highlighted consistently, is the issue around the capacity of the department to implement and to manage strategic procurement. And it is a very important element to ensure that your objectives are met, especially when it comes to issues of services, the procuring of it, and especially with your capital projects as well. It's exactly the same in terms of how you acquire services and how you manage once you have gone into contract with service providers on high value projects, how you manage that. And we have seen in this department as across government that there is an incapacity to not only contract manage, but also to strategically procure. And it is an issue that has been raised within this committee over and over again. And the answers, the question when we talk about solutions is, the state needs to change the way they answer Parliament. We have a death by PowerPoint. It is as if officials come to this committee or committees in general, and they come with presentations that either confuses members because, first of all, we are representatives of the people. These are not experts, but they certainly have enough intelligence, and all of members that sits in Parliament, I would certainly say, has enough intelligence to understand concepts. But we don't ask these departments to really present to us in terms of impact of their programs. We don't. It's one of the key things that we as Parliament must change. We have to change how officials come to committees and how they present. The reason why there's no consequence management is because within the state, there is a lack of performance management with objectives in mind. I mean, the state is one of the biggest in terms of numbers. It is the biggest business there is, if I can use it like that. But it has the most inadequate processes, systems, and in terms of people management processes. And it will not change. We're going to have this conversation until the cows come home in committees. It's never going to change. So the first solution is Parliament must demand that departments come to committees and that they present outcomes-based presentations so that we know. In terms of the Northern Cape, Chair, it has a dire impact. Ek wil dit in Afrikaans sê. Daar's mense wat nie gesofistikeerd genoeg is
om 'n medical claim teen hierdie departemente te bring nie. In my constituency, I have people who died because an ambulance doesn't pick them up in the Northern Cape. Not one, not two, not three. 4 different cases in one area. That is service delivery. Then you have people celebrating a premier because hulle het nou meer ambulances gekry. This is the type of stuff that is not high level. We are now at the basic level celebrating stuff that is supposed to be a given. The Northern Cape needs an intervention and it needs it urgently. And Parliament have to demand that. I want to ask the AG the question. The lack of internal controls and the reviews and lack of oversight by leadership to ensure that systems internal controls critically required are implemented. If they could just tell us who's the leadership that they're referring to, is this in general, in terms of the committee itself as well, but if they can identify and at what level. Then in slide 10, there is limitation in auditing procurement. What is the reason for those limitations? If the root causes, as the chair has mentioned, there's a delay in projects. I don't know if the AG provides us with that, or most likely if we can get before we meet with the department, which projects, where those delayed projects are, and across, so that we have a full list of the projects, the amount or the value of these projects, and in which areas they are. And that is it, Chair. Thank you.
Yeah, thank you, Chair. Chair, indeed, I must indicate this had been one of the longest presentation, and it is indeed welcomed. Chair, I think rather than maybe as per previous speaker, but I must mention that out of the presentation, there are positives, though I will be ending up with questions I would like to throw. I think the department received an unqualified audit with findings, which is an improvement from the qualified with findings the year prior to the review. The department prevented irregular and fruitless expenditure in the current year. Overall, Chair, there was an improvement in the sector due to National Department of Health and KZN addressing pro-year qualifications and obtaining unqualified opinions. Even though, Chair, we know that there is no improvement to the audit outcomes for Eastern Cape, Free State, and Northern Cape. The department undertook actions on consequence management. That is welcome, Chair. Chair, maybe if I may go to my questions to indicate the following. What are the implications of the weakness in the Eastern Cape's inability to determine the measurement of contingent liabilities due to poor records disabling reconciliation? What financial risk and service delivery risk that can be incurred due to such a problem of such management control? That will be one question I would like the AG to be answering on. Secondly, Chair, what are the implications of the weakness of the Free State limitations experienced during the audit in immovable assets, goods and services? And what financial risk and service delivery risk can be created by such management controls weakness? You see, the issue of financial risk and service delivery risk becomes key for AG to deal and control with. My last few questions, Chair, as I conclude, will be what are the key factors and enablers of clinics having met standards such as oxygen availability, waste matters, ventilation, and storage, which are critical for a health facility and health of patients? What lessons can be learned from these areas to strengthen other elements of services? Chair, what is the level of capability and capacity of project planning and implementation management capabilities? Noting that 69% of 35 projects audited had findings on delays and 40% had build quality findings. Though that will be my questions, Chair, as I submit. Thank you.
Thank you, Honourable Chairperson. Honourable Chairperson, I want to thank the Auditor General for bringing this report in front of us today. I am of opinion, if we want to know the truth, what is going on in the different departments, provincial department, finances, bring the Auditor General to this meeting. It's very disturbing news we have received today. As you have said, Chairperson, these are matters we have been fighting about and talking about for the past 4 years, and the matter is just getting worse and worse and worse every year, and something needs to be done to solve these problems urgently and a very fast rate, because we saw during our oversight visits what this problems is escalating to what we have seen today and we have heard over the past 4 years, and we see the effect it has on service delivery and the danger it has to patients' lives, which is in our state and provincial hospital. So we as a committee need to urgently, Chairperson, the provinces must appear in front of this committee for the consequences and to take responsibility for the matter in which these provinces have fallen into. Because I can remember only one time that some of the provinces have appeared in front of this committee, and that was during the COVID-19 period when there was problems with the government procurement in certain provinces. But never in these 4 years, the provinces has come to take responsibility for what is happening in the different health departments. Now we see today things that the Auditor General have come to present to us that there's no improvements to audit outcomes for the Eastern Cape, Free State, Northern Cape for 4 consecutive years. This is totally unacceptable. We have material misstatements identified for Gauteng, Mpumalanga, and Northwest. This is unacceptable. We can't continue like this. Critical positions not filled timelessly with the right skills. The lack of internal controls, lack of oversight. This is totally unacceptable. We cannot continue like this. Medical legal claims, which was last year at 125 billion, is standing now at 67 billion. The matter just not getting resolved. We must urgently intervene here and resolve those matters. And then I'm getting worried when I see on slide 12 for Mpumalanga, fictitious, or you can say fabricated payments for infrastructure maintenance budget, the Free State payments made for work not performed, Eastern Cape invoices not paid in 30 days, Northwest prices paid for medical equipment which is not market related. And these are the perfect examples what is we saw every day when we go to oversight visits, not only with this committee, by ourselves also as members of parliament, of what is happening on ground level. When will this matters going to be stopped? When will this matters be addressed? And I said to you now, Honourable Chairperson, it's time that provinces come in front of this committee as soon as possible to take responsibility for these actions. We cannot continue on the path we're continuing now like we have done the past 4 years. Thank you, Chairperson.
Thank you, Chairperson. I could not say it better than what Member van Staden has said. I do believe that we need to develop a strategy in this committee to get each and every province and to come and account to this committee, because we are never going to deal with the issues we've seen today in this report. And I thank the AG for this report, because it's really, I mean, last year we did not get a detailed report like we did this time round. And I thank you for that report, because it really, once again, confirms that no matter what is within that report, it's the same issues year on year and nothing changes. I also would like to, first of all, I also have to say to you, Chairperson, I've dealt with a lot of issues in terms of the NHLS, and the NHLS is very problematic. There's a lot of stuff happening there that is not above board. And then also the MTSF targets that are not possible to track. Could the AG just please explain that that issue? Because I'd like to understand that. You know, and not just the provinces, but all the departments. I mean, the NDOH not delivering of quality primary healthcare is very concerning. Ideal clinics outcomes, medical legal claims, and can we once again get these advocates that are busy dealing with these medical claims that told us we're having such great outcomes at the Presidential Health Summit, come and give us a report on that. I mean, 8 provinces are, have delays on case management systems. I mean, this is just not on. The digital systems that is not being achieved in terms of streamlining medical legal claims and also case management in terms of the healthcare systems. 4 years of irregular expenditure and procurement. And the top contributors of that is the NHLS, the NDOH, and the CMS. You know, we need, and really, for me, we need to get every one of these issues actually unpacked in a report so that we have every detail, not just a broad spectrum detail, but every detail of what's going on in each of these departments, and have those criteria as well as for the provinces so that we can actually do our jobs properly in terms of oversight. Because if we don't do that, we won't have the necessary equipment to put these guys on the spot and say, these are the recommendations we make to you as the committee, as Parliament, and you're going to be called back if you don't achieve these things. You know, and I agree with you. The Northern Cape is a massive problem and should be put under administration. 17% of the Northern Cape comply to ideal clinics. The Eastern Cape 25%, Limpopo 23%. I mean, it's ridiculous. And then, of course, you know, as we always talk about, the medical legal claims that need to be dealt with. So I really feel, you know, what is justified for us is for each one of these sectors to be unpacked, detailed, and we probably need to have a workshop for 2 or 3 days together with each of these departments and the provinces in order to deal with the massive issues that has been presented to us today, because I can assure you 1 day is not going to work. We're really going to have to do that, Chairperson, to make a difference in our healthcare systems. Thank you.
Is it my turn?
It's your turn.
Thank you very much, Chairperson. I just would like by stating that a lot of the points that I was going to speak on has already been touched on by the Chairperson of the committee. But nevertheless, I just want to say, in all this, say for an example, the poor quality of performance report, where no clear definition of indicators are reflected, we also find the National Department of Health being part of the entities that have a problem also. And my question is, if NDOH is found also having some problems, who is going to guide who, and who is supposed to be the best performer in this one? And it's happening every year. Every year when the AG is reporting to us, NDOH is also included in those that do not perform well. And to say, I'm very much surprised under the recommendations that are done, the recommendations given by the AG, to say there is no way where they state that personnel who are found not to be doing well should be removed from their position. Every time we are talking about monitoring and evaluation and so on, but there is none of the strict measures which mentions the removal of the personnel. I think we have to move along those lines, because we can't have the very same report that is presented here. The same applies to the repeated findings of the quality of the financial statements. Obviously, it talks to the personnel that are doing this. So I definitely think we have to remove this redundant people here that are not doing the right thing. I didn't hear about the staff that are in hospital or in clinics that are suffering from job burnout. I mean, the status of certain clinics where you find some nurses sitting without attending to the patients for the whole day, which obviously means they have a problem. And we haven't had such a report being reflected to us. And what is it that is supposed to be done to help them so that they can be able to work well and enjoy the work that they are doing? And when it comes to, there's a repetition of the call for the provinces to come and account towards the report of the AG. But what I can say is that what we have observed is that the province will get the report, and when they come to report to us, they will come and tell us about what they did to change the whole situation, and which is not true. And the reason why I'm saying that is that each and every year, there are numerous problems that are reported to us from the AG, but they will come to us and tell us lie, all these provinces, and nothing is done, including the NTOH. So we need to move to stricter consequence management in connection with those that are not performing. Thank you.
Honorable Morawane.
Oh, thank you very much, Chair. I was just thinking that is it my turn. And also thanks for the presentation that has been presented from the AG. I've got only two questions, Honorable Chairperson. The first question is with regard to what, in relation to the Northern Cape, what consequence management interventions will be appropriate for the non-implementation of the audit plan, and what are the critical root causes the audit action plan responded to, and what financial and service delivery risk do they have? The second question that I have, Chair, regarding the duty of the accounting officers with reference to the PFMA, what are the implications of the failure to implement the audit plan? Thank you, Chairperson. Those are my two questions.
Thank you, Chairperson. My questions are, as I'm new to the committee, I'm saddened to hear that these have been going on for so long. And thank you to the Auditor General for this very comprehensive briefing. What is being done to address the recommendations that are made and not adhered to, such as maladministration and material findings? One of the statements that I found the most alarming is that the auditees cannot continue to see the Eastern Cape, the Free State, and the Northern Cape continuing as a going concern. What is being done to address that? This has been going on for 5 years now. That concerns me immeasurably. And like the previous Honourable Member Morawane said, what is the consequence management that is going to be meted out to accounting officers suspected of or found to be involved in maladministration? What is being done to encourage people to be involved in revenue management and collection? I agree with all the other members, Honourables Van Staden and Honourable Clark, who have said that the time has come for the provinces to come before the Portfolio Committee in a workshop and actually answer these questions. Because if we are looking at the fact that only 59% of facilities meet the ideal clinics standards, and there is such a push to implement NHI, it's not going to be possible, because one of the prerequisites for NHI, amongst other things, other than the fact that South Africa is broke and we can't afford it, is that you have to comply with ideal clinic standards. And if only 59% of the facilities are even scratching the surface of adhering to ideal clinics, it's not going to be possible. And my last comment is a comment, is not a query. If we do not address the problems that are leading to medico-legal claims, that is going to be the final straw that is going to break this camel's back. I'll leave it there. Thank you so much, Chair.
Thank you, Comrade Chair. And I just would like to say thank you for a very thorough presentation. I was very impressed with that. I've got 3 questions. My first question will be the following. Noting that the Free State received no material findings on its reported predetermined objectives, which is positive, what measures were undertaken to improve the management of reporting information? My second question, in relation to the fact that 40% of departments not being able to provide supporting evidence for the material and significant reported performance information, and 30% have material findings, what implications will this have on the quality of expenditure? And what is the state of compliance with management controls? And then my last question will be the following. What is the level of contract management and compliance within the departments? And what contractual provisions should be included to protect public funds and to ensure quality expenditure? Thank you, Chair.
Thank you very much, Chair. Let me also join my colleagues by welcoming the 2 comprehensive presentation from AG. Chair, indeed, you have said mouthfully, and I fully support your proposal, Chairperson and Comrade and Honorable Club and other colleagues that spoke before me, Chairperson. Chair, I'm having a few questions that I want to raise sharply, so Chairperson. And I think the issue of consequence management is being touched. I'm not going to repeat. We need also to go and do oversight in Northern Cape and see actually what we can do as a portfolio committee in terms of assisting the Northern Cape province. Chair, my question to the AG, is there a vacancy rate linked to the budget limitation, and what prolongs a recruitment process? 2, what was the extent of the late payment to suppliers, and are the cases of payment beyond the 30 days standard? The other one, Chair, is that what implications does the 19% expenditure accrual have on the financial capacity of the department to optimize an appropriation? My last question, Chairperson, to AG, are there non-compliance of the NDOH, CMS, SAHPRA, and NHLS repetitive from the previous audits And if yes, were adequate measures implemented in the action plan? Thank you very much, Chairperson.
Thank you very much, Honorable Chair. Welcome the two comprehensive representation from AG. That is very impressed. The first question I have, what are the key drivers of success in the improvement of the KwaZulu-Natal for producing good quality financial reports? Second question, what is the extent of the use of consulting companies for accounting services in the different provinces? Thank you, Chair.
Thank you, honorable members, for those questions. We are now running late. So we will have to take the answers from the AG. And I still have a few things to mention. I just want to state that what I have raised and am raising is because we have a responsibility to do the right thing. But I also have a second responsibility, which is that as a medically trained person. And I certainly have that towards the people of South Africa, that we should be able to deliver the best services that we possibly can in every facet of our lives and people's lives. So that we should not use as a portfolio committee anything that is said for any kind of politicking. I said earlier that we should look at the solutions that we should be able to offer. And some of you have offered some solutions. For example, let us interrogate what is happening in the sectors, in the provinces, etc. I think also what you're asking for is a lot of time for this portfolio committee to take a lot of time, find the time and do this kind of work. But when we meet as a portfolio committee, some of you tend to delay us by bringing unnecessary politicking into the discussions. So yes, it's a political discussion. One can view that as a political discussion, or one can view this as an opportunity for all of us to find solutions to the challenges which exist in our country. And it is not particular to our country. It is where the world is going. The world is having challenges generally, and we should be more matured or able to provide the solutions and discussions at a matured level and not make this about party politics. So I am not talking party politics when I talk about what I am talking about. So basically, a few things still, questions I want to ask. The one has to do with a very critical point that was raised by Tabelo, and that was the one on, for every finding and action plan is developed by the accounting structures. The point is that the plans are often not implemented or not seen through to its finalization. My view is that the largest challenge is funds, and somebody would say, no, it's not funds, but it's funds in the sense that we've shown that not all of the money that is provided to provinces, whether these are conditional grants or not, is really used for the services because it's eaten up by other things, like accruals, payables, unpaid invoices, delayed infrastructure with interest payments, etc., medical legal claims, other things. That's where this portfolio committee must rise up to the occasion when we discuss at that higher level of engagement. So I raised this point of 75% of claims against the department. The question is, what is the financial, the AG can maybe answer this question. What financial risk does it cause? And has the AG ascertained the reliability and appropriateness of the claim values? And is it in a position to be able to do that? And if yes, and it hasn't done so, whether they can look at it and maybe come back to this portfolio committee through the committee secretary for my attention. There are also good news. We must not forget there's a lot of good news. The department is trying under very difficult fiscal constraints in the world, in South Africa, And everybody, I would think, is trying to do their best. Yet, all that is required is a bit of assistance from us. So irregular expenditure, for example, has declined from 9.4 billion rand to 7 billion rand, which is an improvement. But how much of this is related to material irregularities? And what is the progress of the material irregularities in the various provinces? And then finally, I want to talk about the critical areas of concern, which was raised about the PFMA. And surely it in itself, that decision in itself by the National Treasury poses a lot of challenges for departments itself to keep track of what is happening for us as portfolio committees, for National Parliament, for the departments themselves, for the AG itself. And I agree with the approach that was taken by the AG that they will continue to look at the irregular, fruitless and wasteful expenditure in the annual reports versus what is then put into the financial statements. And I think it is important for those historical balances to not be completely removed from these annual financial statements, because there is no way that one would be able to remember, say next year there's a new portfolio committee and wouldn't have, apart from our legacy report, have an idea of what was contained previously and where money is really getting lost in the system. What are the implications? So what implications does this Treasury note have on the ability of entities to table credible financial statements for financing? And what impact can the Treasury note have on the credibility of financial statements disclosure and the principle of transparency and public accountability? And then what is the recommendation of the Auditor General in relation to Treasury Note Instruction number 4 and its potential effects? So I think that has brought us, honorable members, to the end of the question session and the points for clarity and discussion matters we wanted to raise. With the AG, we will go straight over to the answers or responses from the AG. We would have to go until the AG had completed its responses. I'm not going to cut them short. So if it does mean that we're going to have our lunch on the go, that is what we would do. Thank you very much. Over to you, whoever needs to respond, Tabelo and the rest, and Andres and Bule from the AG side. Thank you.
Thank you so much, Honorable Chair and honorable members, for the questions. So what is nice about this is when I started with the introduction, I did say that I'm here with my team, and some of these questions they will then assist me in answering, especially some of them that might be specific to an area that they were then looking at. I think from the start, we appreciate the questions and the engagement by the committee, and I think we really appreciate the feedback that the committee found the presentation very action provoking or thought provoking, and we really, from our side, we really aim to always improve on how we communicate our messages, to ensure that we lend the messages that is going to empower the committee as they then perform their oversight duties. So we really are appreciative if we were able to achieve that today. So there were some questions and some comments in between, and some of them were interlinked. So I'll try by all means I'll have to answer them in a haphazard manner, so I won't be able to follow the way the members were asking. But like I said, my colleagues were on the call. If I did miss a question, I think they must just be preparing themselves to then assess some of the question. I'll start with the question around the recommendations that we have and around leadership. So from our side, when we give recommendations, we start with the leadership within the management, with the department itself, which then becomes the accounting officer and his team, the senior management within the departments. If we'd recall, in the presentation on the accountability ecosystem, we were very specific around the role of the senior managers and also the role of the accounting officer supported by the Internal Audit and Audit Committee. So when we refer to management or senior management interchangeably, we really are referring to the DG and his team in implementing the controls, because the DG has the accounting officer has the ultimate responsibility, according to the PFMA, for ensuring that there is a development and implementation of a control environment that is going to align with the financial management. So all our recommendation around implementation of controls are internal, and those are the recommendations we give to the accounting officer and his team throughout the audit. And some of these recommendations, they do come through as and when we raise a finding. I did give an indication that for every finding that we raise before it's elevated this platform, we communicate the finding to the relevant official within the department, and it also then goes with the recommendations. And then when they respond themselves at the department, they do indicate this is that they agree with the finding and what caused the finding, and these are the action plans they will implement to correct the situation. So those, I think it then talks to the point when we were saying that over the years, we've always had responses from accounting officer and his team around the findings we are raising, and every time in every finding, there is an action plan that they have then indicated. And this is where, when we are reflecting on what might be going wrong, we do then reflect that they need to maybe reassess the action plans that they have put in place, that maybe they are not addressing the real root cause of the findings we are raising. And hence our recommendation to the committee that there need to be a tracking of this action plan. If we are seeing repeated findings, it could be an indication that the action plans that they are developing are not addressing the core issue or the real issue that the department that is happening. Or so usually it's twofold. It's either they are not implementing the action plan, or either even though when they're trying to implement what they've committed, it can be an issue that the action plans was not adequate enough to deal with the real root causes of what caused it. So we've always in our communication said to the department, you need to really get to the real root cause of why the departments find themselves in this place. So those are the leaderships that we are referring to and the action plans that we are then referring to. So with regard to the limitation on the auditing of procurement, so as part of the audit process, we then send a request for information from a contract basis, and then would have selected maybe 3 contracts, and then would have asked them to be submitted to us. So where we say limitations, these are instances where the information is not sent back to us for various reasons. Sometimes you find the fact that they're saying that contract maybe is sitting, especially when they have contracts with other service providers or other entities like SETA, maybe they say the contract is not yet back from SETA, it has been signed. Or some instances we do have seen somewhere there's either something happened, there was a damage that happened to the documents, whether it was fire or something like that. The situations depend on each province and on each sample that we select. But what we then say from our side, it's a limitation, because I am seeing that there was a procurement on the a procurement register, but when I'm asking for supporting documentary for that, I'm unable to receive it. And therefore, at that point in time, I'm unable as an auditor to conclude whether the proper procurement process was followed and whether there was or wasn't any irregular expenditure. So that's what the limitations then mean. There was an issue, the request around the list of projects that were delayed. From the office of the AGSA, we only audit on a sample, and hence on the presentation we saw 35, and only from the 35 there was I think it's 69% that was delayed. The department would have the full list of the projects that are delayed because they also keep a register. So our recommendation from our side is, if the committee wants a full detailed list of all projects that are delayed, the complete list would then be with the department, and the committee could then take that question to the department so they can get a comprehensive list of the projects that were delayed. There was a question around the implication of some of the limitations or the findings we have been putting on the table. And these talk to the implications of the limitations in, for example, the annual performance report, as well as the financial statements. So the impact of the limitations, as I try to unpack it on the procurement, is if we are, and so our role as the Office of the AGSA is to provide assurance to the committee and the public at large of whatever the sector, the departments have reported, whether they are reporting it in their annual financial statements or they are reporting it in the annual performance report as an achievement. So our role is to be able to say to the public, when they read the balances that has been disclosed or the achievement that have been disclosed, we are giving an assurance of whether that balance is valid, accurate, and complete. So when we are limited as the Office of the AGSA to make that opinion, what then means that then we cannot give their assurance on whether whatever they are then reporting is valid, accurate, and complete. And the impact on the limitation, if I talk to the annual performance report, which we tried to unpack it, I'm trying to get to the actual slide, unpack it on the sector slide. I think it was slide 7. The impact on the limitations within the annual performance report is that if the sector is reporting an amount and they are working towards a specific target, however, we are unable to give assurance on that number. So basically the number that is going to eventually be used in the reporting, it could, maybe it's not accurate and maybe it's not correct. I think we've seen instances where in the same slides we have also demonstrated the example of where there is no credible performance information, the sector is unable to respond to the real service delivery. So the moment there are gaps in the information being reported, the moment the information being reported is not agreeing to information on the ground, as and when a service delivery is about to be rendered, there are gaps. We see this, for example, even in the pharmaceutical industry. So when there is no reporting information on whether there is sufficient stock at the given point in time when the sector is about to render a service, complete a service through giving the patient pharmaceuticals, they will then find themselves not having those medicines on the shelves. And this would be because there was no processes to ensure that they close the gaps on some of the limitations that we are raising. So those are some of the information. And from a financial statement point of view as well, if I look at the implication of the contingent liability, I think I'm going to link it to the question that the chair raised around if we audit that. So ours, so the standards, the accounting standards are very clear on how the departments must account for contingent liabilities. The understanding is the fact that at a given point in time, the departments don't know whether that claim is going to actually result in an actual payment. So the standard allows the departments to estimate based on prior experiences on the probability or the how much that they're going to pay out for each claim. For example, if there is a trend that for every claim that they get, they only get to pay out only 50% of that claim. So the standard allows their department to then unpack all the claims they are receiving and then only disclose the 50% in their financial statements, as long as they are able to disclose the assumptions they used to for that amount. And on our side, when we come as the Office of the AGSA, we then audit those estimates and assumptions of the department. And when we are comfortable that they are supported by evidence, we then are able to accept some of the findings, some of the amounts that have been disclosed. So that's why, Honorable Chair and members, if we recall, in the past years, we were qualifying the contingent liability balance because we were not satisfied with the process the sector was undertaking to ensure that the amount of the contingent liability is a reasonable amount based on the experiences. But we have seen that when the sector went back and unpacked some of these claims and looked at the historical trends, they were able to make adjustment to some amounts. And it then links to the question around Eastern Cape, that Eastern Cape really struggled to get to that estimated amount. When we were then unpacking to try to understand the reconciliations of the amount, they were unable to do that. And the impact of that is if they are unable to estimate how much they would possibly pay out as a department, they are unable to plan, because this is then the overall impacts becomes the slide that we presented around the ripple effect of the payouts of them of the claims themselves. We have highlighted previously that some of these provinces are able to even budget for the payout of the claims, because they would have made an assessment and estimated how much could possibly go into claims, payments of claims, and they will then make a provision in their budget. So if that number is not correct, if they're struggling to get the contingent liability numbers, it does have a ripple effect from a budgeting point of view as well, because they will not be able to estimate how much they could pay out from claims. And that is then the ripple effect that we are seeing of some of the limitations that we see in the system. I am going to then look at there was also a question around our recommendation on why are we not very specific on the fact that when the officials are found guilty, maybe they must be let go. We do understand that whenever there's an investigation, there's a full employee relation process that gets that kicks in, and the department themselves would then follow an investigation, and depending on the outcome of the investigation, the recommendations, the department then is the one with the final decision on what happens to those officials. I think on our side, we keep encouraging that there must be swift consequence management. I think throughout from our engagement, we have seen some provinces giving feedback that some of these employees are getting warning letters, and some of these employees that let go. It's just that it's usually not, we can't then come and say this must be the recommendations. The accounting officer, after doing the investigation and going through a whole employee relation process, and we do know that sometimes it takes long because at some point it's a legal process, and that's why some of these officials either go on suspension or some of them are even reinstated depending on the outcome of the case. There was also a question around highlighting of the burnouts in the clinic staff. I think we did indicate, and we highlighted it as a ripple effect of the possible burnout. I think it was on the slide in one that we and some of the slides, which is at 19, where we're talking about the fact that when some of these recruitments are not made on time, and the current officials have to now do a number of roles, there is currently an impact on how on themselves, and then that's why we also then indicate the fact that there's additional burden on the hospitals and the employees. There was also a question around what happens now if the recommendations are not implemented. So the effect of recommendations not being implemented is really the picture that we're presenting today. If the recommendations that we've been giving to the management are not being implemented, unfortunately, the audit outcomes remains the way we say it. And unfortunately, also, it does have a ripple effect on the service delivery itself. So in instances where some of the non-implementation of the recommendations does meet the definition of a material irregularities, we do then raise a material irregularity. And if we can recap on the process of the material irregularity, it's an enforcement tool that we then use to then say to the accounting officer, this is what needs to be done to be able to deal with the matters. And instances where the accounting officer is not taking into account our recommendations, we then move to the step where we then issue specific instructions to the accounting officers to then implement specific recommendations. So far, the slides around the material irregularities that are presented, those are examples of where we had to then use enforcement, where the matters that were being raised were then not addressed by the accounting officers, and therefore we took it a step further of enforcing to ensure that the accounting officers actually implement the recommendations that we have given. So on I think the part on the implementation of the findings, implication of the findings I've covered. I'm trying to check my list, Honorable Chair, to say if I didn't miss anything, because some of them I did lump them together. There was a question around the extent of the late payments to suppliers. I'm not sure if the question was around the NDOH and or the sector, but from the NDOH, unfortunately, in the current year, they actually had a lot of those, and hence we reported a material non-compliance findings because we did observe the fact that they did not settle a lot of the invoices on time, and therefore that then triggered the finding. From the sector perspective, when you look at the compliance findings that unfortunately I didn't include in the presentation, there's a lot of some of them that actually are also sitting with the finding, and that's why the impact of the late payments becomes the fruitless and wasteful expenditure that we see that the sector is incurring because they are not settling the invoices on time. So there was also a question on the impact around the implication of the 9% that we had included on the slides for the available funds. So the exercise that we did, Honorable Chair and members, what we are saying is there were funds that were allocated for a specific year, which is 22-23. And in that funds, the expectation is that the funds is available for service delivery for the 22-23 financial year. And the process that would have been followed is the sector would have submitted a request for budget to Treasury, linking it to the different indicators and targets, and they would then receive an allocation. So what then happens is, because of the financial constraints that the sector have, mainly because of the prior invoices, they sometimes then don't settle invoices by year end. And when they don't settle those invoices by year end, it then means that when the new year starts, before they can even start requesting service delivery from some of the service providers, those service providers request the payment of their funds. And that's why we are then saying then that 17 billion, which is unpaid invoices, it's already putting the sector at a back foot, because come 1 April 2024, when they receive a new allocation, they need to first settle those old invoices. I think the Honorable Chair called it the old debt. And therefore, you are then depleting the available money for that year. So we are then saying, if it's 92 billion available for that year, and the first month of April you settle 17 billion, the difference is what is remaining for the sector for that year to render services. And that's what we are saying. It is putting then the pressure, because the sector will now have to reprioritize some of the services, because the amount that they hope that they will receive is now reduced by old debt. And that is what we are talking about. The implication of that is the fact that some service delivery options will have to be set aside, and so that they are able to first settle the old debt and then move on into the new year. If I have missed any other points, my colleagues will help me, but I wanted to also hand over to Mareka to then respond to the question around the key enablers with the feedback that we presented on the idle clinics. And then Nancy can then also respond to the question on the infrastructure. The rest of them, my colleagues can then indicate if I missed something. Over to you, Mareka, with your permission, Chair.
Thank you, Tabelo. Good afternoon, Honourable Chair and Honourable Members. Thank you, Honourable Ntlantla, for the question where you were asking how is it that certain elements can be in place, like the oxygen is available, the sewage systems are well, and there's waste bins in place. But then for the other elements, the clinics are struggling so much in terms of how to get it right. And what is the key enablers to get the other things right? And some of the findings is that they do not determine the minimum and the maximum stock levels, or the temperature control is not in place for the medicines, or the backup generators that is not in place, or the emergency trolleys that is not restored after every use or on a daily basis. And what we realized during the audit is, in terms of the key enablers, is that in the healthcare system, and specifically on primary healthcare level, that policies and procedures are in place, and specifically with regards to the ideal clinics, The National Department has done so much to issue manuals, procedures, and checklists to really help the people and the clinic managers in the clinics to go through those checklists and make sure that all these things are in place. And then it goes back to the daily disciplines. There's a specific person, there's roles and responsibilities that specific person need to do their job. And it's also important what some of the other honorable members indicated, poor performance management. Are these things included in their performance contracts? And then the operational managers or the clinic managers, do they hold the people accountable for their daily roles and responsibilities? So that is quite important. Key enabler, doing the basic things every day. If you need to do a stock count, do it. If you need to determine minimum and maximum stock levels, temperature control, complete the temperature control sheet. If you need backup electricity, request for a generator, and they have policies and procedures for all these things in place. So it's just the important part is to actually do it, and then for somebody to supervise and oversee that it's actually done. Also, in terms of the ideal clinics on a district and a sub-district level, they are doing the ideal clinic improvement plans. And it's quite well compiled. And even at all 27 clinics that we visited, these ideal clinic improvement plans were there. So all the problems was identified, and the district and the sub-district offices knows about it. The problem comes in with regards to the implementation thereof, and then again, oversight and management to make sure that those plans are implemented. Thank you, Tabelo.
Thank you, Marika. Nancy, I hope you're still on the call.
Thank you, Tabelo. Thank you, Honorable Chair and the members. I noted a question. I can't recall which honorable member asked the question, but it was more information with regard to the delayed projects. So I wanted to indicate that on the slide that is part of the presentation, is actually slide number 27. There is information as to which project are delayed, and we've also indicated the number of months those projects have been delayed by. And then on the same slide, it also shows the names of the province. So the information is already there. And then with regard to the amounts, we do have a list or a table that shows those projects together with the project costs as well as the expenditure spent to date for those delayed projects. And then there was also another question with regard to the quality of the findings. And I think it's what my colleague Tabelo has touched on in terms of the root causes. The fact that there are no controls in place to ensure that quality arrangements or quality inspections as and when these projects are in progress are not being implemented. You find that in most of these projects, the quality issues are actually identified at the end, where now the contractor will be given a snack list and then they will have to go back and rectify these defects that have been noted. Or when we do the audit, that's when we pick them up and highlight them to management, and only then management is aware of this quality deficiencies. So in a nutshell, I can say there are no adequate controls in place to ensure that the projects are monitored and supervised to pick up the quality deficiencies as and when the contractor is on site so that they are addressed immediately. I don't recall any other question on infrastructure, but please, Chair, you may remind me if I missed any other question. Thank you.
Thank you, Nancy and Marika, for that. Chair, I did see that I had missed. I think there were two questions from your side. You asked a question around the status of the material irregularity. The slide that we presented on the screen. These are the material irregularities that were still in progress. So we were accounting officers were still implementing some of the recommendations. However, on the slide as well, on the list, we have indicated the ones that were resolved. So which means that at that point in time, the audit team was happy that the accounting officer has implemented the required controls. However, Honorable Chair, we are available because the MIs are a lot. We are available if the chair wants us to then maybe make a submission on the status of the material irregularities that are included on the slide for the consumption of the committee. There was also a question around the irregular expenditure framework. So the irregular expenditure framework, if I can summarize its impact, is the fact that previously we would see the historical balances on the notes of the financial statements, and our audit, because we cover annual financial statements, it then meant that automatically it forms part of the audit process, and then we would then audit whether that balance that they are disclosing is valid, accurate, and complete. So the impact of them this balance now moving into other parts of the annual report, it means that they no longer form part of the annual financial statements, and therefore they no longer necessarily form part of our audit. So when we give an opinion on financial statements, it does not include historical balances of irregular expenditure. And therefore, that's why we are saying we are unable to give any assurance on the historical balance of irregular expenditure. However, since they are still including the current year movement, which is, for example, what we've been presenting in, if I look at the second slide, slide 10, they will still report the movement in the financial statements with the comparative, and that's the balance that we would then audit and then express an opinion on. So we have engaged. I do know that when the framework was released, there was engagements with our technical team, with the National Treasury on its impact, and hence from our side as the Office of the AGSA, the way we continue to track from a historical balance point of view is consequence management. So on our side, what we can still do is to check that any irregular expenditure that is sitting on the balance is actually investigated and is consequence management implemented. So that's as far as we can. We just can't give an opinion on whether that overall balance is valid, accurate, and complete. So that is the impact then of the irregular expenditure framework. I think I know Mule also has a hand. I'm going to allow her to then take maybe the questions that she noted that I missed. Over to you, Mule.
Thank you so much, Tabelo, for that. There was a question on the use of consultants and from Honorable Harvard, and on that question, there was no use of consultants on the portfolio as well as the sector. Then the other question that was raised, it was what is Free State doing different in terms of the predetermined objectives, why they managed last year, they had material issues, and then in the current year, they don't have a lot of issues. So we went back to the audit team and we just asked for what did they do different, what really transpired that caused the upward movement in terms of the audit outcomes relating to PDO. And we found that there were district-wide workshops that were performed by the auditee, which included the health professional as well. And there was also this workshop, it also gave the people that were working on the ground in terms of their effects, say how does their daily checks and balances, their daily work affect and translates on a high level? How is it reported in the financial statements? And they also workshop them on the importance of keeping the accurate records. They took the audit plan, they discussed it with the hospitals as well as the district hospitals so that they implement the whole plan, not just limited to the high level provincial department, but brought it down to the users, to the people that are actually doing the initial capturing of the information, doing the checks and balances. And they also mentioned that there's an active chief director for monitoring, and that they do physically attend the meetings, and they do those workshops, which then assisted in terms of improving the audit outcomes. There was a question again relating to SAHPRA on terms of the revenue management. And in this question that was raised, it was indicated that on this one, what was not done, it's the sending out of
adequate communication was not done with the debtors. So the recommendation was that they need to revise the policy in terms to be specific in terms of the services that have been provided on credit, and then formally issuing out invoices and statements on time so that the customers are well aware of what they are owing. And so in terms of how they responded to the actual audit finding, they have now prepared the post-audit action plan, which would then need to monitor as we go into this current year audit cycle. So I will just pause there for now, relating to the questions that were raised. Thank you, Chair. Thank you, Mole. I think these are the questions that we were able to capture. If we did miss a question, Honorable Chair and the members, we can maybe be reminded, but that's what we could capture. Back to you, Honorable Chair.
Thank you very much, Kabelo, Mule, everyone, your whole team. It's been an insightful morning. Thank you very much for the presentation. As I said, food for thought, action-provoking. But just to be reminded that everything that we discuss when we talk about social cluster is that whatever we do has an influence on the lives of individuals, communities, and indeed an entire country, as we had seen with COVID. So we appreciate this, and I'm sure as a committee we'll be able to engage more thoroughly with all the other presentations we are about to receive this week. I think with that having been said, I'll just give an opportunity maybe for 30 seconds. You want to say anything? And then I will give the way forward.
I'm sorry, Honorable Chair, I couldn't hear you clearly. Please repeat your last statement.
I thought you might want to just make a closing statement, and then I will give the way forward to the committee for the rest of the afternoon.
Thank you, Chair. I think that's it from my side, Honorable Chair. And once again, to the Honorable Chair and the members, we highly, highly appreciate this engagement. And from our side, we really wanted to be able to lend the messages to empower the committee as you discharge your duties. And if we were able to do that, I think from our side, it's a positive. And thank you so much for this. And also, we are available for the committee, Honorable Chair, and the members. We always say this at the end of our presentation that we don't want to only see the committee during BRRR, but if there's any given point in time, the committee really wants to engage us on a matter, we are available. We keep that door open, and would also then be able to engage, and we'll also maybe be able to bring our colleagues from the provinces that are able to then give the detail of what's happening on the province. Thank you so much, Honorable Chair and members.
Thank you very much. Of course, we would come if you provide the scones and the tea. There might be a special event. But yeah, that's on a lighter note. Just a little joke. So just to remind you, yes, we'd be happy to receive those submissions on the status of the irregular expenditure and other requests we had made. Thank you very much. You're welcome to leave after this. I'm sure you have a lot of other work to do. And then I will tell the members what else we're doing for the afternoon. So, honorable members, thank you. I've requested SAHPRA to come at 14:30 already earlier, because I'm sure you would want to have at least a short break at this point in time, and I'm sure we'll even make up the time as we go along today. But just to remind you,
excuse me, Chairperson, when is our lunch time? I don't think 30 minutes is enough. We need a longer period of an hour, please.
Well, you have 30 minutes plus 2. That's a joke on the Temple Choir. I'm not sure whether we'd be able to really push it too far. And what I mean by that, I'm sure a lot of others have responsibilities, including SAHPRA. Let me hear what the members say. For me, 30 minutes are adequate. And other members?
I suggest an hour, please. Thank you.
I will not be able to push this to an hour, Honorable Chamber Choir. I give you 40 minutes. We will start at 22 exactly.
Make it 45.
Please don't switch off your devices, 40 minutes. Don't switch off your devices so that you don't struggle to log in again. Enjoy your lunch. Thank you. See you later. Ms. Majalamba, if you can just inform SAHPRA that we will start at 22. Thank you. start in about 2 minutes with the rest of our program for today. We're going to check if you are all here, honorable members. Thank you, Honorable President, for acknowledging all of the rest of you here. Honorable Biela, Honorable Tembakwayo, are you here? Honorables, all of you, not Narple.
Yes,
go
I'm
down
here.
the list. Thank you.
I'm here,
Alma.
Chair.
Thank you. Clark, Lengua, Raba, all right, it is now 20 minutes to 3. We said we'd start at 3 o'clock, so I'll do the introductions. Honorable members, I've just had news of a family member who's been involved in an accident. So I'm going to allow for the introductions, start the meeting, or the continuation of the meeting, and then I will ask Honorable Gela to continue with this meeting. So please excuse me, I will log off after I had done the introductions, and we'll see each other tomorrow again. So Honorable Gela, if you'd be able to do that, just give me an indication, and then I will ensure that I at least ask Professor Helen Rees and CEO Dr. Boitumelo Semete to introduce the rest of the team. Thank you, Honorable Gela. To introduce the rest of the team, and I hope you will have a good meeting. Over to you, Professor Helen Rees.
Thank you very much. Can you hear me okay?
I hear you very well, thank you.
Good. And can you see me? Because it looked a bit blurred from my side.
I think it is blurred, yes.
Yes. So I'm in Senegal.
Something to do with your screen.
Yeah, I'm in Senegal, and it might be a bandwidth problem. So if I'll talk now, but then I'll close my video. So thank you very much. And thank you very much, Honorable Dr. Jacobs and colleagues. We very much look forward to this discussion. As we've discussed before, SAHPRA continues to grow in strength, and this is in the context of drug regulatory authorities being seen as increasingly important. I'm at a scientific meeting here in Senegal, which is hosted jointly with by the president of Senegal and the government of Senegal. And what's clear for our region is that there are going to be huge and rapid demands for regulatory authorities, which we already know about, but are going to grow in importance. And in particular, for example, regulators in the future are going to have to think about things such as artificial intelligence, which will be used for many of the products, one way or another, that we will be looking to register. But Dr. Semete will present that. We've got a few colleagues. Unfortunately, we didn't give many of the board members were unable to attend, but we promised to give feedback. But we have Dr. Mandisa Skosana on the call. We have Advocate Hasina Kasim, I'm just looking down. I think, did I say Kalani? Sorry, this is jumping a bit. We have Professor Patrick Demana. Yes, we have Dr. Kalani Ngobesi as well. Yes. Have I missed anybody? Because I'm afraid my screen is jumping a bit. Is anyone else from the board who I can introduce?
Prof, is it Annie here? I'm also here. Thank you.
Excellent. So that's Mr. Itani Mashau. Thank you very much. And you've got Itani as the chair of the technical committee for SAHPRA. And we've also got amongst the colleagues, Klani is responsible for the governance, Hasina for legal, so we have a variety of contributions and expert skills. With that, I'll ask Tumi Smith.
Mandisa is also here.
Who is that?
Mandisa.
Oh, I introduced you, Mandisa. Sorry, I think I introduced you. No, I would never forget. Thank you. Yes, and both Mandisa and Patrick, who I've introduced, are both active members of board committees as well. So thank you very much. I don't think I've forgotten anyone else. I'm sorry for the quality of the video. I'll turn off now, and I'm going to hand over to Dr. Smeti. Thank you.
Thank you very much, Prof. Rees. Good afternoon, honorable members of the Portfolio Committee. Dr. Jacobs, thank you very much for having us this afternoon. From the executive's perspective, I'm joined by our CFO, Mr. Rehat Khos, as well as our board secretary, Advocate Mpo, who I think will be joining soon. We've got quite a number of engagements taking place. Some of our executives are unfortunately in a change management workshop that we're having with our staff. And so we will represent them, and I hope we will do a good job of that. Just to add that we have the deputy board chair, who has also just joined, Dr. Obakeng Kaole. She just joined now. Thank you so much. I'm going to share my slides. I trust that you can see them.
Yes, thank you.
Thank you. Thank you. I'm going to switch off my video also. Okay. So thank you very much, Gay. So I'll give, today we will be providing feedback on our performance for the last financial year, which was 2022-2023. In this presentation, I will briefly touch on our vision, mission, and values. I'll talk around the environment wherein we were operating in the last year, and then we'll touch on the performance of the organization, as well as matters pertaining to human resource. And then I will hand over to the CFO to address the financial information. 2022-23 was quite an exciting year for us, as we were established as a Schedule 3A entity in 2017. There are a number of elements that we worked very hard over the last few years to achieve, and we're quite thrilled with the performance that the organization has had in the year 2020-22-23. I'll highlight just these three as we start off. Firstly is that for the second time now, in the 5 years that we have been established as a 3A entity, we managed to again receive an unqualified audit opinion from the AGSA, maintaining our status of 2021 and 2022. Secondly, in the year in discussion today, we also achieved a maturity level 3, which is a benchmarking conducted by the WHO, wherein they assess regulators across the world, and I'll speak to it in a bit of detail just now. And then also that we were able to finally clear the backlog of applications that we had inherited from the Medicines Control Council. Just as a reminder, and this is, three elements that we reflect on quite a lot in the organization, our vision, which is that we are agile as a regulator. We're a responsive African regulator, also that is globally recognized. And when we look at what we've been able to achieve in terms of our continental presence and participation, the global recognition that we've been able to sustain since the days of the MCC, and our responsiveness during COVID, it says we're really living true to this vision. Our mission, which is core to what we do, is that we promote access to quality, safe, and effective health products for both the animal and the veterinary sector. Even as we're speaking now, wherein we're dealing with the avian influenza, we've been in many engagements with the Department of Agriculture, Rural Development and Land Reform under Act 36, wherein we've been in discussions with them and working together with them around the vaccines that are currently in development for the strains of the avian influenza. Our values, again, we continue to reflect on these as an organization. As I've already alluded to this, the year at hand was our 5th year of operating as a Schedule 3A public entity. The last 3 years have been very challenging, considering that we had to operate as this newly established entity under the COVID-19 pandemic, wherein we needed to support the national efforts. And I do believe that the SAHPRA team did very well in that. And last financial year, we started to see the numbers of the, infected individuals, the hospitalization reducing quite a lot. We're still not out of the red. We continue to receive applications for COVID products, and we evaluated as much as now a decision has been made that it's no longer a public health emergency. We've learned a lot of lessons during the COVID period, and we're bringing those into how we operate. And also, as we focus on the priority areas being HIV, TB, malaria, and oncology, we continue to reflect on how can we bring some of our successes and operational efficiencies during COVID into these areas that are priority. I've already alluded to the ML3. So WHO has 4 levels of maturity for that they apply to regulators. Level 1 being that you do not have any formal approaches in how you work. There's some element of regulatory systems that exist. However, there's a lot of development that's required. 3, which is where we are, and many regulators are there. It means that you are a stable, well-functioning, and you have an integrated regulatory system. And this is really where many regulators aim to be. And SAHPRA is one of the 5 African countries that is at ML3 for vaccines. We now, in November, we will be undergoing an assessment again by the WHO for medicines. And we hope that we will be among the first to have ML3 for both medicines and vaccines. Egypt is pushing quite strongly as they also have ML3 for vaccines and are also working towards ML3 for medicines. ML4 is what we all are working towards, and there's very few regulators across the world that are ML4. And one regulator that is currently ML4 is Singapore, and we know that it's one of the very strong regulators, and we have a partnership with them. And then the other regulators, such as Swissmedic in Switzerland, soon they will have their outcome, but because they're well-resourced, and a number of us rely on them, they come out at a status of what they call a WHO-listed authority. But that's what we're working towards. In terms of the environment that we're working in, we thought we will just highlight these 3 kind of buckets of areas. Firstly, the area of medical devices is an area that we have prioritized going forward. Again, we saw the effort that we had to put in place to support during the pandemic, the approvals of in vitro diagnostic tests for COVID, and we continue to assess those tests. At the moment, we are licensing manufacturers of medical devices and IVDs. And this year we started with renewals, as these licenses are valid for 5 years. So we started licensing in 2017. Secondly, within this area, at the time that we're reporting in, we had approved 4 self-test kits for COVID-19, which are currently available in the market. We've also, through engagements that we're having with the NICD and the NHLS, we have verified that these test kits that we have in the country continue to detect even the newest Omicron variants, the XBB variant. So we know that they remain to be sensitive and specific. Clinical trials is an important area, and we continue to improve our timeframes within the area of clinical trial protocol assessment. An area that is a big priority for us, and some of you that may have seen Carte Blanche on Sunday, you would probably ask us some questions around that. But the issue of vigilance, pharmacovigilance, and post-market surveillance is critical. And this is one area where we're undercapacitated in SAHPRA. And yet this is the area that I do foresee that in the immediate future, there's going to be a lot of demand on the regulator to do more in this area. We need to ensure that we assess products that are already in the market to ensure that they're not substandard, nor are they falsified. If they are, we then have to act. And we've been working very closely with the police services around this. Secondly, we need to make sure from a vigilance perspective that there's reporting and we act on any vigilance reported. We prioritize the COVID vaccines, but now that the numbers have reduced quite significantly, we are expanding our vigilance effort into all other therapeutic areas. And very important in executing our mandate, the regulatory space is a very litigious environment. So we continue to ensure that we operate within our mandate. Yes, we will always be challenged, but so far we've been successful in a number of cases, even those that pertain to COVID. This is our board. Some of the board members, as indicated on the call this afternoon. Furthermore, on the organization environment, just 3 points I would like to highlight. The first being the matter of having the right skills and having those right skills in the required capacity. When we look at the complexity of health products that are being developed, when we look at our efforts to increase our work in regulatory compliance from a post-market surveillance and a vigilance perspective, we are certainly undercapacitated. The support from the National Department of Health and National Treasury, this is one ask that we would like to make from Parliament to say, SAHPRA is a relatively new entity. As you've seen, we're only about 5 years old as a standalone 3A entity. And so we continue to require support from the department and National Treasury financially. We've just experienced the budget cuts, and it has had a significant impact on our operations, but also it will have an impact on our ability to deliver on some of our targets and on our mandate. And so we continuously ask that, considering the work that we do, that at some point, we'll be shielded so that we can ensure that this new entity can at least be adequately capacitated and be able to fully stand on its own. That said, we also need support, not only for human resource, but also for our digitization efforts. We have to ensure that we digitize our entire environment, and this project has gone a lot slower than we had anticipated. So being able to have the right talent, to be able to retain that talent in this very competitive space, And again, as we do while as SAHPRA, even other regulators outside the country, WHO and other regulators, they do engage our staff, and at times they would consider appointing them in their respective organizations. So it is really a battle for talent, and we try our utmost to retain our staff. We will not be able to deliver on what we've been able to so far without partnerships. These are critical to us as SAHPRA. On the African continent, we are very active participants, and I chair the African Medicine Regulatory Harmonization Initiative, which really will be the foundation of the African Medicines Agency. And I understand there's very good progress in terms of the AMA Treaty. And, you know, this is an area that, again, we would like to continue to ask for support. I understand that there's questions around some of the contributions from the various member states. And just to say that this, like many other treaties, there is a requirement as per the Conference of State Parties that will then set the annual contributions by each member state. And the intention is that these annual contributions by each member state, they go into supporting making AMA operational. And there will be benefits to us participating in AMA, in that when a medicine has a recommendation from AMA, by the time we receive it as SAHPRA, it will reduce the assessment time quite significantly, because we will only look at local requirements. So we will be able to rely on the decisions made within AMA. Secondly, from an industry perspective, when our local industry that we see is really growing, they're entering into some exciting partnerships. When they then have their products recognized by AMA, it will ensure that they can access many more markets. So there is benefit in South Africa signing and ratifying the AMA Treaty from a regulatory stance, but also from access to medicines and from an industry perspective. Secondly, there are global corporations that we're active participants in, because again, as we said in our vision, we want to ensure that we are aligned with global standards, with best practices, so that when SAHPRA makes a regulatory decision, other regulators can rely on that, and it should not take long to approve products that are SAHPRA approved. Two of those are the ICH, which is for International Harmonization Standards, as well as the IMDRF, which supports the area of medical devices. Locally, we also continue to work with other regulators, such as SANAS, such as the HPCSA, the Pharmacy Council, because again, we all are operating in this space. And I must say, we've had very, very good partnerships with all these local stakeholders. Again, as I made reference to codeine, the work around there, we work very closely with the Pharmacy Council. And actually, we have a meeting tomorrow with industry, really to work together as stakeholders and other regulators to say, how do we address this issue of the abuse of some of these products in our markets? Communication with the public is critical. We saw the importance thereof as during COVID. We continue with these efforts to work with various media houses to ensure that we adequately communicate specific regulatory matters, and that we educate the public on SAHPRA. So just to get then into the performance, I'm going to quickly move through this. We managed to achieve 63% of our targets in the 2022-23 financial year. And I'm going to do a bit of a deep dive very quickly here from a program one, which is our leadership and support. So that's the administrative part of the organization. Finance, we managed to meet our targets then. ICT, again, we've applied a lot of ICT tools to ensure that we can communicate with the patients, with the healthcare professionals, but also to try build systems that are seamless to interface with as industry and the healthcare professionals applied to SAHPRA. One platform that we implemented, and we've received a lot of comments from the public, very positive feedback, is the over-the-counter digital database, so that when someone needs to find a package insert or professional information leaflet, they're able to go onto this directory and they can find it from there, very easy, accessible, and be able to read through those. From a communication, I've already touched on some of these. We worked really hard to ensure that we communicate who we are, what it is that we do, and to communicate elements around vigilance. We've been engaging a lot also with universities, because again, that's entities wherein we can attract talent, and also we can set up partnerships for continuous development of our staff. And we communicate, as I've said, through various media organizations, and even internally. Matters of wellness are also a priority for us. We have had feedback from our staff, some of them struggling with mental wellness matters, and so we have ICAS available to our staff, and there's a lot of awareness in that area. Furthermore, from a resource perspective, it's been a tough year for us, particularly with the budget cuts, in that we were able to fill vacancies, but wherein we were not able to due to some of the cuts that we are experiencing, and also just being underfunded. We've been fortunate and to be able to secure funding from entities such as the Global Fund that then supplemented the funding that we've had. We've gone out even more this year to seek funding from these philanthropic organizations. From an employee equity perspective, we put together a plan and that was submitted, and I'll share some of our numbers in terms of the staff profile. I'm not going to go into too much detail on the targets that we have met. Overall, we've met all our financial targets, and as indicated, we're really very excited about that. In the second year in a row, we received an unqualified audit opinion. From a communication perspective, we did a survey, and we continue to address the feedback from that survey, and again, we met our targets here. Even from a change management perspective, we managed to meet our targets. The areas that we struggled with are on the workplace skills plan. We were not successful in implementing all the training initiatives that we had in our workplace skills plan, but we do believe that this year we have made very good progress. I have mentioned that we had a very low success in filling some of the positions for two reasons. Firstly, the SAHPRA salaries are low when you compare to the market that we're attracting. And so we will be conducting a benchmarking exercise. And the other reason is because, again, of the limited funding that we have, there are instances where we're not able to fill all the roles that we would like to. And so hence we've gone out to raise funding. But one of the major issues is just the salary ranges that we have that don't enable us to attract top talent. On digitization, again, I did indicate that we did have some delays there, but this year we are making very good progress. So at that point, we did not manage to have the enterprise architecture approved. It's now been approved. We've procured the RIMS system, which is a regulatory information management system, and it's really supposed to bring everything together, and it's also interoperable with some of the systems that we have and enable us to be fully digital. So we do hope that in the next 2 years, we should be able to see a massive shift, because in this year and the coming year, we are implementing the pilots and the different phases of this RIMS rollout. Program 2, which is health product authorization. Again, this is an area where we facilitate a lot of our registration processes. We have successfully implemented a pilot for renewal. So for now, we had renewal of licenses, but we also have to do renewal of product registrations. We worked closely with applicants around that, and we managed to implement this. And this requirement is very much aligned with the WHO maturity level benchmarking. And as I've already indicated, in 2022-23, we managed to clear the backlog that we had inherited from the MCC. So this target was met, as well as all the variations that were linked to that backlog. Furthermore, we managed to achieve our target for what we call new chemical entities. So these are products that are registered for the first time in South Africa. And so here we're able to meet the target timeframe, and we actually exceeded it. The area where we're battling is with generics. We missed this target by 18%. We have implemented strategies which we are starting to see that they're yielding fruit. And so as we engage later on around the current financial year, you will see some of the improvements, but we continuously struggle with limited capacity. When we engage with other regulators, we actually salivate when we look at the size of their teams. I mean, the Egyptian Drug Authority, yes, their population is just about twice the size of South Africa, but they're sitting with a regulator of about 1,500 staff, and we're sitting with a regulator of about 300 staff. So we really are undercapacitated, even compared to some of our African counterparts. But that said, you know, we're able to, again, work very hard in that we managed to get this maturity level 3. Program 3, this is where we do inspections and look at the area of compliance, regulatory compliance. And this is an area, again, where we regulate, where the area of cannabis regulation sits. And so here we were able to do our first good pharmacovigilance inspections. We've appointed a number of inspectors. And as I said, this is one area that we are prioritizing as a regulator. With respect to cannabis, we've made some good progress, I'd like to believe. We were part this year of the PAKISA, the cannabis PAKISA, where there were very clear outcomes from that PAKISA. We've been able to act on the commitments that we have made at SAHPRA, and there's some submissions that will be going to the Minister of Health pertaining to that. In this PAKISA, we were also joined by the Department of Health and the Food Directorate within the Department of Health. So there is alignment from a health perspective on how to deal with the recommendations from the PAKISA. Leading up to the PAKISA, we were working very closely with the Project Management Office of the Presidency. Again, they made proposals to us specifically around revising the limits of THC and CBD, and that's what we've now will be submitting to the Minister of Health. And this will ensure that those who are operating with higher limits, however, not for medicinal purposes, they will submit their application to Department of Agriculture and not to SAHPRA. And then again, the Department of Agriculture Rural Development will also then be reporting to the International Narcotics Board together with SAHPRA. In this area around GMP and GWP licenses, we unfortunately missed our target. Again, we have limited resources for the number of applications that we receive. In terms of permits that we issue, we managed, again, we digitized this whole process at the beginning of 2022, and that seems to have assisted us a lot. The regulatory compliance investigations, we met our target. And as I say, this is an area that we work very closely with external stakeholders, such as the South African Police Services. Program 4, this is where we do our clinical and pharmaceutical evaluation. One of the areas that SAHPRA and the control lab is doing very well in is in our lot release functions. During COVID, we had other countries also rely on the decisions of SAHPRA and the control lab. And this is an area that's functioning very well, to a point where WHO benchmarked it as a level 4 function. We also this year managed to get support from the Africa CDC through funding some of the equipment that we require to expand the lab. We've seen during COVID, and we see with all these efforts around local manufacturing, that we will not have adequate capacity. And so we were successful in a grant proposal that we made to the Africa CDC, and we received the funding, and we had the DG come here in person to meet with us and congratulate us on this great outcome. So this remains to be a really well-functioning area within SAHPRA. In terms of Section 21, so this is the area wherein unregistered medicines are reviewed for access. We were able to meet our timeframes for this area. Clinical trials, I've alluded to this. We're really working hard with our teams and our committees to make sure that we meet the targets. The area that we're struggling, as I indicated, is around vigilance. We are undercapacitated in this area. So what we've done is we've approached various funders to see if we can get financial support to fill some of the roles. But this is not sustainable, right? You know, when we get funding for these, they typically end up being contract positions, but we know that this is an area that is important for the long term. And so ideally you want to have permanent appointments, and again, so you don't lose the staff. So we continuously make, you know, a plea to say, particularly for pharmacovigilance and regulatory compliance, we will need support from the government to ensure that we strengthen this area, because this is what is very patient-facing, public-facing, to ensure the safety of the products that are accessed in the market. From an awareness perspective, we've done well. We've had a number of webinars. We publish a number of articles, press releases, etc. On the lot release, as much as it's a well-functioning area, because it was the first time that we were measuring this KPI, there was elements within the target in terms of how we defined it in the TIDS that you know, may lead us to a point where we don't miss this target, but we've subsequently corrected this going forward. But it's not a target that I would worry too much about. I think it's more technicality than actually missing the target. Medical devices and radiation control. We've been with the team working hard to ensure that we clear. We had a bit of a backlog here of licenses that we managed to clear. It didn't take too long. It wasn't too many, but it was still in backlog. And so we managed to address that. We've been working very closely with the IIEA. They've had some training programs. We've participated in the country visits with the Department of Minerals and Energy, with the NNR, and we've seen some very good progress in here, and together with training of our staff members. So we will then continue to be part of this forum of nuclear regulatory bodies in Africa to ensure, again, alignment and harmonization, to ensure coordination, communication, and to ensure that we've got adequate capacity and that we continuously train our staff. So in this area, as I've said, the licensing, we managed to meet that target. On the medical devices, we didn't meet this target because we were still waiting for the publication of the regulations. And so while we wait for the regulations, we cannot publish guidelines because the guidelines are dependent on what on the finalized regulations. The area of radiation control, again, we've met all those targets. I'm not going to go into too much detail. And we have now finalized this very early in this year, Q1. There were some delays in finalizing the core regulation model with the NNR, but we've now making very good progress in that area. So just briefly from an HR perspective, I must say I'm very happy that as SAHPRA, we're quite a transformed organization. You will see that 66% of our employees are female, and these are professionals. They've got professional qualifications. And also, if you look just at the spread and the profile of our team, we have a good representation of African female, African male, colored female, colored male, So matters of employment equity are not a stress for us. As SAHPRA, what is a stress is that we have to increase our capacity. And during this period, we had no one that had declared disabilities. And so even as we recruit for those functions wherein we can accommodate these individuals, we are actively looking at that. I'm now going to hand over to the CFO to take us through the audit outcomes.
Thank you very much and good afternoon. The table indicated there just shows the audit outcomes or the audit opinions for the past 4 financial years, ending with the consecutive 2 unqualified audits. In terms of the material non-compliance areas identified by the AG, we're remaining with 2 relating to audit adjustments and also on revenue management. We were able to also clear the procurement and expenditure management material non-compliance that was an issue for us in the previous financial year, and for the first year, SAHPRA was able to report a 0 irregular expenditure balance. Next slide. In terms of our high-level audit action plans to try to address the material non-compliance areas, and also trying to push for a clean audit for the next financial year or the year thereafter, mainly relates to the accounting standards and how SAHPRA has presented some of its disclosure notes. So we need to do some additional steps there in terms of our internal reviews to ensure compliance. On the revenue side, our challenge there mainly relates to the collection of retention fees or license fees that are paid annually by applicants that have registered on our databases. So we have some detailed action plans and try to do a final collection process, thereafter trying to clear the databases by cancelling these products and licenses from our databases, and then to keep that updated on a monthly basis so that we do not raise revenue for products and licenses that are not applicable. The internal control deficiencies relate mainly to those 2 areas of non-compliance, basically also for performance information, to do detailed quarterly reviews or more in-depth reviews on a quarterly basis to make sure our accuracy and completeness is ready for year-end reporting. In terms of the records management area, number 2 there under internal control deficiencies, also the detailed reviews and supporting document verifications would assist with that. And then also with the monies owed to SAHPRA, the collection and cancellation process to make sure that we maintain our databases would assist in clearing that. If we can manage this, we should be well away to a clean audit in the near future. Next slide. There's an analysis of our irregular expenditure. So all the balances that we've previously reported was condoned by National Treasury. The AG did identify 1 additional transgression in this audit, but it didn't result in irregular expenditure being incurred in this financial year and will be addressed going forward in the new financial year, and we'll follow the condonation processes for that. The current controls that we've implemented appears to be effective, minor omissions here and there, but considering that we had 10 million rand in 21, shows that we've made some good progress there. We did have a additional fruitless and wasteful expenditure, unfortunately, during the 22-23 financial period relating to penalties and interest levied by SARS due to a system error in terms of our deductions and subsequent payment of that PAYE. The matter is currently under investigation and will follow the correct processes as outlined by the National Treasury. Next slide. From a finance perspective, if we look at our revenue generation compared to our grants, we can see a steady increase in our own revenue generation capacity. Basically, the growth relates to an increase in some of our outputs, as well as the impact of the 2020 gazetted fees that we feeling in the past 2 financial years. We basically increased from 101 million in the 2021 financial period and ended to 197 million in the 22-23 financial year. And we do utilize these funds for our digitization and capacity requirements that we have, although not yet enough to cover all the areas. We did generate quite a substantial amount of interest revenue. It's mainly because applicants pay in advance, and whilst we do the processes for the evaluations of those applications, we do invest that funds in the Corporation of Public Deposits, which is mandated by the National Treasury. Next slide. If you just have an analysis of our fees per function, the majority of our revenue do come from medicine evaluation and registrations and our retention fees, but it seemed to have stabilized basically in terms of basically a year-on-year increase of about 8%. So it looks like we've reached the revenue potential there in terms of our current capacity. We've seen some good growth in Program 3, which is our inspections, permits, and licenses, which saw a 34% increase there. Our unregistered medicines, a 12%. Thank you. Next slide. If we look at our statement, financial statement of performance, you can see a stabilized graph there for the past 2 years. And it is mainly due, in terms of our surplus that we have, is mainly due to our more than anticipated revenue generation that we had for the past 2 financial years. And our financial position looks good and we're quite strong with the 69.9 million accumulated surpluses in our statement of financial performance. And that's mainly due to the retention of our surpluses for the past 2 to 3 financial years. You'll also see in the statement of financial performance, the majority of our year-end liabilities do relate to income received in advance, which is an indicator of our future revenue potential as we recognize that revenue over stages when certain points of evaluation has been reached. Next slide. In terms of our external funding, historically, most of our funding externally funded funds related to the backlog project, which has ended now in, I think it was December 2022. So the funding also for that decreased a bit, but we still have some support from external funders such as MEPAD and Auditor, funding our strengthening safety monitoring systems for vaccines. We had some funding from CHAI, which related to the quality management system, which was around about 1.3 million. And then also the Foreign Commonwealth Development Office that assisted us with a customer relations system amounting to about 1.3 million rand. But Global Fund, in terms of our support going forward, also assisting a lot with some of our capacity issues. Thank you, CEO.
Thank you. So just to conclude, Chair, to say we were quite happy that we've been able to maintain the unqualified audit opinion, even during very tough times, and also being able to achieve the MR3 status, reflecting really just our alignment with global standards. Thank you very much. Stop sharing.
Thank you very much for the presentation, SAHPRA. I'm now the chairperson of the Portfolio Committee. The chair has assigned me to continue with the meeting. Honorable members, we have received the presentation from SAHPRA. I'm going to note hands for members to raise their questions. The first member, it's Honorable Clark. The second member, it's Honorable Adeline. The third one, Honorable Klaba. The fourth, Honorable Notnachel. Mahlengwa. Those are the hands on the platform. Or Honorable Harvard. Any other hands before we move? If none, I'm going to give Honorable Clark to start.
Thank you, Chairperson Gela. I'd like to ask the following questions. Firstly, I do want to make an emphasis on the AMA Treaty. And, we all believe that the AMA Treaty was a really good document and we all supported it. The only concern was that we wanted to know what South Africa's contributions would be towards that treaty. And that hasn't come out in this presentation today. And if any of your members could maybe confirm that. Then the following questions I'd like to ask is, what are the current personnel needs and how much budget would be needed to address this? Why can the personnel shortages not be addressed with the 22.5 million revenue surplus that you have? Why only 57% of generic medicine was finalized within 250 working days? And how long does it take to do the rest? And what are causing these delays? Because as we know, many medical aids these days won't pay for medicine unless they are generics. Then how will SAHPRA address the significant internal control deficiencies identified by the AGSA? And please explain the regression in performance from 72% to 63% in the financial year, and how will this be addressed? What are the measures in place to address staff turnover within the technical skills area? Why did the workplace skills not include relevant training? What measures are put in place to ensure training initiatives are relevant and of a set quality and standard? And then you also said you had a system problem in terms of penalties you had to pay in terms of your tax submissions, and that error you're busy working on to correct. Can I please also have the time frame that it will take to fix that error so you don't find yourself in the same situation in the next cycle of returns? Thank you.
Thank you, Acting Chair Geller. I'll pick up, just a note for you on your presentation. On your slide on Program 1, there is a typo. It talks about 1697 surplus. It should be 197 or it's 197 million rand surplus, not 1697, just for your noting. To follow on from Honourable Clark, I'm also concerned about the deferment of the ISO 9001 certification that has been pushed over to the next year. Could you please explain to me why that has happened? Because this certification is the ability to constantly deliver and provide products and services that meet customer and application statutory and regulatory requirements. Surely this would be fundamental to what you do. Following on from Honourable Clark's discussion on the generic medicines, it is quite a concern because, as we all know, medical aids are very, very sticky about what they will cover and what they won't cover, and that is a major concern. Turning to your staff turnover, is the salary scale the only barrier to attracting the top caliber of people to come and work at SAHPRA? Or have you identified any other challenges that you can share with us and what you are doing to manage that? Your high staff turnover in terms of skilled people, what strategy are you employing to address that? And what kind of litigation cases are you facing, if any? And if you are facing those cases, what are they, and in which provinces or in which areas do you find them in? And what is the number of those litigation cases and what severity? You said that there was one transgression this year in the financials in terms of irregular expenditure. What was it for, and what are you doing to address it? And your increase in fees, the inability to collect revenue, it seems to be a problem within the South African government as a whole, that there seems to be an aversion to collecting appropriate fees. What are you doing to address that? And how are you going to address it in the future? I'll leave it there. Thank you, Acting Chair.
Thank you, Chair. Chair, let's welcome the presentation as is done by SAHPRA. Chair, mine will be really I just have 2 questions, I think. Chair, it relates to what were the limitations of the tabled enterprise architecture tabled to the RAG committee? And what implication will this have on the digitization program? And what impact will this have on the efficiency and effectiveness of SAHPRA turnaround times? It's very key, we understand that. 2, Chair, has the entity recovered from the impact of COVID-19 budget adjustments? And what impact can further adjustments or implementation of cost containment have as an entity fail to meet its target of 80% generic medicine registered with performance of 57 and 22% of the new GWMP and GWP related licenses within 125 days? I think those will be my 2 questions, Chair, which I'm submitting to the collective. Thank you, Chair.
Thank you, Chair. Let me welcome the presentation. It was a very informative presentation. Mine, Acting Chair, is just a clarity-seeking question. In these days, there are children who die because they have eaten muffin or cakes with DACA or cannabis. What are the implications of that? Or are we going to continue to tell people that DACA or cannabis are poisons because 2 children will die because they have eaten that muffin which was made by DACA? Thank you.
Thank you, Acting Chair. I just have 1 question. Also welcome SAHPRA for the full detailed representation. What measures is the entity taking to improve its performance in the current financial year to address issues identified by the AG? Thank you.
Thank you, Chair. I've got 1 question, which is the following. Program 4 has a vacancy rate of 31.81%. What are the implications of this vacancy rate, and which functions are mainly vacant, and at what levels of the organogram? Thank you very much.
Thank you, Honorables. I'm going to allow Honorable Lydia to speak.
Thank you, Chair, for allowing me to speak. I only have 2 questions, Chair. The very first one, which is, what financial recovery plan exists to ensure the entity has a sustainable financial position to fund its complete staff establishment? The second question is, why does the entity's basis for non-attainment presume that those who are identified as top candidates, not other candidates, were competent to be offered the position? Thank you, Acting Chair.
Thank you, honorable members, for the questions. Before I hand over to SAHPRA, I'm going to first submit the questions from the portfolio chairperson, Dr. Jacobs. The first question from Dr. Jacobs is that the entity received an unqualified audit with findings due to material and misstatements in relation to the percentage of medicine variation, application backlogs, cleared and weaknesses of records keeping. What impact has the implementation of the audit action plan had, and which controls require a strengthening? Secondly, AG found that the management did not ensure appropriate review and monitoring of compliance with revenue and debt management policies, which led to an ineffective collection of revenue. And how much revenue would have been collected, and which appropriate steps were not taken? Those are the questions from the chairperson. Now I'm coming to my questions. The first one, what challenges does the entity have in attracting and retaining a superior talent at 65% instead of the 80% target? My second question, what impacted the entity from attaining an 80% percentage of new manufacturing practices and a good warehouse practice related licenses finalized within 125 days? My last question, skills development is a critical area of development which all state entities should prioritize, particularly in specialized sectors, which led to the 15% of a training blend initiatives. What interventions are required to ensure the workplace skills plan is optimally implemented? Those are the questions. If members can, the SAHPRA can respond to the members, I will hand over to Professor Helen and to me to respond, actually your team to respond on the question that are being asked by honorable members. Over to you.
Thank you, honorable member. Many of the questions are in response to the presentations, and some of them are really looking at the targets and require sort of operational answers. So I'm going to hand over to Dr. Sameti, and I think she in turn will ask the CFO to also answer some questions. If then there are additional comments that I want to make, I'll come in at the end, but I'll hand over to Dr. Sameti now. Thank you.
Thank you very much. And thank you, honorable members, for all these questions. They're certainly appreciated. And I'll tackle the non-financial ones and have the CFO tackle those. So in terms of the AMA Treaty, so how it works is that there would be the Conference of State Parties that will then determine how much each of the member states would contribute. So as we sit at the moment, there is no dollar amount, so to say, that has been communicated, because the Conference of State Parties still need to sit and determine this. And again, I think once we have signed and ratified the treaty, South Africa will have representation, and then we would get that information. However, I would still like to make a plea to say there will certainly be benefits for South Africa to sign and ratify the treaty. The impact it will have on this growing industry in the country that would export to the rest of Africa. I think if we're able to access the AMA mechanism, it would be beneficial. But also at the moment, they are selecting the AMA board. And with SAHPRA being one of the very strong regulators on the continent, they have indicated that they would like SAHPRA to have representation. But if we don't have that treaty signed and ratified, we therefore cannot participate in these processes. And so I do believe that there would be benefit for the country to participate in this platform. Also considering the role that our president, Honorable Cyril Ramaphosa, plays in some of these AU platforms, COVID-related ones, the continental agenda around local manufacturing. I think it is fitting for South Africa to sign and ratify the treaty. In terms of why generics are taking long, and I mean, if I look at our application, we sit largely with generics compared to new chemical entities. And one of the reasons was that we can't apply reliance to the extent that we would like to, because by the time these products are submitted to South Africa, there's been a lot of changes that when a decision has been made, say, by the European Medicine Agency or any other, that we can't rely on them because, in essence, their assessment of the product could be outdated because they would have changed a manufacturer, etc. The other thing is that we are undercapacitated. So when you look at our timeframes, even for new chemical entities, we're really stretching our team. And at the core of it is not being adequately capacitated. Yes, digitization will assist, but we do need to improve our current capacity. The reason why we had a reduction from 72 to 73 is some of the newer KPIs that we've included for that specific financial year. And one specific one is the lot release, which I indicated that it was just how we described this in our technical technical indicator descriptor. But we do, we will certainly do better in this year. In terms of staff turnover, I mean, when you look at the number, yes, it's high, but it's not out of the industry norm, right? And so some of the mechanisms is that salaries comes up a lot when we do our exit interviews. Some of the staff members, they indicate that, you know, the SAHPRA environment is a very demanding environment. They have to deliver a lot with the limited capacity that we have. So they're finding that they're really stretched and they would like to have a better work-life balance. And so, you know, hence we need to make sure that we've got adequate capacity. But those are some of the issues that have been raised. In terms of the workplace skills plan, we do believe that this year we'll do a lot better because I think we've put the right types of development areas or training programs within that plan. But also we have in the process of raising funding for us to bring in a training and development specialist. We're a knowledge-intensive entity, and we send our staff for a lot of training. And so we need to ensure that we've got someone who can coordinate that and ensure that we do derive benefits from sending all our teams from training. So within the HR function, if we're successful with raising this funding, we will have a resource, and we expect that that will help a lot with some of our training and workplace skills plan objectives. In terms of the ISO certificate, the reason we deferred it is because the quality management team was assisting us with the WHO benchmarking. But again, I'm very confident about us delivering on this year. We've already had our desktop audit by SABS. They were here, I think, about 3 weeks ago. They did a desktop analysis of our policies, processes, etc. And we will then have an outcome by end of the year. But you're absolutely right that it's an important measure, particularly for the nature of work that we do. ISO accreditation is quite important. So yeah, we did our self-assessment, and we met all the targeted kind of findings. We managed to address those, and we hope that we'll get a positive outcome. In terms of the offers that are rejected, a lot of it is really salary. We are attracting from an industry that pays much higher salaries than us, that pays much higher bonuses than us in the public sector. And so it is very difficult for us to match some of those offers. And it really is at the core of this. And we say top candidates because we really want to attract top candidates. We operate in a global sphere, wherein at a point we have our assessors being invited by WHO to assist with their assessment, and we really want to keep that up. But we also want to ensure that we attract people who can also, train others. And so we try, wherein we have a second candidate who's equally strong, we will make an offer to them. But there are instances where we would then rather run the process again. The litigation, I don't have the exact numbers, but I'm happy to do a report that we can share. We do report on this to the board, also on all these cases on a quarterly basis. So I'm happy to share our Q2 report, which we will be making to the board, but I don't have the numbers at hand. Some of the examples of the cases that we're still dealing with, there's one, a COVID-related one, wherein we authorized the Pfizer vaccine for the pediatric population, and that decision was challenged. And the reason for the challenge, they were saying that we're breaching the constitutional right of children. However, authorizing a product doesn't mean it's mandatory. And so, we're still in court for that. There was a question about the severity. As I've said, there's some of them that we've been successful in that we have stuck to our mandate and done what is within our mandate. But we're happy to give a detailed report at a later stage. On the enterprise architecture, again, it was an administrative matter wherein we couldn't get it to the board in time. And so that subsequently has been approved in Q1 of this year. As I've said, we've procured we've contracted a service provider to implement the regulatory information system for us on the back of having that enterprise architecture. So again, it was just a timing matter, which we will ensure that in future we don't see that. In terms of recovery from the adjustments that we experienced during COVID and any other, it remains to be challenging. Being a knowledge-intensive organization that we are, and also being an organization wherein, our biggest asset is our people, because we utilize the knowledge, their skills to review these dossiers and make decisions. Any cuts will impact our cost of employment, which says it impacts our training programs, it impacts our recruitment programs. So you will see that in the long term. And this is something we've seen in SAHPRA. We've kind of stagnated around this 300 mark in terms of our staff complement, and we should be sitting at 500. So we're not even growing. Since we started SAHPRA, we've been hovering around this because we just don't have adequate funding for us to grow quite significantly. So we haven't grown, which for me is a concern. Yet the number of applications are growing, but our even the current recruitment, we are addressing the turnover. People that have been here, we're replacing them. But if you look into it, actually, we're not growing the organization, and that's the impact of these budget cuts. On the matter of the cookies that were spiked, that were contained THC or CBD, I can't comment too much because, again, it's not a medicine. And I think I cannot speak with any level of authority just based on the fact that I've only heard it on the media. But the important thing around cannabis regulation is that all stakeholders need to do their part. And this is something that we've been saying as SAHPRA, that there must be a very clear national policy, a policy that would say then, you know, when we relax some of these requirements, which entity is then going to step in and ensure that matters of safety are addressed. You know, the Department of Social Development needs to be brought on board. There's justice that's looking at some of these matters. Agriculture, so it's a multi-stakeholder matter. And for us as SAHPRA, we focus a lot on those that are used for medicinal purposes, because that's what's within our mandate. The vacancy rate, it continues to be high, and I've indicated the reasons. It's really financial. We do try to ensure that we remain a going concern and we don't affect the financial viability of the organization. So we are very circumspect in terms of how we make decisions that will have a financial impact. And where we can't afford to fill roles, you know, it does pose us with these challenges where you have a very high vacancy rate. And that's what we're experiencing even with GWP and GMP, the areas of inspection. Yes, there's parts of it wherein you may find that we're ready to go for an audit, and then the applicant will tell you they're not ready, come back in 6 months. It throws us off a lot. So as we revise this target, we will keep some of those factors in mind. While I look at if there's anything else that I've missed, I'll hand over to the CFO to comment.
Thank you. In terms of the question relating to the utilization of surpluses, so SAHPRA as a Schedule 3A entity needs to request permission from Treasury to retain these surpluses. So it's difficult to commit a long-term appointment to funds that needs approval from National Treasury. But Treasury did assist us for this financial year. They did approve a budget deficit for us so that we can sort of utilize this retained earnings that we've built up over the years. But they do caution us to then rather look at contracted positions. So there's a bit of a difficult space to move into to utilize surpluses for long-term utilization or commitment as a employment position or employee. But what we also try to do with our surpluses is the retention thereof, also to fund the RIM system. I think we've reported previously we don't have funds for the RIM system. We were able then to accumulate this over the past 2 years so that we can implement this quite crucial system. So the move is more related to the digitization efforts for our surplus utilization. In terms of the number of positions, and my numbers are not updated, but as at 31 March, we had about 79 unfunded positions, and those are mostly technical staff, and the cost thereof is plus minus or just a little bit more than 80 million. And that's 80 million we don't have in the next financial year. We're also busy with our current recruitment plan, and there is quite a few vacancies that we're still trying to get filled during this financial year, and then obviously to fund it over the out years. And that's the main challenge in terms of our revenue growth growing with our cost of employment. The questions on internal control deficiencies, just on slide 37, where we flag the high-level control deficiencies and the high-level corrective measures are listed there. There was a question on the adjusted financial statements and performance information. Now we want to tackle that is with additional internal GRAP reviews, accounting standard reviews, that we need to check and see if it is aligned. And the specific issue that happened here is on one of our disclosure notes for financial instruments, we had additional information there that the AG flagged for the first time. It was there in previous years to remove it, and they saw that as a material adjustment to the financial statements. There were one on performance as well. The tough part, and it's sort of a comprehensive response on the whole revenue management non-compliance. So we did follow a collection process. Our challenge is that some of these applicants have no intention to stay longer, 5-year period, for example. Our main challenge is on medical devices, where they do apply probably for a tender, they don't get it, and they're not interested in continuing with that license, and they disappear. And the challenge is actually getting or contacting these specific applicants, because they will just ignore the efforts, the collection efforts that we have. But we are busy with a detailed action plan that we'll present to the audit committee to address this specific challenge. And the main highlights also captured on slide 37 is to go in and do another final attempt to try to collect. And if we can't get that, we need to follow a formal process of cancellation, which requires gazetting of these licenses, mostly licenses for medical devices, gazetting that we're going to cancel them due to non-payment or whatever other reason, and then we can officially remove them. But we are forced by legislation to raise this annually. So like a license fee, a TV license fee, we need to raise this and then try to collect this, and that's the main challenge. We're also thinking of very specific system enhancements, trying to upload these onto our accounting system where we're currently doing it manually. So it is a tough one and a tough task that's lying ahead of us, but we will try to tackle that before the financial year end and the audit for next year. There was also a question on that one specifically, how much was not collected. So on note 3 in the financial statements, it's about 6.6 million related to the license and retention fees. The others we're not too concerned about. That's listed in that breakdown of receivables, but that's where our main challenge lies. The other control deficiencies in terms of the reviews, I think, I've touched that, and that's basically the main response there. There was a question on the system problem for PAYE. So we did quite a thorough, detailed look into the system. It was very specific to the 2022 tax year. And the system that has operated sufficiently, so we don't foresee any continuation of this specific challenge. And for the 23 year, nor have we heard anything to date that it has an impact on the 23 tax year. So for us, that problem has been addressed specifically. The question on the one irregular transgression identified related to a procurement process we followed for borderline, for ports of entry, where we needed office accommodation, very specifically for border control officials. And the entity that we've engaged at that point in time was not tax compliant, and the legislation required us to make, if we do approval, they need to be compliant on date of approval. They have been subsequently compliant, but unfortunately, our internal checks missed that they weren't compliant on the date of award. So from that perspective, that was the transgression. But like I said, we will deal with it like we did with the other transgressions, and we'll try to clear that before financial year end. I've spoken about the inability to collect in terms of COVID-19 adjustments. So I think from the National Treasury's most recent cost containment communications and guidance, we have submitted a plan where we can do cuts. For example, we've done already a cancellation of one of our tenders, which related to communications and outreach of radio campaigns, which we thought might not be that critical in terms of trying to stay financially sustainable over the next financial year and trying to mitigate the cuts. And obviously our travel and all the other recommendations by National Treasury, we've set up plans, and obviously that would be carried over into the next financial year. There was a question on financial recovery plan to fund staff establishment. Like I've indicated, the unfunded vacancies are, the cost is just significant. We can't increase with 80 million per annum. So we do try our best, like I said, with the National Treasury deficit approvals. Not sure if it will happen in our current fiscal situation, but we do plan quite in detail, even if it's just 10 a year, and try to scrape some of the additional funds through full vacancies. But it's very difficult as well because we're hovering around 70% of our total budget is going to cost of employment. There is not much room in terms of our other expenditure areas to cover for cost of employment. The impact of the controls, like I've indicated, we have quite a detailed action plan that we'll present to RAG for Q2, and those will be tracked going forward. In terms of how much not collected, I've responded to that, and I think that is all the financial related questions. Thank you, Chair.
Thank you for the responses. I'm going to give Professor Helen for final words. We really appreciate, as a portfolio committee, for coming and present to us your BRRR, and we hope that you will correct issues that the AG raised, so that next year, when you come to the portfolio committee, we don't experience same challenges or problems that AG reported. I'm going to hand over to Professor Helen for final words.
Thank you very much, Honourable Gala, and to all the other honourable members who contributed. So I think these comments, just to reassure you, I think the board has also asked similar questions, and I could hear echoes of some of the questions from board members in the questions you asked as well. But I just want to say perhaps a few high-level things. First of all, and at the highest level, and as I mentioned at the beginning, because I'm at quite a high-level scientific meeting based here in Senegal, but it's a global meeting, but very focused on the African region. There's huge interest in the African region in local manufacturing, vaccine manufacturing, pharmaceutical manufacturing. And there's going to be, I can hear, just listening to the presentations and the comments, that this is going to be hugely competitive between countries. So one of the things that we have to ensure is that we do have a good regulatory authority, because nobody will want to manufacture in a country where the regulatory authority is weak. And this is why the WHO maturity level 3, it's one of the reasons why this is very important, because it's a global standard that signifies to the rest of the world, if we're talking about investment, that the standard is one of the highest in the region. And it's obviously very important, and noting that the question that came about the safety, although the muffins wouldn't fall under SAHPRA, but nonetheless, you heard the comments that we're worried about safety of health products generally, and we're worried that we don't have sufficient staff at the moment to do that. The regulator is critical to this for public health safety for all South Africans. So we agree with you that these things have to be fixed, but I guess a sort of a appeal to the committee is to think about, we all understand that the financial constraints, but it's very difficult to do something like pharmacovigilance if you simply don't have a budget for it. So I think that it would be important for the honourable members to think about how much you want to comment about these budget cuts yourselves. Because as you saw, we didn't comment on it, but we're looking for supplementary funds from third-party streams of funding because we simply don't have enough. The other thing just to note, and I would endorse what Dr. Samete said, is the African Medicines Agency is going to become hugely important. And if we're not there, the first part of what I said will also fall off. It's going to be hugely important. It's going to set regional standards, and it's going to allow much stronger regional reliance and exchange of information and collective evaluations. So if we're not in, we're out, and that's not good news for us. The third thing that we're thinking about, and we're having a strategic planning meeting next week of the board with the management for 2 days. And one of the things that has been discussed by the board, many of you mentioned generics. Now, Rechard talked about the fact that when we've gone back to some of these generics to see if we can get payments, because they've been on the books for a long time, some of them have never actually been brought to market. Now, there's a public health issue that we need to think about. You have mentioned, 2 colleagues here mentioned the medical aid industry and the need for generics, and we would totally agree with you. But it doesn't continue to be beneficial to have more and more and more, say, generic paracetamol. Once you hit, say, about 7 generics, that's what the public health data would suggest. You cease to lose the price advantage by going to have more and more and more and more generics. And some of these generics, many of the generics we're finding that were never really meant to be brought to market in South Africa, some possibly in the African region. But we need to have a more analytic approach to generics. And in some regulatory authorities, there's a limit on the numbers of generics because they simply are not of public health advantage. So what others we're considering, what we've looked at is whether as the numbers of generic applications go up, once you hit a point beyond which there's no public health benefit, then you can also use an incremental fee scale. Because what we're grappling with at the moment is the many generics that we have registered that simply haven't been brought to market. We need to understand better why that would be of a commercial benefit to the companies concerned. And overall, we're also looking at the legal framework for SAHPRA. Like all new pieces of legislation, once you start to use it, you say, aha, we didn't think about this, or we didn't think about that, and the minister's aware of this. So again, one of the issues we'll be discussing next week is where are the issues in our current legal framework that we would want to propose to the minister, and then obviously through himself to Parliament, that could be revised and have an improved legislative framework. I'll stop there, but Honourable Geller, thank you very much, and please thank Honourable Jacobs as well, and I hope that all is well with his family member. Thank you.
Thank you, Prof. Ellen. I'm happy that Dr. Dumi clarified the issue of Amatrit that was raised by Honorable Clark, and really we are looking forward that we can have Amatrit, we can be part of Amatrit as South Africa for medicines. And thank you very much for the good work that we are doing in terms of SAHPRA. But don't drop the ball. You were doing a very excellent work during a difficult time during COVID-19. And I hope really, as we have indicated now, that you will make sure that you address all the challenges that you are currently faced in terms of correcting what need to be corrected from AG's report. Thank you very much. We have come to the end of the portfolio committee meeting, but I want to make an announcement as I've been requested by the chair to remind honorable members that tomorrow meeting will be held from 9:30 to 7:30. The committee will be receiving a presentation from the Office of the Health Standard Compliance, the Office of the Health Ombuds, and also MRC and NHLS. So we must be prepared, honorable members. The link and presentation have been distributed already to yourselves, and we have come to the end of our first day meeting. Tomorrow will continue until the 13th of this month, which is Friday. I wish you all the best this afternoon. Go and rest and be ready for tomorrow. But also, let me take this opportunity to thank the administration led by Sisma Jalamba for the good work that you are doing to assist us as members. Thank you very much. The meeting stands adjourned.
Thank you very much.
Thank you, Acting Chair.
Thank you, Matemba. Goodbye.
Thank you, Lady.
Recording stopped.
Thank you.
Thank you, Acting Chair.
I'm now on load shedding.
Thank you. Bye.
Bye.
Bye.